Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
Why do we come? Because knowledge is power, and knowledge provides hope.
And this is a place of hope and healing, and that's why I like coming here.
People come to this conference, they're uncertain, and they walk out of here with hope.
This is my 5th time. I learn something every year.
That was my first conference.
This is my 4th.
I think this is my 6th, and I love it. It's part of my treatment plan.
I've come to quite a few of these PCRI conferences and enjoyed all of them.
I've been to probably 9 PCRI conferences. Every one there's something different, so I keep coming every year.
The key is to be able to go and even have direct, individual questions answered with such kindness and such patience by folks that are at the top of their field.
It surprised me how accurate and up-to-date all the physicians are.
And they are very warm, they're open, they're available, and they present scientific information in a way that's very easy to understand and also quite entertaining.
The way they keep it moving and engaging, I mean, this is not a dull conference. This is, I don't want to use the word entertaining. I mean, it is entertaining, but it keeps you focused, keeps you engaged, anxious to hear the next thing.
I would say you have to come here and experience it.
Excellent beyond description what this conference brings to our lives.
This meeting has singularly been able to propel forward many of the concepts that are changing the field throughout the world. So even though you guys think that you're just sitting there as participants or audience, just through your social networking, just by sharing ideas, just by changing referral patterns, other institutions are going, well, crap, you know, we better set up a PET scanner, or gee whiz, we better get into a more aggressive mindset about therapy. I like this meeting. I like talking to patients. I think patients get it much better than doctors. So for me, that's why I come and speak to you. And for me, the privilege is simply that some of you are doing better, all right? That's all I need.
Hi everyone, I'm Alex with the PCRI, and today we're excited to present our 2025 virtual prostate cancer patients and caregivers conference. Now this is footage from our in-person conference that we had back in September. Thank you so much to the hundreds of people who showed up. It was amazing meeting you in person, getting to hear your stories, and so much more. And we're excited because we will be having an in-person conference in 2026 in September. And if you would like to be part of that in-person event, you can find out more at pcri.org/2026 conference. Now, before I get started, I just wanted to have a short invocation from Pastor Tim Clark, and we'll be right back.
Hi, I'm Pastor Tim Clark from the Church on the Way in Los Angeles, California, and I've been given the honor to pray over this conference. So let's do that right now. God, we come before you and we recognize that you are the God of all healing and all wisdom. And we're really grateful that you've given humans the ability to understand how the human body works. The medical science really is a miracle, and that you today are going to be communicating through the speakers the realities of how we can align to your purposes for our bodies. I pray that people, wherever they're coming from, whatever situation they're in right now, would be blessed by the information given today, and that they would be able to go away and apply it to their lives. Lord, give everybody wisdom today as they seek to understand more. And it's in your name that we pray. Amen.
Thank you, Pastor Clark. Now, this conference was brought to us by some incredible sponsors who have made it free for all of you. We're going to have thousands of people all over the world viewing this. And if it wasn't for these sponsors, it wouldn't have been possible. So we'd like to thank Bayer, Pfizer, Astellas, Janssen, Dendreon, Novartis, Miradex, Blue Earth, Foundation Medicine, and AstraZeneca. We really appreciate that you took the time to get to know us, to partner with us as a nonprofit, and to support these prostate cancer patients all around the world. Now, we do have an introduction from our favorite moderator, Dr. Mark Moyad from the University of Michigan. He is the Jenkins Poe-Kempner Director of Complementary and Alternative Medicine for the Department of Urology at the University of Michigan, but he has done over 25 conferences with PCRI. He's worked with us for years. Now, we all see him on camera as he moderates and interviews physicians, but really he's helping us pick speakers. He's helping us develop content. He's helping us know the latest and greatest in prostate cancer and what we need to pay attention to. He is so intricate to our process and what we do, and it's amazing having him moderate another conference. So without further ado, here is his introduction.
I'm really excited to be here and welcome you. This year is a little different. How do I put this? Yesterday something happened that was extremely upsetting, so I'm not really fired up about this conference. I'm fired up about quelling or dispelling a rumor that's going around, and I'm worried it might turn viral. So how do I do this? You probably know the story. of this tech CEO who went to a Coldplay concert, and on the kiss cam, it showed them hugging, and it turns out he's married, and he got caught in the act of the affair. It went viral, and he had to resign. She was head of HR. She had to resign. Total turmoil, total chaos. And America and the world became absolutely obsessed with it. You know, forget about research and all these other things going on, like a PCRI. People's obsession was clicking on this video a million times, watching this happen. So I figured that the world got over this kind of stuff and we wouldn't have to deal with it anymore. So yesterday, I can tell you, bothers me. I went to a concert, an outdoor concert, and somebody, I don't know if someone here in the audience took this photo. Can you please show the next slide? This is very troublesome. And then they apparently, a couple other quick shots. Could Bobby show them the next one? I just like, and can you show them the next slide? All right, so I just want to tell you this is not what it seems like. Just a second. Not what it seems like. It's my mom. Just 1 second. Hi, Mom. I'm in the middle. No, I love you too. No, I'm not dating Mark Scholz. I'm not leaving Mia for Mark Scholz. It's not that there's anything wrong with that. You know, we work closely together. Sometimes I do find him attractive, but most of the time, no. So nothing is happening. It's just a silly, silly rumor. I'm fine. I'll be home soon. I'll be home Monday. Love you too. Anyway, so let's just not pass those photos around anymore. Let's not turn this into a viral thing, please. Okay, so let's start the conference. Now that I've gotten that out of the way, welcome. Here's our speakers in the order that they are. This is the largest, arguably, patient conference in the world. It's very, very exciting. I always combine this event, though, with another event. I first go to Alaska, and then I come up from Alaska to here. And I don't know who's done this, but I just finished my 29th year of giving a lecture at Providence Cancer Center in Alaska. Who goes to Alaska 29 years to give a talk? So I keep thinking this will be my last year. I'm getting old. I'm starting to feel it. But something happened in Alaska this year that was very strange. I always go for a run on a couple of paths near Anchorage, and it's always really interesting to see the wildlife and different things. And so when I was running, I looked out and I thought I saw something strange. And I took my camera out and I took a photo, and as you know, I don't get political at this conference at all. But I just thought, I don't think anyone has this photo, so can you show them the photo I took in Alaska? So, it's just strange. And they're like, oh, well, you know, Moyad's picking on the Republicans, and they don't know me. For 20 years, I picked on all sides, whatever is fair game, you know, but I do feel sorry for some of the politicians. I saw recently that, for example, Hillary Clinton is still dealing with people who are accusing her of having stolen things from the White House when her and Bill were finally exiting the White House. They're still saying, you know, where did you put that stuff that we can't find? And I'm just telling you, Bobby, can you show that? I don't think she's taken anything, actually. So let's welcome to the conference again. I'm kind of getting this. You know, part of what this conference is that a lot of times I do feel we get it right, but sometimes we get it wrong. So if you see in this next slide, you know, this wasn't that long ago, actually. And the next slide after that, you know, these were real advertisements, and we realized, well, wait, with more research, this is probably not the way to go. So over these next two slides, I can show you that life gets messy. And, you know, we need to clean things up. So if you show that one, we got to clean things up, and that's what this conference is all about overall. A couple other things I want to tell you, some notes out there. It's a self-promotion here. When the conference first started, we raised some money, and I did some things, different charities I work with. I've done some crazy things. The next slide is coming out of the water in San Francisco Bay after doing the Escape from Alcatraz triathlon. That's my roommate from medical school to the right there, Jim. And it was just amazing how many people came out and actually ran this race in order to raise money. And a quick story, if you've never seen the Escape from Alcatraz triathlon, this is going back 20 years ago when I did this, is essentially what they do right before you jump off the boat at Alcatraz, they write your age on the back of each ankle. So at the time, I'm 60 now, at the time it was like 40, so they write 4040, and I thought that is just an awesome tradition they've been doing for decades and decades. And you have all of these cancer patients there doing it, and so they write my age, I jump in, I swim on the shore, and finally at the very end, you bike over a lot of San Francisco hills, and then you run over a lot of San Francisco hills and in the sand. So I'm running there, I'm almost in last place. I'm running there with my roommate, and this person comes up and blows right by me. And I said to him, Jim, that person looks like my father. And I said, speed up. So I sped up, and I looked just to look behind the ankle, and it said 7474. This 74-year-old's blowing right by me. So I took a little bit of an ego hit. And we're only about 3 miles from the finish line. It's a true story. And this woman blows right by me. And I said, Jim, that woman looks like my grandmother. Speed up. So I sped up. 8383. And you know what I thought spiritually at that very moment? I thought that tradition of writing ages behind each ankle, that is the dumbest tradition I've ever heard in my life. So now what am I doing? I got talked into by Undo Medical Debt, which is the largest nonprofit group in the United States, to eliminate medical debt from people in poverty. You can't solicit. They just go into hospitals, they work with collection agencies, and they just simply wipe out debt. So whenever you hear that Los Angeles or Minnesota, we just heard in Michigan that 200,000 people had their debt wiped out, that's really not necessarily who's making the speech. It's Undo Medical Debt that's doing that. So they called me and said, we love that you've worked with us. We have a team of people running the New York City Marathon right now. We want you to be one of our poster boys to go run this marathon and raise money. And I said, well, it's going to be anonymous until I announce it. So I'm going to run the New York City Marathon on November 2nd to continue to raise money. But I did the dumbest thing. I said, by the way, what's the average age of the people on my team besides me? And it was like 29. So somehow I got talked into this silly race. So if you hear it, if you see it on the website, I always say now, give to PCRI if you can. But also if you see me on there, the anonymous MD running this marathon, feel free to donate also, all right? But at the end of the day, it's about the conference. We all want to live a long, high-quality life. Yeah, we want to live a long time. What I can't emphasize enough about this conference is we don't play lottery here and we don't play Vegas. And what I mean by that is, you ever go to Vegas and it says, look, Bob and Mary, they won $10,000 each, and they're all happy and everyone's excited in that advertising, but they don't advertise the 10,000 losers that day. They'll show you the 1 or 2 winners. And that to me reminds me of medical research and how you're going to hear from these speakers. They're going to tell you where the plethora, the probability exists, where the majority of the evidence. Sure, we make mistakes, but they know the majority of the evidence. And the majority of the evidence tends to take you to the answer, not 1 or 2 random moments like lottery, for example, or gambling. So that's an important thing to keep in mind overall. So this is my way of saying welcome to the conference. Make sure you pay attention like my dog's paying attention here. In the next slide, please do not fall asleep. We want to make sure. And most importantly, you're going to meet the experts afterward. When Dr. Heath, for example, finishes, she's going to go across to the room and answer questions. And you can do anything. You can take pictures. You can say hi. We just have one rule here. There's no photo bombing. Can you show them that, Bobby? No photo bombing allowed. So this is about looking forward. There's amazing things happening at this conference. There's amazing laughter. But this is a special place. I always say this is a place of love. This is a place of laughter. This is a place where we make connections and learn from speakers. It's really it's the one thing I really, really look forward to every single year with work overall. And laughter is a good thing. So once in a while, I will insert a slide. For example, this survey I took. What's the number one funniest thing heard from a patient during a digital rectal exam? I thought that would be interesting. So I took a survey of the urologists and oncologists, and one answer stood out from one patient. And can you show them what that answer is? Hey, doc, can you now please write a note to my wife confirming that my head is not up there? Here's my dog hugging monkey. That's important. And one more thing I'm going to say before we conclude and start with our first speaker, a couple more quick slides. This conference is dedicated to Dr. Snuffy Myers and his wife, Rose Myers. They were essentially a huge part of this conference. Now they're at home and retired. I love Dr. Myers because even when we were, at times he's serious. He had to deal with a lot of advanced prostate cancer in his career. And this was me presenting his shirt to him after he finished my Q&A. And I put a big picture of myself on the shirt. And this is how he is. He put the shirt on. And then let me show you the back of the shirt. It said, I survived Moyad's Q&A, so it's kind of cute. Welcome to the largest conference for patients in the world. I will forget to say this, but to the staff and the people that showed up, I thank you. Because if it's not for you, I'm already retired. This is the kind of thing that brings me back every year. The love in this room, the kindness in the room, it is a beautiful spiritual place.
Thank you, Dr. Moyad. Now I want to introduce our first speaker. Dr. Elizabeth Heath is the chair of the Department of Oncology at Mayo Clinic in Rochester. She used to work with Karmanos Medical Group, and she just made the move to Mayo in the last, I would say, year and a half. But she is an incredible doctor, and the reason she is because she truly cares about patients. She's also a great educator, and she's good at explaining the situations when it comes to advanced prostate cancer. And today she's going to be talking in 2025, what are the latest advancements in advanced prostate cancer, and how are we seeing these treatments be layered on top of each other so that you can have a longer survival effect. So without further ado, here is Dr. Elizabeth Heath.
I want to bring up Dr. Heath. I'm not going to say much. I've known her for about 30 years. My dad, who passed many years ago, said she was one of the favorite doctors that she had ever met and learned from when she lectured. And the amazing thing now about Dr. Heath is, you might not know this, last year she worked in Michigan. And then suddenly at this conference, she accepted to be the new chair of oncology at Mayo Clinic in Rochester. So she's a big wig now. She doesn't talk to me anymore. She thinks she's better than everybody else. But the real reality is she's a subspecialist. She sees prostate cancer. She does the clinical trials. Her name's on almost all the clinical trials, all the major papers. She's what we call a triple threat. So she does research, she also sees patients, and she's teaching the next generation of doctors. And I'm so honored that she always kicks off to be our first speaker here. So Dr. Heath, come on up. Thank you so much for being here.
I'm not sure how to top that at all. How do you move forward after that beautiful human right there? Another round of applause for Dr. Moyad. Thank you all for just being here today. This is, and I will say it again to Dr. Moyad, this is actually the premier meeting for all of us to connect and really talk together about what's new. I know many of you follow along as well virtually, and the changes that have happened actually require many more meetings than what used to happen in the old days, which is once a year we got together and shared, and usually not with patients or families or caregivers. So what I'm hoping to do is to run through what is new in advanced prostate cancer. Many of you have actually asked me, whether I was in Detroit or at Mayo Clinic, sometimes what they like is that my slides don't change too much, because it gets really overwhelming when you're trying to follow a thread of information that's happened. So I'll keep some of the things the same, but also show what's new since last year. Because for some of our return attendees, that's important. For some of the new folks joining us, it's also to understand what that landscape looks like. So I start with this slide to kind of do a level set. I'm just impressed at your lineup for this meeting. You have literally the world's experts to talk about everything from local therapy to clinical trials to all sorts of what's new. We're talking about prostate cancer in September because this is the month that we talk about prostate cancer awareness. One day I'd like to stand up at this stage, and I'm sure my counterparts would agree, where we could say prostate cancer is no longer an issue. But we're not seeing that, and if anything, as you see the death numbers, and compared to last year, they're a little bit higher, it's because we're starting to see from the lack of screening that occurred a decade or 15 years ago catch up to us. So we're seeing more advanced prostate cancer. I'm a medical oncologist, and when I see folks coming in with high PSAs and sort of, 3-year back pains or difficulty urinating and not really having a discussion about a rectal exam and or a PSA check, that's really sad to me. I think it's sad to all of you when all of a sudden you say, wait, I could have had a conversation, I should have had a conversation. Maybe I can pass that forward. So action item 1, just from this first slide, talk about what's happening. Because when you tell your neighbor or your family members or just friends, they may also want to hear from you that it's okay to ask about whether prostate cancer screening is important, whether this is appropriate. Because when found early, and most folks are, it's highly curable and treatable. So what we hope to see is getting that conversation started so early that I become obsolete. That would be lovely. That would be really, really lovely. Because once you get to the metastatic advanced stage, what we are learning nowadays is that it's not just the one-size-fits-all kind of treatment. And if anything, in a good way, there's a lot of different options that's occurring now. But that makes it really hard to articulate and share with you when we're seeing you for the first time. Oh, here's a whole menu of things we can do. And you're like, I think you just need to start from the beginning. And it's a lot of information. So kudos to all of you for taking this time to really learn at least some of the words that we're saying. Because when 1 in 8 men in the United States get prostate cancer, this is a conversation you're going to hear at some point. Doesn't matter if you're at the Thanksgiving dinner table, at a neighborhood party, this is going to pop up. So what do we know? We know that in 6 out of 10 men, you're gonna get prostate cancer over the age of 65. So some of those conversations that we're having also may revolve around a higher risk group in African American men. And having those discussions about family history. Thanksgiving tends to be the time we encourage people to talk about your family history. And this becomes more and more important in prostate cancer because things that affect us in the advanced setting really hinge nowadays in knowing not just your family history, but the impact of that for your next generation. So if you have a dad or a brother that had or has prostate cancer, that doubles your own risk for developing prostate cancer. And when you're thinking about that, your mind right now is thinking, oh gosh, who else do I need to talk to in my family? The risk is actually higher for a brother than it is for a dad. But the good news in all of this, and I always say, look at that last bullet, 3.5 million men are survivors. That includes all of you, so a round of applause for all of us today. Yeah. Fantastic. It's important because that is part of the journey. Because this model here, which we show over and over again, and despite multiple promises that we're going to update this still holds, which means that it is a journey. Some of you are right at the beginning, at the clinically localized space. You just got told recently you have prostate cancer. That's several of you in this audience. There are folks that have had treatment, whatever that treatment is, and maybe you're worried that your PSA is starting to tick up again. Do I need to do something about that? And then there are folks in here in the green boxes, which is you've been on hormone therapy and you're kind of worried that things are advancing or you're presented that way. What's next? So this is a wide range. And when you talk to your neighbors and your friends here in this conference, recognize everyone's here at a different point in their journey and that the questions will reflect that. So I just want to encourage you again to interact as best you can. The way we think about it, and this is not anything you have to know, what we think about is, well, why does medical oncology even have to worry about what's happening in clinically localized disease? Why? Because when you look at this group, if you are defined as a high risk or very high risk localized prostate cancer, the conversation of having a hormone drug is already part of the picture if you're considering radiation therapy. And I'll see a lot of you in my own clinic where you're stunned. You say, I don't understand. You're going to take my testosterone away. Why? And now we're adding pills to this story. So it's really important to know that we're going earlier and earlier in your journey to try to get at this cancer so we can control it as best we can. I am impressed at, I guess, my own self for having this slide with the boxes. Many of you have seen me say, you know, I go back to the slide with the boxes because it's color-coded and it's easy for me to see the entire landscape of what is approved in prostate cancer right now, today in 2025. So the yellows are the chemos. The purple is a type of immunotherapy. The greens are what we call androgen receptor pathway inhibitors, or sometimes we call them ARPs. It's the new lingo, so you guys are now caught up. Radium is a type of treatment that is also a radiation, a fancier type of radiation. Relugolix is a new type of pill for hormone suppression. Lutetium-177 is a theranostic, and all those in red are what we call PARP inhibitors. So it's easy to see the whole swath. We're not going to talk about every single one, and I'm not going to show you 1,000 curves. I just want to hit some of the highlights so that you become familiar with the language. Why? Because when we start spouting off this, it not only feels like you're in a biology 101 class, there's a quiz at the end that you're not going to pass. That's even worse. So we don't want that for any of us. But compared to last year, what's new? Hey, Dr. Heath, there's no new boxes. There's no new boxes from last year. Well, but there's always something new. Now, the boxes don't all come barreling in, but there is always forward motion. So what's one? One of those ARPs has an expanded indication. Now you can give it earlier in the hormone-sensitive state without chemotherapy. With enzalutamide, in partnership with one of those red box drugs, the PARPs, it actually did not get approved for all comers with prostate cancer. So it's actually important to know what didn't happen. Number 3, apalutamide, another ARP in there, actually had a generic version. We don't often talk about generics. We often talk about how expensive these drugs are. But at some point, they do become generic and more accessible to everyone. We are coming from all different states, from all different parts of the United States and beyond. Everyone's access to all these drugs are different. So when we have an approval like that, it's important for all of us to know. There is a new type of PET scan, PSMA, not the PET scan itself, but another tracer that was approved, known as Gozellix. So this is important because it expands, again, the different types of tracers accessible to you. There are many people sitting around this room that don't have access to PET scans, which sounds phenomenal. You said that's impossible. Actually, that's very possible. I practice in a rural community, so not every person next to a hospital can get a PSMA PET scan. Important, why is this one important? This has a longer half-life, which means that you can have this 6 hours away and get it to you so that you can actually get the PET scan near your house as opposed to you traveling somewhere far away. And then an expanded indication in March to include, again, we'll talk about that for Pluvicto, which is getting it earlier in the stage. So whether you have an extra box or not, you certainly have advancements every year. And that's why you guys come to this conference, because then you know what they are. We're still on the ARP train, all about the androgen pathway, so make no mistake about it. One of the things that we are doing, and not just in everyday practice, but in drug development, we're still targeting that androgen receptor, which means somewhere in there, we are affecting, most of the time, your testosterone. So talking about these different side effects, I'm sure many of you can identify any, some, or maybe all of the side effects that have occurred to you. My plea here is tell your doc that this is happening. Don't keep it all inside, because there are ways that we can help to improve your quality of life. There are newer medications, there are newer strategies, there are things that one can do. So just be mindful of that. There we go. This is not for you to know, but to recognize all those things that populate the boxes come with data. So the data that we cite, and this is the most recent, really shows that there's a survival benefit. So a lot of times we're up there with our science and we go, hey, look at this, it's cool, boy, I sound really smart. At the end of it, hey, Dr. Heath, do I live longer if I add this medicine on board? And the answer is yes, you do. Shouldn't that be the main goal? Of course, but of course, done well, meaning we can't make the medicine worse than what the cancer is doing to a person. And that sometimes gets overlooked. I also want to say that we talk about chemo, so again, the first 3 boxes, like it's, it's a taboo thing, but it is something in our toolkit. These are standard chemotherapy side effects that are related to those drugs that I mentioned to you before. But that's not where we should focus. The question is, who should get selected? Should you get an injection and an ARPI, so injection and a pill, or should you get an injection, a pill, and some chemo? And that's the number one question I get for men who are newly diagnosed with metastatic disease. And the answer is there's a lot of reasons why we recommend what we recommend. You may look identical to your neighbor, but have different comorbidities. You might have a diabetic patient and you might have a hypertensive patient. You might have access issues. You might have the world's best insurance. No 2 men with prostate cancer is the same. And that is an important thing. What do I personally use other than these selection factors? I could tell you, and I'm so sorry, I think I'm struggling with the thing here, is that there are actually tools that we use to determine whether doing chemotherapy is the right thing for you. And you're gonna say, well, why is that? Because I'm used to working with a lot of engineers, and you know what we want? We want hard data to know if something is helpful, harmful, as opposed to the gut feeling. Not to take away the gut feeling, because gut feeling means experience. But let's say in a hypothetical patient, you're 74 years old, you're newly diagnosed, you have a little bit of hypertension, you're mildly anemic, you got some balance issues, so you're a little worried sometimes about not knowing where that next bench is gonna be and your walk, but everything else is looking great. You look on paper like you're a spectacular candidate for chemo with the ARPI and the shot, and we're all good. But if we're going to actually, you guys might have to help me with actually moving the slide because the clicker isn't super responsive. Oh, there we go. Right here, what might be helpful here is to show, this is one of the tools we use called the CARG-TT tool. And so I'm gonna run this patient with, so he's male, yes, okay. Age greater than 72, he's a 74-year-old man. He's going to have genitourinary cancer, that's what fits for prostate cancer, standard dose chemotherapy, we only give 1 drug at a time, but you're a little anemic, so his hemoglobin's at 10.5. Going on the right side, normal kidney function, hears very well, but he's fallen a couple of times. So what do you mean? Well, the balance was a little off, I kind of fell, and then 3 months ago, I kind of tripped, I don't know, maybe some of my I fell anyways. But I don't need any help walking, I don't need any help with taking medicines, and I'm pretty active. But if I put all of those numbers together, you can see when I do this actual scale that this person is at a high risk of having a grade 3 toxicity, meaning we might run into some real trouble with this chemotherapy. And you're thinking, how is that possible? Because there are studies that have done to back up this table that shows, you know what? We're not gonna just blindly say, hey, this is gonna happen to you. We're actually gonna use some tools to get us to a better place. So this person might actually be just fine to do an injection as well as an ARPI. So I hope that's helpful in terms of sort of opening up the back room to say, how are you guys making these decisions? Because at the end of the day, more than an injection in this scenario is the standard of care. And I keep saying it again and again because 5 years ago, that message wasn't there. But because of conferences like this, that message is happening. So look at this study. This was just looking at 24,000 patients in a health system called Flatiron. Nowadays, 77% of men are getting their treatment intensified. That means instead of just the shot, you're also getting either the pill and or the chemo. So conferences like this, all of us talking about it helps, because we didn't do this. The number of men not getting life-prolonging therapy was at 80%. A total miss. We're doing better. So see, there is a reason why we're all here, and it's to really make sure that we're getting to what is on these boxes. Hey, Dr. Heath, how do we get the red boxes to be applicable? How do we know if we should have that as part of our treatment menu? So here's the latest guidelines. Those PARPs are for folks who have an actual genetic mutation. So you're gonna say, well, how do I know if I have one of those? That's exactly why you're all here. And I know you have a more in-depth session on this, is the entire world of prostate cancer has moved on to include molecular testing. So this is not just hormones. Oh no, chemo doesn't work. We moved on from that. So if you take away anything, remember this slide. If you have advanced prostate cancer, you need what we call germline testing. All right, we're all gonna say it together. Germline testing. That means we're gonna look at the inherited panel. What is your DNA from your mom, your dad, and what makes you you? Why is that important? Because those 4 boxes that exist right now, you don't even know if you're eligible for them if you don't check. Now that is a miss, a total miss. So these are all things that will be helpful when you ask your doctor, is this possible? And we're not gonna go through the Bio 101 lecture other than, why does this work? Because it knows how to kill those prostate cancer cells. And it's really important because these are the 4 that are approved now. These are the red ones. I don't know how they turn blue, but they're supposed to be red boxes. But they're all approved. Most now in combination with an ARPI. So not just alone, but with another agent. Why is this important? Because if you sometimes don't even get this discussed in your visit, you can be your own advocate and say, excuse me, what about the pills in the red boxes? Do I qualify? Does my father qualify? Does my granddad qualify? Are there side effects? You bet. There are always side effects, but manageable, treatable, doable. How are we doing on testing? Just like did the message go out with intensification? How are we doing on testing? Look at the bottom bullet. 62% of men are not getting tested. Now it says somatic testing. You said, what's that? She said germline. Germline is what you got from parents. Somatic is what the cancer is doing. So we don't have enough time for me to go in depth other than that's more testing. So you can also qualify for things in the red box if your cancer has that mutation. Really important to know though that that message is not out yet. So that will be the next sort of bar. What if you can't have any insurance coverage? The Promise Registry is still open. You can still go on Prostate Cancer Promise and get a kit for yourself if you worry about your insurance not approving it. And they will mail you a kit, and you could do your own cheek swab and check yourself. Okay, so that's still open. Moving on quickly, for immunotherapy, there's only one immunotherapy that everybody sort of, what about this drug? What about this drug? In 3% of cases, we look in people who have been molecularly tested for a status known as MSI, or microsatellite instability. And what that means is a drug known as pembrolizumab, but all of you know it better as Keytruda, because they do a lot of commercials, and it's approved for 26 other cancers to work with your immune system. In prostate cancer, there are 3% of you that will test positive for this. It is often missed. So a lot of people will say, that's it, I have no more treatment, but they've never been tested. This is a miss if you don't test. There's no other way for you to know. So super important. The other one is known as Sipuleucel T or Provenge. It's still around, just not as heavily used as it's been in the past. For men who are newly diagnosed in the castrate-resistant, meaning you've been on shots or shots and pills, and now the cancer's starting to take off, this is still available and is still FDA approved. So that still warrants its spots in the, but just like most immunotherapy, when you're messing around with the immune system, you could have these types of side effects of chills and fevers. Very manageable, very time limited, usually not a big issue. The other medicine known as radium is also around. This has now been around for a long time. Raise your hands if you know Marie Curie. Yes, because we've seen movies. She's talked about having the Nobel Prize, 2 of them. That's the drug that she discovered, radium. So there was that movie, I think, known as the Radium Girls. Why is that important? Because it's actually a drug to treat prostate cancer now. So people are still very much into the theranostic space. This is still a very much ready to go, available treatment for men with bone-only resistant cancer. Bone only is the catch, but still there. So again, oh no, my doctor says I have nothing left in my toolkit. This is still part of the toolkit. These are some of the side effects. And we are perpetually going to be worried about your blood counts. Unbelievably worried about your blood counts because we are now keeping everyone longer alive. But we're doing a lot of things to you. So we have to be really careful on the sequencing. What do you do first? What do you do second? Those are conversations that your key opinion leaders and experts are having all the time. This should be first, this should be first. So you might get a little bit of that. And why is that? Because this study that I just cited was maybe 12, 15 years ago. And so how do you integrate this study with newer studies that are just getting published in 2025? And that's the difficulty we all have, because everyone will be able to spit out one of these things and go, oh, look at this. I've got survival curves. Oh, look, I have long-term data. Okay, but I'm coming into the story in 2025. What's for me? So when you have conversations, it isn't what's on the menu. How is the menu applicable to me? And how are those side effects being integrated? You all have heard about PSMA. It's really important to know that has taken up a lot of conversation, I think, both science-wise as well as these types of meetings. Oops, I think we want to go back just one. I want to highlight that the way you know if you're eligible is you need testing. So I'm not sure if somebody can, it's probably me. There we go. These are 5 agents as your PET tracers to check your PSMA. So one of the tricks would be, oh no, my insurance denied a particular one that my doctor ordered. You can be specific and say, did you order Pylarify? Did you order Locomets? Did you order Posluma? Because depending on your insurance plan, they may say yes to one and no to the other. So we've had that happen already. We go back and say, what will you approve? With those indications down below. Suspected metastases, who are candidates for initial therapy, suspected recurrence based on your PSA. So you are now empowered to ask. All of this with Pluvicto, which is one of the medicines that you are all very familiar with, is from this study. And as we think about where is this field going, it is taking off like a hot rocket. It is not just about lutetium-177. There are many other molecules now being developed to target PSMA and to also target nearby offending areas using this strategy. So is this important? You bet, because clinical trials will depend on what did you get before you showed up for the trial. That is the #1 reason someone is actually not eligible. Oh, you can't get this because you've had that. So important to know for yourself what that looks like. So in this trial, people live longer. I want to be careful to say people live longer, but no one is cured. So there is this sense where it's like, oh, I got this medicine, so I'm going to be fine. Nope, it's another one of the boxes. It is going to be very helpful, but no one is cured. That means we're still on this journey. We still need a game plan. We still need a strategy. I just want to make sure that that is really important for you to know, because as we're thinking about how this particular drug area is going, it is amazing that the effort now is to move it closer and closer to the local space. So this is for folks who are metastatic castrate resistant, meaning you've been on treatment, and in this trial with an RP, one of those pills, and chemo. And the advancements, again, is recognizing how do we deal with some of the side effects. I know dry mouth drives some of my patients nuts. There's ways around that. But anemia and bone marrow decline is one of the big ones. So we have to be really careful and not just sort of giving you the treatment without making sure you're doing okay. If you're not doing okay, speak up. Say, excuse me, I'm not sure if I'm doing so great. Because people get focused on it. I show up every 6 weeks, you're going to give me this medicine. You might have to delay it to every 8 weeks and it's still okay. So just be really mindful to advocate for yourself. And so that's for people who've had pills and a chemo. This trial is not just for people with pills. So, well, I've had the pills, can I get the medicine now? And the answer is yes, you can, because there's a survival benefit there as well. So in one of those updates for 25, this is the most significant update. You do not need to have had chemo to now get Pluvicto. That is a huge advancement, and it has shown all of the same perks and benefits and side effects as we've seen in those who have had chemo. So really, really important, because with this FDA expansion, you can advocate for yourself, because maybe this message isn't exactly all out there. So now you know, if someone says to you and you think, wow, in this 25, do the physicians really not know? If you don't specialize and think about prostate cancer like I do all day, every day, these kinds of little updates, it's just a, oop, March 28th, newsflash, we have an approval update. Okay, if you are in a really big practice, there are many approval updates, which is great. You now can be the advocates for yourselves or for your loved ones. What about Pluvicto now, as opposed to after failing chemo? Right? So everyone's got that. Now, you're going to say, well, what else is happening here? Do we have other trials? I heard there were many, many trials post-1 RP. What if we get another theranostic, which is what this drug kind of class is known as? And this was a trial known as the SPLASH trial. And it was ongoing and accruing like crazy. But just like in everything we do in science, it's not always a home run. Now, in 2023, and I shared this with you last year, it's looking pretty good. There was an advantage for what we call progression-free survival. We got to wait for more time to pass. But this was looking like, wow, this is going to look just like the other medicine. But many of you know, not every trial ends up the same. So what was the update in May of just this year? It reached 100% of pre-specified overall status or survival events. And what happened? What happened was, it wasn't the home run. The way the trial was designed, slightly different than the other trial, but the bottom line is, when the company, last line says, does not plan to pursue or further invest in this asset, that means this particular line of inquiry is complete. So you have a drug that worked, you have a drug that didn't. Same class. Are we surprised? No. Drugs will come and drugs will go, all depending on how you design the study. And we will be picking at this for years to come. Here's another trial, Eclipse. Last year, there's this endpoint saying that, yep, it's looking good. We saw some benefit. Okay, we will wait and see what is the final. There's no new updates for that. For Pluvicto, it's now moved on to even earlier in that castrate-sensitive space. And this trial, PSMA Edition, is waiting for its final readout. It has finished accruing, and maybe even some of you in the audience has participated. So really important. But in just June, I mean, right out off the press, it's met its endpoint. So what does that mean? We started here after you've had an injection, pills, and chemo. And now today, in 2025, we can get it with pills and an injection. No chemo needed. This result just said, you know what? For you newly diagnosed folks, maybe we give it to you right now, and we don't have to wait till you turn resistant. That is going to be a big game changer for all of us. I'm not sure we know the right answer, because we have to make sure that we know what to do, especially in an evolving landscape in this world of theranostics. What about another type of payload instead of lutetium? Here's actinium-225. Raise your hands if you've heard of actinium-225. Right, not too many of you. Why is this hot off the press? Because now we're getting fancy science. We have here lutetium-177, known as a beta particle emitter. Actinium-225 is an alpha particle emitter. They have differences in how they kill the cancer cells. There are trials ongoing now to evaluate actinium. If you've had Pluvicto, you might be eligible. There's now trials to combine the two. And this is my last slide and my usual plug every time I have the stage time, which is think about a clinical trial. None of those advancements in those boxes could have happened if your peers and or yourselves in this room did not participate. I just checked on clinicaltrials.gov. Open and accruing prostate cancer trials, we are at 1,186 today. That's a big number. And those are treatment, big number. What's up and coming? Dr. Moyad's gonna ask me this question. All the trials are available. Again, back to that slide with androgen receptors. It's still all about the androgen receptors. How do we continue to kill it? Protacs are another modality where we try to kill that androgen receptor. Molecular testing might discover things in the breast cancer gene family. It might uncover different things. And another target would be P10. So that is already near completion, and we should have some readout here very soon on what to do. AKT inhibitor already approved for breast cancer, but not for prostate just yet. Immunotherapy has now snuck back into the world of prostate cancer. We were the first with Provenge, and then we sort of faded into the background because prostate cancer has traditionally been known as a cold tumor. Now we have newer ways to target this, known as cellular therapy. These are CAR-Ts, bispecifics, TILs, all probably quite foreign words to all of you, all on studies to modulate your immune system. So I will stop now and turn the floor back to Dr. Moyad. I just want to thank everyone for your participation today and give me some airtime, and it's really a pleasure to be back. So thank you very much.
Thank you. Thank you. Thanks. I want to do 15 minutes with you because I can't let you leave without doing Q&A. That's not fair. No one escapes the Moyad Q&A.
It's the Moyad Q&A.
Let's go to slide 1. You're chair of oncology at Mayo. Where's the crown? Where's the big fur coat? This is your photo at Mayo. Any comment before we move?
Absolutely not.
All right, we'll work on that.
You.
I'll work on that with you. You need an agent. Next slide. 2 things make me wacky talking to oncologists. They use the word advanced metastatic. What does that actually mean? And when do I want to see someone like you? If I talk to someone, for example, one day they'll say, oh, you don't have to see a medical oncologist till you become really advanced metastatic bone, things like that. Other people say right when you're diagnosed. What's your answer to these 2 thoughts?
You could see us anytime. You can see us anytime. Thank you. One clap. No, you can see us anytime. Sometimes what we're helpful when you're just diagnosed isn't to weigh in as a medical oncologist, but to be that impartial third person to say, my doctor really wants me to have surgery. My doctor really wants me to have radiation. What say you? And most of the time, the medical oncologists are not that involved. The second group early on is the high risk, very high risk. You saw the way folks are sort of put in different buckets. It's important to know us then. That's not metastatic.
Yeah.
That's not metastatic. That's just high risk.
Anything you want to comment on subspecialization? Meaning to the audience, if you go to one part of the country and you want to go see an oncologist early, they'll say, hey, no problem, but that person's treating 10 different types of cancer. Do you really want to focus on someone that's primarily or only doing prostate as a subspecialization? How do you feel like that? I've never asked you that question.
You can have it all. So I'm being realistic that not all of us have access to a prostate specialist per se, but you are somewhere located nearby a National Cancer Institute Cancer Center, somewhere. Even if it's a one-time consult to talk to a prostate expert in that center, it's worth it. Just to get the bigger view, just to get the newer view. As I mentioned before, how many of these little updates that don't change the boxes necessarily, but it changes the access to you? It happens all the time. So if you treat so many different cancers, these alerts are coming at you all day, every day. It's a lot to keep up. It's not anybody's fault. It's just medicine has gotten so big, so large, no amount of artificial intelligence tool is going to get us there. So you have to advocate for yourself. Right now, unless something drastic changes, every state has a National Cancer Institute center in their state. Even for a one-time visit, it's worth it.
These are guidelines from Canada. So I give talks in Canada when I travel. We have them in America. You know about guidelines. It's supposed to guide us as to how to treat side effects. I thought that was interesting. They published these guidelines from Canada, and I know you can't read the fine print, but for almost every single side effect of androgen deprivation therapy, it says exercise therapy. I don't hear about that, but it's in the guidelines. Every single thing, bone health, cardiovascular, it's going to be added to cognitive. Do you have any comment on that? Are you responsible for the lack of people understanding about this? What's with you oncologists? Why don't you get the word out about this?
Well, there's two things. Guidelines, FYI, don't control them, but they do become a reference tool, so it needs to be up there. And what happens with exercise and mental health and everything else, it goes into a bucket known as integrative. And many, many centers don't have that. So you're sort of, quote unquote, on your own, or you're at one of these events and you go, oh, you know what I learned? What about this? What about that? So number one, the breast cancer family of researchers and doctors, they've already figured it out. It's on their guidelines. So if you look at breast cancer, you see that exercise is already there. The prostate group just needs to catch up. So we're trying very hard. We're catching up much better in the last 15 years. That needs to be there as well.
It would be interesting with someone with a lot of power. Say a chairperson at Mayo could possibly push this a little more.
Duly noted.
Just thinking out loud, not necessarily referring to you, a chairperson at Mayo. This, I thought, should have received more attention, and maybe it did, but in my world it didn't receive enough. Metformin, a drug that costs, could be over the counter actually. It's been the #1 drug utilized to prevent prediabetes from becoming diabetics. Also, it's the #1 drug used in diabetes for type 2 diabetics. It costs maybe a penny a day. It's natural. It came from the French lilac. They put it in a phase 3 trial called Stampede. This was just published, and it said it reduced many of the side effects, some of the side effects of ADT, and it could have possibly had an anti-cancer effect, but they're going to have to look at that in certain patients. But the bottom line is it helped with a lot of side effects of ADT, costs a penny a day. What did you think of this study?
Well, two things. I think that I love good data, and I think what they're saying is true. However, I don't think metformin is as benign as one makes it out to be. I think there are a lot of patients who can't take it due to GI side effects. So I don't think one wants to offset one symptom alleviation for another. I think the anti-tumor piece has been looked at for many, 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 many years with many, many, many studies with really no positive result. So I think going down the anti-tumor would be not the way they should go. I think there's a lot of other tools to consider.
Yeah.
What we don't know is with GLP-1 inhibitors being now so widely used, what is that going to do? And we don't know that.
Because that puts metformin to shame in terms of weight loss.
Correct.
Right, some of the newer weight loss drugs.
Yeah.
But I think this is interesting.
Yes.
Some people use it now. I think one of the most interesting thing was it didn't make the cancer worse, but it might have helped some side effects. This came from Mayo Clinic. You know, let me set this up. This came from Mayo Clinic, and everybody's always looking for a hot flash cure, and we've been fighting hot flash cures, right, since I've known you for 30 years, and you want a non-hormonal treatment. Along comes Mayo Clinic. They do this Ditropan, oxybutynin, which is an overactive bladder drug. It costs pennies a day, and they're reporting this massive reduction in hot flashes. What say you about this new potential treatment? Is it?
I think it is. I think, you know, it's coming from the Alliance Group, which is a huge cooperative group. So this isn't one center, although Mayo did do a lot of the work. This is multiple centers. So you're not getting one biased view, you're getting multiple investigators. I think for a medicine that even has a different, you know, potential benefit from that, as Ditropan's a great drug, I think this one has legs and should be incorporated.
That's awesome. Because some of the early data came from postmenopausal women experiencing hot flashes, and then breast cancer, and now prostate is utilizing it. So I didn't know you were going to say that. That makes my day. So here's my argument, because you know I've done talks for you and other people. You know, I always run around, people want to hear about vitamin D deficiency, and I always go, well, wait a second, let me put this in perspective. I'm not worried as much as any other person about vitamin D deficiency. I'm worried about a D deficiency that no one talks about, and that's not enough men are getting DEXA scans. In the last database, only 8% of the men that qualified for a bone mineral density scan got it while they were on hormone therapy. So the real deficiency going on is not enough men are getting their bone mineral density done. Is this true? Do you push bone mineral density, DEXA scans? What say you?
Yes, it's true, and yes, you should be getting one at least as a baseline, especially when you start ADT therapy. The second deficiency is the follow-up. So many of you who are on more than just your allotted 6 months, 2 years, this is something that you start to see bone loss after 6 months. So you need another one. Now, the insurance companies won't technically let you do one unless it's been about 18 to 24 months. That's usually what the timing is, and that's probably right. But the deficiency, number 2, is that you're not getting a follow-up. For those of you who are metastatic and either resistant or sensitive, you should be getting them every 2 years. So we know that you don't have ongoing bone loss. Okay, so that's second message, do a follow-up.
Thank you.
Just maybe a lot of them don't know what it is, though.
Yeah, so a DEXA bone mineral density, because in women's health, you know what it is. In order to diagnose you with osteoporosis or osteopenia, you have to just go into a 10-minute little device. It's an imaging device. It's an open device. It has 10% of the radiation of a chest X-ray. It's very safe. It takes about 10 minutes. They look at your hip generally to tell you how your bones are doing, and women are doing this when they're going through breast cancer treatment. It's a no-brainer, but yet we have virtually no men getting this done and asking for it. And even if you got to pay out of pocket, it actually costs less than dinner in Los Angeles now. It really does, right? I mean, it's gotten pretty
Not
cheap.
in Rochester, Minnesota, but for sure, LA, absolutely.
You talked about germline or genetic testing. So what you're born with certain genes. They can test that for BRCA1, BRCA2. Then you talked about somatic testing. They can test your tumor. You can do liquid biopsy. So we talk about this and this. But this is what I'm learning in other cancers. Yep. Other cancers are doing both.
Yeah.
And sometimes they find a mutation in what you're born with, and sometimes they find a different mutation in your tumor. And to some drugs in those other cancers, the patient's getting a bigger response to those drugs. So my question is, why don't do both when you're dealing with an oncologist? And what do you think about this idea that, because some people are getting somatic testing without getting germline.
Right.
So anyway, that's my...
Right. So the answer is both at the right time. That's probably the right answer, right?
Okay.
So if you are a very high risk, no metastatic, but now you're coming to see me for additional RP pills, you should get germline. But to get somatic, number 1, won't be covered by your insurance because you're not metastatic. And number 2, doesn't help you at the hot moment. There you would do germline to make sure that there's no future impact to your care, but also about other family members, either brothers, sisters, or kids or grandkids. But if you're metastatic to begin with, you should get both. I also want to clarify, germline is a one-time type of test.
That's a good point.
You don't keep testing that, but know what you got. So you're going to say, well, what does that mean? Well, there's a lot of companies that will say, we just want you to check for BRCA1 and BRCA2. But most companies are now testing 88 genes. So it's the most wanted on your post office, like, I don't like that gene, I don't like that gene. The breast cancer gene itself has 14 ugly cousins. So some tests don't check it. So number one, know what your test is. Number two, get your results so you have it as part of your medical records. Because guess what? These things tend not to get uploaded in the EMR, in the electronic medical record. Okay, that's a one-timer. Your somatic, you can get every time your drug doesn't sort of behave and it doesn't work anymore.
Thank you.
You get it again.
Not just one and done.
You get it again. Okay.
All right, sorry, I got you all excited. You talked about immunotherapy, so Provenge is still there. The idea is to use it as early as possible when you become castrate resistant, hormone refractory, whatever we want to do, right?
Yep.
But then you talked about this MSI test that then you qualify for Keytruda.
Yep.
But how do I get this test to see whether or not I qualify for this drug?
When you do your somatic testing, it's usually part of that panel.
Okay.
Aha. So, again, know what the test is. This is now the Wild West in terms of somatic testing. Everyone's got their favorites, but even within one company, there may be 8 different things you can check. Okay. So some just do 10 genes, some are 40 genes, some, I don't know why they're doing this, they check your entire genome of 22,000 genes. So this type of testing is very complicated. Worse yet, you get the results back, and a lot of calls I get is, can you help me interpret what this means? Because it's so hard, 30 pages, and you're not sure what the test is telling you. So it's 2 issues. One, advocate to get tested. Even if you're not sure if it's one or both of the other, say, what about molecular testing? That's a good conversation starter right there.
So when someone comes back, have you seen someone come back with this MSI high, and then you give them Keytruda, which has 41 FDA approvals for 18 different types of cancer? Do you see them respond in general?
Absolutely.
Absolutely?
Absolutely.
Absolutely.
3% of you will respond gloriously. Gloriously. I had a patient with a PSA of 1,000, went down to 2.
Nice.
The issue is it can't hold it, right? But that's okay. If we can get a period of time where your PSA and your cancer is controlled, thumbs up. But this is where you don't get upset, where you're like, well, I'm not this. I just told you, it's 3%. That means 97% of you won't test positive. But if you're that 3%, it's another box that you can check in your toolkit.
Great.
So why not?
CAR T-cell therapy. Man, you came to this conference a couple years ago. We were all excited about it.
Yep.
What happened to it? And now I saw a press release in the past few weeks about forget CAR T. There's this new thing at UCLA and other places called CAR NK, natural killer cells.
Yep.
And it's a lot cheaper to do, and it might be more effective in prostate. What do you say about this? What is this, and what do you say about it?
So let me just say, when you're thinking about what's happening, what's the bucket of cellular therapy, it's not going after the cancer specifically, like chemotherapy and all these other agents I was talking about. This is us trying to tell your immune system it keeps missing the bone metastasis that's in your system. This is us telling your liver that those cancers don't belong there. But to do that, it's worked exceptionally well in liquid tumor patients. So lymphoma, leukemia, multiple myeloma, you can mess around with the immune system, reprogram it. In the solid tumor case, it's a little harder. And this is very huge field where you're basically re-engineering your immune cells to recognize things in a much more thoughtful way than your other medicines like Keytruda and so on. They all work differently. Most of these trials will combine it. So what's the downside? There's a lot of side effects because you almost have to wipe out your immune system to begin again. So this is a different view. It's not for everyone, but there are derivatives of this coming, such as the bispecific antibodies, targeting a part of your immune system. So this part has completely exploded. Why is this important? Because a lot of trials are looking at the different targets and also different drug delivery. So if you feel that, oh no, I don't know if this is right for me, just ask, because this may be the right next step.
Pluvicto you talked about. I'm excited about it, but I'm excited in urology. There's a trial, for example, it's going on where they give it in a trial before surgery.
Yep.
So these are people who are still sensitive to hormones to see if they can help downgrade the tumor or wipe it out.
Yep.
What's next for Pluvicto? I know the side effect there is dry mouth we always freak out about. So that's the quick question.
Yeah.
What's next for Pluvicto? Is it just moving it earlier?
And maybe longer. So the next big trial is not just you stop at 6. So many of you said, why am I stopping at 6? I still have a PSA, I'm still responding. If this was chemotherapy, you'd go on for another 6. So the current trial now is you go for 12. So that is available, and there will be many more. And then of course, hey, doesn't Pluvicto need a friend? So there's a lot of combination studies as well to try to get at that quickly.
And the next drug that might even surpass Pluvicto that you talked about is actinium.
Yeah.
It's the same, it's a radiopharmaceutical. Is that going to be the next FDA-approved medication? And hold on, I got to get my financial advisor on the phone.
Yeah.
No, it's not a stock tip. I always like people to predict. Are you feeling good about this possibility? Because there's a lot of these trials going on that are moving.
I am feeling good about this possibility. Alpha emitters in general are really, I think, very, very active. The side effects will be the thing to watch for. As any one of you can imagine, powerful drugs come with powerful side effects. So the trials will probably not finish for another 2-3 years. So this has still got a while to go.
Here's a couple trials of chemo. Next slide, let me just summarize this. So you all get excited about 2 chemotherapies, Taxotere and the other one's Jevtana. But I always find it interesting that the first one that you give has more neuropathy, nerve issues, and it causes hair loss, but the other one doesn't. So why is this just a breast cancer issue of losing hair and these nerve issues? Why not give the second drug first instead of the first drug that's more toxic?
Yeah, data and insurance approval. Many of us would love to give cabazitaxel first. We absolutely would. Can't get it cleared through your insurance.
Okay, but then what about what they're doing in breast cancer to stop the nerve? So during the time of chemotherapy, they give them cold caps, they give them cold socks, cold gloves, because it cuts off the amount of drug that goes to those areas. And so why not just let them put their hand in ice or their feet in ice or something that's cold during the time of chemotherapy? Are we doing that?
I think it's available. I think it's the infusion itself for 60 minutes. So you sticking your hand in a bucket of ice for 60 minutes might be somewhat challenging, just putting it out there.
Yeah.
It is available, so at Mayo Clinic, for example, we have that. But there's also a whole thing where you can try to cycle it based on the chemo administration. So you have to start it, and then it goes through, and you're still in it, and then you finish, and you're still in it.
I just don't know why.
It's a whole algorithm.
I don't know why this is not offered to everybody. I don't get it.
And sadly, it's also an insurance issue, so I'll just plug that for all of you to advocate for.
Well, then stick in insurance. Ice is free. There are a lot of my patients that will suck on ice for the whole time. Okay, the other thing is we have these other chemos out there that are doing some good stuff in other cancers. Are we going to see another chemo drug come along?
I think not. I'll be honest with you.
Okay.
I think not.
Okay, this is the end part. What am I missing? What's coming next? We talk about ARV-110, these things that degrade the androgen receptor. Yep. I'm really excited about that. I don't work with any of these companies there. So, what else, Dr. Heath? I mean, there's a couple other drugs. Is this the category you're most excited about that we should be watching? What's your take home one more time on that?
So I think, again, anything that goes after the androgen receptor is still all in play. Much like in breast cancer, it's all about the estrogen receptor. We still haven't deviated from the androgen receptor. The newer version of the ARV-110 is the ARV-766. All that means is we're going to keep going like this to the androgen receptor until it cries uncle. So that's one, and I think those studies are really looking very promising. Checking on molecular testing is, again, to look at PTEN loss. So if you say, what else am I going to look other than the BRCA family and the MSI? PTEN loss, because AKT inhibitors are oral drugs that are already approved in breast cancer, and we tend to take the the lead from the breast cancer community. So my sense is that's
cool.
going to mature sometime very soon.
I like that. I like that a lot. Next important question. Is it true you're heir to the Heath candy bar fortune?
Absolutely false.
False?
Thank you very much. Yeah.
No wonder
they
you
taste
never
really
buy me
good,
anything. Okay. So you have no relationship with the
No
Heath candy
relationship.
bar?
Full disclosure.
So last year we gave out free Heath candy bars. They made money. You didn't make any money.
None. But
I just have to understand conflict of interest here. I've talked to the most brilliant team in America, which is the PCRI team. I said, this is not appropriate. I knew her 30 years ago when nobody knew her name, and now she's the big wig, the big hot shot at Mayo. We need to do her a favor and fix this up. So I thought, how about this as your Mayo slide next?
That is awesome. I'm going to gift that to my husband.
You should.
So he knows exactly. Yeah, that's perfect.
But we thought you might think
you,
this is too much except for your husband.
Yeah.
And so maybe we'll just kind of a midpoint. Do we have the other one? There. How about that one? So at least you get the white coat and the stethoscope. And as we finish here, and we'll come back a little bit after 10 o'clock, I have to give you your gift. For those of you who have not seen Dr. Heath before, she is the luckiest person in the world. She's received the best gifts of all time.
That's true.
We gave you an Oscar a couple years ago.
Sitting in my office.
Right? We gave you a coffee cup that said that you're cancer's biggest nightmare, and you like that? Is that in your office too?
Yes, that's in my office.
Okay. How about a scepter?
Wow! I love it! Oh my gosh.
Yes, it was extremely expensive. That's a blue diamond. And we thought, well, if you can't use that at Mayo, I'd use that at Mayo if I was the chair. We got you a Hollywood Walk of Fame, Dr. Elizabeth Heath, signed here, so you have your own Walk of Fame that you can put up in your office.
Thank you.
Thank you, everybody. Alex, thank you so much. She's going to go in the back room.
I'm in the back room.
She's going to use the scepter, and Alex has an announcement, and we're good.
Okay.
Thank you, Dr. Heath, and thank you, Dr. Moyad. That was great. Our next speaker we want to get into right away because we have just an action-packed day for you. I do want to remind you to go ahead and go to our conference page at pcri.org/2025-conference. We're also going to link it in the YouTube section here and in the comment section because we want you to see and experience the full breadth of all the information and resources that we've developed from the conference. You can see the agenda, you can see our sponsor and exhibit hall, and so much more. So I would encourage you to check it out there. I'd also like to thank our sponsors, Bayer, Pfizer, Astellas, Janssen, Novartis, Dendreon, Miradex, Blue Earth, Foundation Medicine, and AstraZeneca. Our next speaker is Dr. John Mulhall, and he is the Director of Sexual and Reproductive Medicine at Memorial Sloan Kettering. Dr. Mulhall is the author of a book called Saving Your Sex Life, and it's a guide for men with prostate cancer. Now, as we know, prostate cancer affects the functionality of a man, and it's important that this is paid attention to, and Dr. John Mulhall has been such an incredible advocate, helping men understand what to do for erectile dysfunction, Peyronie's disease, testosterone deficiencies, and so much more. And today he's going to go in detail of what you can do to take care of yourself, as well as paying attention to your overall prostate cancer. So without further ado, thank you so much, Dr. John Mulhall.
This guy always gives me a little bit of a heart attack when he comes and speaks to the conference because his flight just landed about 35 minutes ago. So thank you for that. Thank you for creating all this stress for me, not knowing if your flight was going to be on time from New York. Yes, however, the reason that we put up with Dr. John Mulhall, not just the fact that I've known him for 30 years, I mean, he's lucky to know me, that's the bottom line. But I'm just going to give you this introduction. Not only are his videos the most popular when we do them at PCRI, go check them out on rehab, sexual dysfunction, what's happening in the area. I can tell you behind the scenes academically, and I don't want him to be PC about it, you don't even have to comment about it. There is no one better in the world that does what he does. That's why he's at Sloan Kettering. He ran our biggest journals. He's a mentor to countless individuals. He's got a very busy practice. And so I think that's the best way. He gets the gold medal in this category in all of prostate cancer, which is why I'm inviting him, and I'm also smoothing this out because when I come after him during the Q&A, he'll remember that I said nice things about him. Ladies and gentlemen, number 1 in your heart, number 2 in my heart, Dr. John Mulhall from Sloan Kettering.
That's a lot of pressure, right? It's my pleasure to be here. It's not the first time I've spoken. It's one of my favorite conferences to speak at. I usually start by saying bravo, and bravo is to you for seeking information and knowledge. In the ever-changing healthcare environment in the United States of America, patients need to be their own advocate more frequently. And I think the fact that you're here, you're demonstrating that. These are my disclosures. There's nothing that I involved in that's going to impact upon the conversation today. So I'm not an oncologist. I have many patients come to see me. I met 2 of them the other day on Thursday in clinic who really wanted me to help them make a decision. What should they do, surgery or radiation? I never do that. I give information. I talk about data. But I am an oncosexologist. So I am a urologist who does only sexual and reproductive medicine at the nexus of cancer. I work at a cancer center. I see 600 new prostatectomy patients a year. I see 200 new radiation patients a year. So this is a huge part of the practice. And as Mark alluded to, I've been in the business 30 years, and we've known each other 30 years, which is very impressive. Thank you for reminding me of that. So I love this quote. This is from John Hewlings Jackson, who was a neurologist at the beginning of the 20th century. It takes 50 years to get a wrong idea out of medicine, and it takes 100 years to get the right idea in. The wrong idea is your PSA is undetectable, Mr. Jones, and you should be happy. Even though you're leaking urine, you wear 4 pads a day. Even though your erections haven't worked in 4.5 years, and your penis is bent and shorter, and you leak urine every time you ejaculate. Okay? So my job is to empower you to ask the questions you need to ask to get the best outcomes you're going to possibly get. Surgery, radiation, hormone therapy, chemotherapy, vaccines, whatever it is, you must be your own best advocate. There is nowhere in the prostate cancer journey where sexual dysfunction is not an issue. Even the diagnosis of cancer can lead to sexual problems, the stress associated with diagnosis of cancer, etc. And stress is a cause of erectile dysfunction, for example. So everywhere in the journey, sex is potentially threatened. Achieving optimal outcomes required fully informed consent. I say to patients all the time, eyes wide open before treatment, preferably, and requires that the clinician gives realistic expectations. The word cancer is scary. If you take men who come in to see me pre-prostatectomy with Gleason 3+4, clearly organ-confined cancer, who've got lots of time in making decisions, there's always this big stress. I need to get my prostate removed. I need to get my prostate radiated. And sex in their mind is the last thing they're thinking about until 3 to 6 months after treatment. And then they come in and say, okay, now I'm ready. I want you to think of your penis like your biceps, Mr. Jones. And if you put your arm in a plaster cast for you and you don't move it, you know that your biceps will undergo atrophy. The same thing happens in your erectile tissue if you're not getting erections on a regular basis. And that atrophy in the penis is permanent. And that's why we get 3 to 6 erections every night of our life after 12 years of age, because those nocturnal erections have nothing to do with your bladder being full, by the way. They are there to protect your erectile tissue. You don't use it, you lose it. In fact, you don't even need to use it. You don't get it. You use it. Erection rehabilitation, which we'll talk about a little later on, is erection-based and not activity-based. So my job today, my job every time I speak at a patient conference, is to give you advice to help you enter any treatment program with your eyes wide open. The only sex-friendly prostate cancer treatment is active surveillance, and even that is not even that sex-friendly because, as I alluded to earlier on, the adrenaline response to a diagnosis of cancer, adrenaline is the world's most potent anti-erection chemical. We're only as good as our last erection, right? If our last erection is bad, we walk into the bedroom the next time, anticipatory anxiety, adrenaline sky high, and then we just don't function well. And that becomes a snowball over time. These are the barriers to good sexual health care. I won't go over these in great details. There are groups of men who are even more disadvantaged in this space than the average patient who walks in at 65 years of age who's been married for 25 years. And they are men who are single and the gay male. The patient who's got pre-treatment ED is very interesting because if you say to your treating physician you already have erectile dysfunction, there is an increasing likelihood that you will not be spoken to about in the same terms about your sexual function in the long term than somebody comes in who says, you know, my sex life is really important to me. So even if you have baseline erectile dysfunction, but your sex life is important, it is critically important that you declare that to your treating physician, that you don't want to let go of that. These are the sins in sexual medicine. This is mainly for clinicians and not for patients, but I thought I'd share it with you. The first is ageism. Oh, you're 75 years old, Bill. You've had a good innings. What are you really worried about? I got 2 93-year-old men. I saw a 91-year-old man this week in my practice. I don't care how old you are. I care how motivated you are. Projection. Clinicians project. There's no other area of medicine where this happens as regularly as this. We project our own sexual mores, our own interest, our own proclivities, perhaps, onto our patients. Judgment, intolerance, apathy, and then very, very prevalent in the cancer space is the concept of parentalism. That we as the doctor, we're the parent, we're guiding you. When really, to be honest with you, in the sexual medicine space, this is all about shared decision making. My job is to give you options. Your decision is to decide what you want to do with those options. And I think that is doesn't happen with great regularity in the sex space and cancer, in oncosexology. Realistic expectations. The Movember International Society of Sexual Medicine guidelines came out a couple of years ago. It's really mainly for physicians. It's easily found and it's very interesting for you to read. Referral pre-therapy to a sexual medicine clinician, discussion of frequency of problems, discussion of time course of recovery or preservation, ways to minimize long-term treatment effects, and discussion of strategies. And this is the publication. I was the senior author. Daniela Whitman, who's at the University of Michigan, a psycho-oncologist at U of M, was the lead author on this. And this was a huge effort over the course of several years to get these guidelines. 47 guideline statements that are published. And I'll just show you the first one of them. A clinician-initiated discussion should be conducted with patient and partner, where one exists and where it's socially appropriate, to educate them about realistic expectations of the impact of prostate cancer therapy on patients' sexual function, on partners' sexual experience, and on the couple's sexual relationship. But it isn't just about whether Bill's erection gets hard or not. It's about the downstream consequences of everything that's associated with that over, let's say, the 2 years after his prostatectomy, when he hasn't had a good erection and he ejaculates urine and his penis is curved and he has to use penis injections. All of those downstream sequelae of those factors. There's a bunch of different sexual problems. We'll go over as many of them as we possibly can. Mark's going to stop me when I run out of time. But these are the ED rates in the literature, 3 to 90%. How's that possible? Because there are different definitions of this. And if you ever see 97% of my patients have erectile function recovery after radical prostatectomy, that defies the laws of physics and physiology. It just doesn't exist. And those patients in that 97% are using penile injections to get erections. Okay? That's just fact. Okay? And ejaculation, the failure to ejaculate, 100% of men after radical prostatectomy. But there's a significant proportion of men after radiation in time where that happens also. Low sex drive, changes in orgasm, nature, intensity, orgasmic pain, climacturia, arousal, incontinence. We'll talk about this in a minute. So this is the prevalence of the sexual problems. But if you do a Google search and look at those very same things, what you'll see is that erectile dysfunction is not the number one thing that's being searched. What's being searched are things like changes in orgasm, low sex drive, and penile volume alterations. And in the medical literature, these are way down the list in the number of publications and the amount of research that has been done and the amount of time that clinicians spend talking to patients about these before treatments. These are the causes of ED, erectile dysfunction, the consistent inability to obtain and or maintain an erection sufficient for satisfactory sexual relations, blood vessel damage at the time of surgery with radiation, hormone therapy damages blood vessels, the lining of our blood vessels, the endothelium is damaged by the absence of testosterone, nerve injury, of course at the time of radical prostatectomy, minimal nerve injury with radiation, but hormone therapy also damages nerves to the penis. And then the final common pathway to permanent problems is that muscle inside the penis. You put your hand around your penis, Mr. Jones. Most of what's inside your hand is a muscle. Remember I said it's like the biceps. When that muscle degenerates, it is gone. And radical prostatectomy, especially non-nerve sparing surgery, Radiation therapy over time and the addition of androgen deprivation therapy all damage that muscle, and that leads to permanent erectile dysfunction. The undecided patient, the patient who comes in to see me before, should I do surgery, should I do prostate gland ablation, should I do radiation? I always say, I'm not your cancer doctor. I'm not going to tell you what to do, but I will tell you the impact. When you go back and you speak to your prostatectomist, ask your prostatectomist, what's the possibility of doing excellent nerve-saving surgery on both sides? Because that's a major predictor of erection function recovery. When you go back and you speak to your radiation oncologist, is it single radiation therapy, monotherapy, or is it dual therapy, seeds and then external beams some weeks later? Is there a need for hormone therapy? And what duration of hormone therapy should be used? And if we're getting these patients coming in focal therapy, high intensity focused ultrasound, cryotherapy, irreversible electroporation, photodynamic therapy, all of these minimally invasive strategies, right? Is it half the gland? Is it the whole gland? Which energy is planned? What's the possibility of excellent nerve sparing? And ask about ejaculation. Even with prostate gland ablation, there are ejaculatory problems. So if you're before all of your treatment, get out your phone and take a photograph of this, because these are the questions you should be asking your proposed treating physicians. So let's talk about erectile function. Erectile function preservation, degree of nerve sparing at the time of prostatectomy. Baseline erectile function, if you go into your treatment with poor erections, especially if that's physically based, your outcomes in the long term are going to be poorer. The older you are, the more likely you have poor outcomes. The older in the literature is above 60, 65 years of age. 65 is the new 40, right? I'm 63, so that's what I believe. Physician experience, very important. Physician volume, particularly in the surgical space. It is a perishable skill. Medical comorbidities, especially things like diabetes, sleep apnea, and very low testosterone levels. We now have accumulating evidence in the literature, especially from Memorial Sloan Kettering, that the presence of diabetes, the risk of having sleep apnea, and very low levels of T are independent predictors of poor recovery after radical prostatectomy, right? So if you're diabetic, optimize your treatment. If you got sleep apnea, you think all that's happening is it's keeping Mary awake at night. No, it is potentially damaging your erectile tissue because you're not getting REM sleep and you're not getting nocturnal erections, and it increases the risk of problems with prostate cancer treatment. So after prostatectomy, ED is immediate. Had sex on Tuesday night, had surgery on Wednesday, no erections on Thursday. The low point after prostatectomy is 3-4 months after surgery. We see men come in a month after surgery, Viagra, great response, Dr. Mulhall, and 3 months later, it's much worse. There are things that happen around the nerves after surgery, especially in good nerve-saving surgery, where those nerves get damaged in a more long-term fashion. Recovery is at 18 to 24 months. One of the great tragedies in my practice is somebody comes in to see me and says, but my surgeon said I should be fine by 6 months. And then by 9 to 12 months, erections haven't recovered and a sense of hopelessness sets in. Right? This is an 18 to 24 month time frame, and only 20% of men ever get back to baseline. So everyone takes a hit with radical prostatectomy. Now we can get many more back to baseline by using medication or medical treatments. And that number, by the way, when you're over 60 years of age, is only about 5%. 5% of men over 60 years of age, Memorial and Sloan Kettering, seven men who do prostatectomy who don't have any female prostatectomists at our institution. All of them are expertly trained, even in their hands. 5% of men over 60 years of age get back to baseline. We talked about recovery. We'll talk about rehab later. You will never ejaculate again. If you're interested in fertility, okay, some of you are out there like giggling about fertility. I work in Manhattan. We got lots of 68-year-old men. I got 38-year-old wives, okay? We've got really good data on patients not knowing and regretting not pursuing sperm banking before their prostatectomy. So fertility is important for you, for surgery, for radiation, for hormone therapy. Bank sperm. You'll have an orgasm after prostatectomy. It will always, always feel different. It's just not the same. Almost 100% of men say those exact words. And pain can occur at orgasm, dysorgasmia, and that's about 15% of men, usually short-lived. Sexual incontinence, we're going to talk about that in a little bit of detail in a minute. And penile length loss. 70% of men have documented penile length loss. Patients come in all the time and say, my surgeon says my prostate is this long, and therefore my penis is going to be that much shorter. That's a fallacy. That's just not how it works. The bladder is brought down to the urethra, not the other way around. Okay? If you're not using that muscle, It undergoes atrophy. Third time you've heard me say that today. Okay? And that atrophy is permanent, and that is the major factor in long-term volume loss. In the very early stages after surgery, there's a complex thing called sympathetic hyperinnervation. You don't need to know much about it, but the penis has excessive tone, and it's contractile. And we see these men who are circumcised at birth, they come in, and they have a hooded penis. The foreskin is draping over the head of the penis, even though they were circumcised, because their penis is contracted. And that's just a function of nerve trauma. That's temporary. But the long-term length loss, volume loss, is due to collagenization of the muscle. The atrophy and the muscle turns to scar. There's no clear data that's showing that one radiation modality is better than the other. What you have in the literature, unfortunately, you got the proton people saying this is great, you got the brachytherapy people, you got the IMRT, the IGRT, the VMAT people saying this is the best thing, but there's no head-to-head studies comparing one versus the other, okay? There's little effect on the penis within the first 12 months. When men come in to see me, I saw a man the other day, 4 months after his radiation finished, and he's got an ED, almost certainly, he's not no hormone therapy, almost certainly that's not his radiation. That's an adrenaline response. Because radiation doesn't really have much effect within the first year. Years 3 to 5, that's when it's at its peak. Recovery, as I talked about before, and ED rates after prostatectomy and radiation are about the same at 3 year, parenthesis caveats, provided you're comparing excellent nerve-sparing surgery to radiation monotherapy. As the nerve-sparing drops, it becomes worse, the ED rates go up. When you start doing high doses of radiation, combining brachytherapy and external beam, the ED rates will go up, and the addition of hormone therapy, especially beyond 4 months of duration, is going to significantly increase the rates of ED. So when you're being told by your radiation oncologist, by your rad-onc, or your medical oncologist, that we really need to be adding in hormone therapy on top of your radiation, your reflex next question, write it down, is what's the survival benefit, Dr. Jones? Okay? Because then and only then can you, as the patient, make the decision whether 6 months is needed, whether I'm going to do 24 months or I'm going to do it at all. Androgen deprivation therapy causes erectile tissue degeneration. Assuredly, that will happen. You need some testosterone for that muscle to stay healthy in your penis. You don't need a lot, but you need some. And you're not getting nocturnal erections when you're on ADT, and you're not getting good erections, and almost certainly you're not responding well to Viagra, Levitra, or Cialis. Permanent ED is associated with men who are greater than 6 month use. So the further out you get beyond 6 months of ADT exposure, the more likely you are to have permanent erection problems. Ejaculation, you don't make semen if you have no testosterone, and it's almost impossible to have an orgasm when you have no testosterone. And likewise, 90% of men have almost no sex drive when they have no testosterone. There's an interesting group of men who have preservation of what's called visceral sex drive. I think of something erotic, I see something erotic, I get aroused. 10% of men with no testosterone have preservation of sex drive. It's quite remarkable. And if you speak to these men, they are the most libidinous men that exist on the face of the planet, and they don't need testosterone, even as a young man. They are just innately sexual human beings. What about ejaculation? It's really impressive to me how many men just don't get the difference between orgasm and ejaculation. Orgasm is the climactic, pleasurable sensation that occurs in the cerebrum, the brain. Ejaculation is the expulsion of semen, fluid, from your penis. The ejaculation apparatus is removed at the time of radical prostatectomy. 0 chance of ejaculating. If there's any fluid that comes out, it's one of 2 things. If it's watery, it's urine. And if it's clear, sticky fluid, then it is a secretion from the glands in the urethra, which more vernacularly is termed pre-cum. Radiation therapy, 50% of men fail to ejaculate at 3 years, and that number at 5 years is 90%. So when men come in trying to base a decision on ejaculation function, right, you're going to end up being anejaculatory almost certainly, even after radiation. If you had radiation and you're trying to get your partner pregnant, you must take at least 12 months off from that, because radiation causes DNA damage in the sperm. That's absolutely it's not very common in your age group, but we have had some exceptional circumstances. I told you before, when you have hormone therapy, there's no semen production. There are 2 other causes There's one other cause for failure to ejaculate. In the first year after radiation, many men are put on alpha blockers like tamsulosin, and tamsulosin has a very high frequency of causing retrograde ejaculation. Now, what's interesting about focal therapy is that many people are gravitating to focal therapy because they want to have preservation of ejaculation. The concept is called ejaculatory distress, right? That men getting bothered by the fact that they no longer ejaculate. And that's about 30% of straight men and about 90% of gay men are of high levels of ejaculatory distress. Be forewarned, even if you're having hemigland ablation, you can have complete failure to ejaculate temporarily for up to 12 to 24 months. Okay? And if you're having whole gland ablation, then you're virtually assured not to ejaculate because the energies are going to fry the ejaculation ducts. And if it's hemigland, it can take a while for even the other side to recover. What about sexual incontinence? The concept that urine comes out of my penis when I'm sexually stimulated or I'm sexually active. There are two types. There's climacturia, which is basically urine leak during climax. So it's urine leak at the time of orgasm. This is due to the bladder neck after prostatectomy being relatively incompetent early on. So the bladder neck contracts at the time of orgasm, so we don't ejaculate urine normally because urine's toxic to sperm. Okay? So physiologically, that's why it's there. But the bladder neck cannot contract effectively in the early stages, and so 60% of men have climacturia on at least one occasion after prostatectomy, and that figures about 20% of men throughout the first year. Less common in the second year, rare in the third year. It can be drops, it can be ounces, and the patient and partner bother is incredibly variable. It's uncommon past 12 months, and there are a variety of treatments, and I'm happy to answer those questions later on. The other and more problematic problem is called arousal or foreplay incontinence. This is unrelated to orgasm, but just when I'm getting stimulated, she comes, she gives me a back rub, I start getting turned on, and I start leaking urine, Dr. Mulhall. And that is a sphincter problem. And that's why arousal incontinence is linked to diurnal incontinence. I'm still wearing pads 6 months after prostatectomy. I cough, I sneeze, I leak urine. That's called diurnal incontinence, and that's the link between diurnal incontinence and arousal incontinence. And because it's unpredictable, because it doesn't just happen at one moment in time, orgasm, like climacturia does, it has a higher level of bother for the patient for sure. It occurs in at least 30% of men in the early stages after surgery, and again, usually resolves within the first year after surgery. But unfortunately, compared to climacturia, the treatments are relatively limited. Now, this is a really, really hot topic. If I stood here 10 years ago and I put this slide up at this conference, I would have been considered a heretic. Okay? Because the label for testosterone products says, do not give testosterone to men with prostate cancer. However, that's based on 1940s data. So, tremendous confusion in the field, not just among you, but among physicians, including many urologists who practice in the space. The most important message about testosterone for you is you need testosterone to make PSA. If you don't have testosterone, you can't make PSA. That's why you're on hormone therapy, you're on androgen deprivation therapy, your PSA is undetectable. Right? But if your testosterone level, the normal range, let's say, is 300, 800, if your testosterone level is below 200, you might not have enough testosterone to actually generate a PSA response. That's very important that you understand that. Testosterone is needed for bone sugar, heart health, osteoporosis, pre-diabetes development, worsening diabetes in the diabetic, and premature cardiovascular events and heart attacks and strokes associated with certainly the longer-term exposure to hormone therapy. And it's not just the exposure to hormone therapy that's important, because if a man goes on 6 to 12 months of hormone therapy, it may take another 6 to 24 months for him to recover, especially if he's older. And now it's 3 years of no testosterone, and they're the men who get osteoporosis, pre-diabetes, and are at risk for cardiovascular events. So at Memorial, before hormone therapy, everyone gets a baseline bone density, and they're being monitored with hemoglobin A1Cs, diabetes assessments, on a regular basis. Low T symptoms are really non-specific. Low energy, afternoon fatigue, decreased strength, decreased endurance, losing muscle, putting on fat, irritability, depression, decreased response to exercise, decreased productivity at work. They're also the symptoms of depression, chronic stress, chronic fatigue, perhaps sleep apnea. Okay, so they're very non-specific. The assays are very complicated. There's tremendous difference between how the blood test is done. It should be done in an early morning fashion, and some of them assays are much more accurate than others. What's interesting is that low testosterone is associated with higher stage, higher grade prostate cancer. It's not clear why that is, but it's likely that at least part of the problem is that men who've got low T don't generate the same PSA response. My PSA is fine. PSA has been 2.5 for years. Yes, but your T level is low, Mr. Jones. Okay? So just bear that in mind, that low testosterone is associated with higher stage, higher grade prostate cancer. There's excellent evidence to show that one's T levels, our T level in our blood, testosterone level in our blood, is not a predictor of the development of prostate cancer. And testosterone therapy is not associated with a risk of prostate cancer development. The Traverse study published 2 years ago, 5,400 men, large randomized controlled trial, placebo versus gel, following men for a few years, clearly shows now definitively that if you don't have prostate cancer going into the study, that you're not going to develop. There's no higher rate of prostate cancer between the placebo arm and the treatment arm, testosterone gel. Testosterone therapy is safe and effective when used, and I use this word very carefully, judiciously. If you listen to sports radio, you're going to hear lots of ads from low T treatment centers who just can't wait to get you into their office, and they will treat you with T levels that are perfectly normal. They'll treat you at high doses. They won't monitor you well, and they'll be very happy to take your credit card. Okay? They do not do this judiciously for the most part. Be very careful. The product label I already talked about, the contraindication for testosterone in men with prostate cancer and breast cancer, by the way. There are numerous treatment options, from pills to gels to injections, short-term injections, long-term injections, nasal sprays. There are a variety of different strategies that you could use. The potential risk for testosterone therapy is that you can develop a condition called polycythemia, which is an elevated hemoglobin level, because testosterone makes your bone marrow make more red blood cells, and then the blood can potentially become more viscous. This is most problematic in patients who have sleep apnea, who are at increased risk of polycythemia anyway. When you have really low testosterone levels, you should be anemic. It's very common we see men who come in with very low testosterone levels who are not anemic. In fact, their hemoglobin levels are very high. And by definition, those men have sleep apnea until proven otherwise. And then if you give that man testosterone on top of that, they're the chaps who run into problems. And we've had patients end up in the intensive care unit with flash pulmonary edema because their hematocrit levels is extremely high. So it's not a benign event. High estrogen levels, testosterone gets converted to estrogen. Very high estrogen levels chronically cause gynecomastia, breast enlargement. Fertility suppression. Again, perhaps this is not the population where this is most frequently spoken about, but if you take exogenous testosterone, gels, shots, it's going to suppress your fertility. And if you're on that exogenous testosterone long enough, that might be permanent. There are strategies for treating men who are interested in fertility who have low testosterone. So that may not be relevant to you sitting in the audience, but I'm really speaking to those who are going to look at this online. The next issue is a huge issue. If you're on testosterone, or if you're going on testosterone, or you're going to choose testosterone therapy, and that includes a gel, then you're at risk for transference, which means passing that on to a woman or to a child. Now, a postmenopausal woman getting a little testosterone is not going to hurt in general, but you can take a 6-year-old granddaughter that you're a caretaker to, and you can put her through puberty. And that's actually a true story in this country. Massive lawsuit against a pharmacy chain and against a urologist for a caretaker putting a 6- and 8-year-old granddaughters through puberty because of transference. We do not give transdermal testosterone to men who are at high risk of transference. And by the way, that includes obstetricians and gynecologists, and that includes pediatricians. Risk, not heart attack. The Traverse study that I talked to you about earlier on, not alone did it show that there was no increased risk of prostate cancer in men who go on testosterone therapy, there was no increased risk of cardiovascular events. And this is why that study was done. It was mandated by the FDA, $500 million trial, and it shows definitively now, for once and for all, that testosterone therapy does not increase the risk of myocardial infarction. These are the AUA guideline statements for prostate. I was the chairperson of the AUA guidelines on testosterone deficiency and testosterone therapy. If you're going to go on testosterone therapy, if you're 40 years of age and older, you should have your PSA level checked at baseline. There's an absence of evidence linking testosterone therapy to the development of prostate cancer. That was even pre-Traverse. Now that's confirmed. And then we just don't have enough data in the prostate cancer space to say what the safety is of men who have prostate cancer going on testosterone therapy. So there's an absence of large, long-term safety data on the safety of TTH, testosterone therapy, in men with prostate cancer. Saying that, what literature does exist, there is no signal that testosterone therapy increases the risk of prostate cancer, right? So we don't have 15,000 men followed for 15 years, which is the least number you would probably need to show definitively it's safe. But I can tell you that we have hundreds of men at Memorial Sloan Kettering post-prostatectomy. We have smaller numbers after radiation, and we have increasing numbers with active surveillance who are on testosterone therapy safely, if they're properly selected and carefully monitored. We published this in January. This is a prostatectomy study, Gleason 6, Gleason 7, organ-confined cancer, 200 men followed for an average period of 3 years, no signal whatsoever that the recurrence rates are higher in those men who get testosterone therapy versus those who do not get testosterone therapy, whether it's 3+3, 3+4, or 4+3. I'm going to give you some one-man opinions as I go through. I'm not sure how much time. I think I got like another 15 minutes or so here. You heard me mention adrenaline earlier on. From an erection standpoint, adrenaline is the enemy. Okay? It is the fight or flight hormone. Two circumstances under which you don't want to be getting an erection, right? So our body is designed, physiologically, adrenaline turns off erection. In fact, we walk around during the day, at least most of us, maybe not Mark, flaccid, because there's high levels of adrenaline in our penis. Right? And the first thing that happens in an erection is adrenaline gets turned off. But if you walk into a sexual scenario with extra high levels of adrenaline, then you're likely to have problems. Less blood flowing to the penis, and adrenaline opens up the valve. So men who come in and say, you know, I get rigid and then I go to penetrators. Just after penetration, I go soft. That is adrenaline, right? We're only as good as our last erection. Now, I have been admonished and chided and rebuked for putting up this term. And the concept is obsessive-oncocentricity, and that cancer doctors are interested in your PSA. And they become increasingly less interested in things that go outside the PSA, including quality of life. The wrong idea and the right idea. You need to be your own advocate to talk about the importance of your sexual health and your sexual function and your sexual relationship in your life. Shared decision making. You've heard me say that already. You think that your treating clinician will tell you everything you need to hear, when in fact the clinician will tell you everything that they think you need to hear. That is not out of malice. That is just, that's what they do day in, day out. They have a script, they go and they talk. Patient A comes in with this scenario, B, C. This is the talk that's given. You have to go in and you have to declare, I really want prostatectomy patients, for example, do whatever you possibly can to preserve my nerves, right? Yes, I know I've got ED. I'm taking Viagra. It's working great. Do whatever you can. At Memorial Sloan Kettering, if you have ED at baseline, we've published this, you're 5 times less likely to get nerve-sparing surgery. Memorial Sloan Kettering, I will contend that those figures are vastly higher at many other centers. So if you have baseline ED, you have to go in and say, it's still important to me. We have a vigorous, we have a rewarding physical intimacy life. We don't want that to change. Don't be afraid to ask why active surveillance is not an option for you. You know, this slide was much more meaningful 10 years ago when active surveillance wasn't a big thing. But now we're not really operating on Gleason 3+3 cancers, right? So active surveillance is a big deal. We have a huge active surveillance program at MSK. So, you know, just don't be afraid to ask that. And it may be a very clear and obvious reason why. You got a Gleason 4+4, you got extracapsular extension on your MRI. Very, very obvious things. But it's not unreasonable to ask the question. Before committing to a treatment, you've heard me say this already, think seriously about how important your future sex life is. Now, I want to say this to you. I want you to think about what your sex life was a year before your diagnosis. After the cancer diagnosis, men are consumed, couples are often consumed, we just want to get rid of the cancer. That's their only focus. And they're less focused on their sexual health until they get into a several month or several year period when they're completely incapable of having satisfactory sexual relations. Then it becomes a problem. The time to think about this is before you commit to treatment. And when you commit to a treatment, your eyes are wide open, you don't look over your shoulder, you don't second guess yourself, you made the best decision for you. Understand what your treating clinician means by erectile function recovery or erectile function preservation if you're a radiation patient. Okay? I told you what the definition of erectile dysfunction is. The consistent inability to obtain an erection good enough for penetration, sexual intercourse, satisfactory relations, however we want to define that. But it doesn't say in there when I'm using penis injections or when I'm using pills. Okay? So the literature is heavily skewed because there's a lot of data out there with very high numbers, as I said earlier on, defies the laws of physics and physiology, that they're including patients who are using penis injections. So be very, very careful. If you're seeing regular urologists, they're going to cite the literature. It wouldn't be unreasonable, okay? And I don't want to give urologists too hard a time, or radiation oncologists too hard a time, but in your hands, Dr. Jones, what's your recovery rates? I know that Dr. Walsh's and Dr. Scardino's and the Memorial Sloan Kettering data say this, that, and the other, but in your hands, please give me an honest appraisal of what the recovery is after prostatectomy or with radiation and with hormone therapy. Get realistic expectations about the time frame. Erectile functional recovery after prostatectomy is 18 to 24 months. The low point after radiation is really 3+ years, okay? That is clearly that's reality, okay? Beware physicians citing incredible figures for erectile functional recovery, preservation. I've already alluded to that. This is the back to baseline data. This is Memorial Sloan Kettering data. It's published in 2014, over 10 years ago. And if you look at the far right-hand column, this is a man who got back to baseline, same hardness after surgery that they were before, without having to use pills. You can see if you're over 60 years of age, that is almost zero. It is almost impossible to get back to baseline. You know, this used to be more relevant when there were prostatectomies that were being done open. In 2003, robotic prostatectomy came in, and now it's essentially every prostatectomy. There are residents, there are trainees in urology who've never seen an open prostatectomy. So really the robot is it. It has made no real difference in erectile function recovery outcomes, in urinary function recovery outcomes, or in actually cancer cures. So, but it's here, and it's the norm. It's really only how young urologists are being trained now. Physician experience is key. I think that's a very reasonable question to ask the surgeon or the radiation oncologist or the medical oncologist. How long have you been doing this? How many prostatectomies have you done? How many do you do per year? I know there's incredible patient discomfort when it comes to that because they don't want to upset the surgeon who might be actually operating them in a few weeks' time. But it's a very reasonable question and fair question. And if that surgeon becomes defensive, then I think that surgeon's not the match for you, to be very honest with you. I'm not showing much in the way of data, but this is surgeon experience on the bottom. This is biochemical recurrence rates on the left. You could put incontinence there. You could put sexual function, erectile functional recovery, and you can see that there's a learning curve, right? Whether it's 250 or 150 or 400 is less important to know than there's a learning curve, right? It's a skill that you have to acquire. This is interesting data. The bigger the circle, the greater the lifetime experience of a Memorial Sloan Kettering prostatectomist. So the smaller circle, low experience, and you can see probability of continence at 12 months, and on the y-axis, probability of erectile functional recovery. And you think those surgeons with the greatest experience would all be at the top right-hand corner, and the ones with little experience are at the bottom left, and that's not the case. And this heterogeneity is because some surgeons are just good. They're just good. And we are kind of, in our training programs, we can identify those people very early on. He's got good hands, she's got good hands, right? And some just are not as good. So you either do a good prostatectomy or you don't. ADT, I think I've said this enough. If you're going to be exposed to androgen deprivation therapy, and there are excellent reasons why you might be, okay, from a cancer-curing, life-saving standpoint, irrefutable. But it's very reasonable to ask about survival benefit. It's incredible to me, 25 years after the introduction of Viagra, that people come in and they're still using the medication improperly. Okay? The estimates are if you're prescribed Viagra or a Viagra pill by your primary care physician and you fail, you have a 50% chance of actually not having failed. You just haven't been using it properly. Right? Viagra, Levitra, Stendra. Peak levels within 1 to 2 hours. Empty stomach is critically important. Sexual stimulation required. You can't go sit in the corner read the New York Times and expect to get an erection, Mr. Jones. You have to be aroused. Oh, I didn't know that, right? Viagra, Levitra, 8 to 10 hour window, Stendra, 6 hour window. Here's how I think you should take Viagra or Levitra during a trial phase. 2 hours before a meal. You got an 8 hour window of opportunity. Dinner at 7, you take it at 5. You're good till after midnight, Mr. Jones. Sexual stimulation required. Brain and penis, Mr. Jones. Okay? Side effects, headache, flushable congestion, heartburn, visual side effects. 5% of men stop because of side effects. Most men who give up, it's not working well. Cialis is a little bit different. There's no food effect. It's very slowly absorbed, but it's very long lasting. We tell patients to take it at least 4 hours before sex. We got a 24-hour window. You don't need to be worried about food. It does have a peculiar side effect called myalgias, which is muscle aches, quads, glutes, erector spinae in the back. Sometimes that happens. About 12% of men will get that at maximum dose. You need to know how to use the two different, the short-acting at top and the long-acting at the bottom. You've got to use it properly. And then it works when you're using it properly. Then you can play around with it whatever way you want. Word for the partners. I know you felt unseen, and I know you feel unheard, and I know that there just aren't resources for you. How do I know that? I know that because Stacey Loeb at NYU and I, a couple of years ago, did a qualitative project where we took female partners of men who had prostate cancer and we did interviews with them. And we looked at the themes that they were complaining about. Isolation, unseen, unheard, no resources, nobody to speak to. We know that. And there are research going on now that is entirely focused on the female partner and hopefully in the future the male partner in gay couples. So you're no longer unseen and unheard. And with that, Mark, I'll stop, and I think you've got some questions for me. Thank you very much.
Let's go to the first slide.
This is usually the embarrassing one.
No.
Okay.
This is my dog looking for you at the airport because you always show up almost late, and it makes me nuts. So that's my dog going, where's Mulhall? It's a 24-hour worry we have at our house. However, to give you one compliment, since I've known you for 30 years, he's in New York now, I just thought, does he practice what he preaches? He seems like a fit guy. So I snuck in one morning a couple of weeks back when I was in New York into the health club. He was working out early in the morning. He starts his day early in the morning. And I snapped a picture of him, and I thought we would show that next. Impressive. Very impressive.
I cannot lie. I cannot lie.
Your buttocks is sublime, I can tell you.
That's called the Irish erection, right there.
Because we're going to finish at 11:20. I actually have time, and we're going to start lunch a little late, but we're going to do well here. You'll still get plenty of time for questions. All right, you're going to not like me for this slide, but I want to explain this. So we did an interview together a few years ago. It's been seen like 50,000 times on YouTube. I make him look good. You know, he doesn't do anything for me, but I make him look good. And there's a couple things that we got a lot of feedback on. So he comes into the meeting and goes, I said, how are you doing? He goes, oh, well, I had a brain tumor and they took it out. I'm good.
Very surgical.
What? I said, what? And he said, yeah, I'm good. I'm fine. I said, what? And so all these people are like, is he okay? So are you doing okay? I mean, that was the stunner of the interview.
Wow. I almost feel embarrassed to say this. I mean, I had neurosurgery, but it was a benign brain tumor.
I know, but benign brain tumor is like saying jumbo shrimp.
Okay.
It's like saying Ohio State winners or something like that. That was pretty funny.
few Midwesterners here. I'm fine. Thank you very much for asking. But you know, in fairness, physicians are really bad patients. I thought I was a good patient, but it gave me, you know, I've worked at a cancer center now for 23 years. It gave me added perspective on the whole thing. Surgeons are very surgical, you know, okay, choose the right surgeon, let's get it out, let's get on with it. But there was an intense emotional reaction after the surgery that I had because, you know, the mortality concept. So, but I'm fine. Thank you very much for asking.
Okay. Thank you. Yeah, give him a round of applause. You're going to dislike me for this. I ask you every time. Next slide. All right. I need to know some myths, facts. Do you really get ED if you ride a bike? Can you please tell me what the latest is? Can you get erectile dysfunction, or can you make your situation work by riding on a bike?
So anatomically, when you sit on a regular bicycle seat, you're actually sitting on your erection arteries, right? Those bones, that's called the ischiopubic ramus, that V that the pelvis makes. There's a canal under there called Alcock's canal, and in that canal are the penis sensation nerves. They're nowhere near the prostate. That's why there's no penis sensation problems after prostatectomy. But right beside those nerves are the erection arteries, left side and the right side. So technically, if you were sitting on those arteries a lot or repetitively doing compression trauma to them, you can cause damage. The three risk factors in the cycling space where we start paying attention are patients who cycle more than 100 miles per week, patients who have associated penile numbness when they cycle, so get out of your saddle, and those patients who do off-road biking, so mountain biking, BMX, etc., where there's a lot of compression forces. The cutout in the middle of the seat is just rubbish. It's a great idea. That's not where the pressure is applied. The pressure is applied on the side of the saddle. And so the seats, the only seats that really make a difference from a physiologic standpoint are noseless bike seats, which I think are probably, I'm not a cyclist outside of Peloton, so I don't really know how they work, but that will be the only one because it reduces the compression on the ischial-pubic ramus.
So if someone's
on the other side, sorry Mark, on the other side is any form of exercise is good for your endothelium. The lining of our blood vessels is the endothelium. And the penis is a big blood vessel. And the master regulator of blood flow in and out of the penis is actually the endothelium. And the reason we'll allude to PDE5 inhibitors, Viagra, Levitra, Cialis, and Stendra as rehab, the reason we use them in rehab is to protect the endothelium. So exercise is an incredible endothelial protectant. When I take men in my practice who have ED, who are over 75 years of age, and for some reason we're doing an ultrasound of their penis, and we show they have perfectly normal blood flow, 75 years of age, perfectly normal blood flow, almost 100% of them are exercises. And I don't mean I walk around the block every day, I mean they're exercises. Okay? So it is one of the best things you can do for your blood vessels and therefore for your penis. So whether it's bike riding or whether it's pickleball, then I think it should make no difference.
Pickleball increases the risk of ED?
No.
Sick of
I don't know how you play pickleball, Mark. But
I don't play pickleball.
That's not how I play.
I'm just sick of people talking about pickleball like it's the second coming of Christ or something. I don't know. Ejaculation, study from Harvard said 21 or more ejaculations per month, that people had a lower risk of cancer, they were healthier. My take on it was, this is probably not true, this is just a bunch of men lying about how many ejaculations they have. But
lying or scientific, a concept called recall bias. So if you say to somebody over the so I'll give you a scenario in my practice. Over the last month, Mr. Jones, how often have you had an erection, right? Or had sex? And he says, 8. And the wife turns around and looks at him. There's just incredible inflation, and it's not necessarily from a bad place. It's just recall bias, remembering. I can't remember what my erections were last month, right? You get these questionnaires, how were your erections over the last 6 months? This is the same thing. So there is no credible evidence that ejaculatory frequency decreases the risk or is associated with prostate cancer risk, that I am comfortable saying.
Every year I say this to you. You had this book. It covered everything. Best book written in the category. I can't find it now. Go to the next slide. Look at the table of contents. It covers everything. The pills, the suppositories, the injections, the implants. Are you going to do this book again?
Yeah, chapter 3 is done. It's very interesting.
Okay.
Publishing a book in the modern era is very different than publishing it back in 2008. Because unless you've got a social media profile, no publisher wants to speak to you. You have to have a social media profile. You got to be on TikTok or Instagram or whatever. You have to have that first to really garner the attention of the publisher. So hopefully, ultimately, I may end up self-publishing it. But yes, hopefully over the next year or so, we'll have the second edition for you.
Okay. All right, let me give this setup for this slide. When we did the YouTube video that got so much attention, I asked for a slide on penile rehab. He provided it, and this is probably the most input we had is, can he re-explain this slide? Because this is how he thinks rehab should be done. Can you go to the next one, please? So here's the slide you provided. Can you just walk?
Yeah.
If you have a camera, I'm telling you, I mean, the video is coming out in 4 weeks or so. Take a picture of it, because from the top person in the world, this is how he does rehab. Please walk us through it.
So patients who are going to go through extended periods of time not getting erections are at risk for that degeneration, atrophy, collagen deposition in their penis. One of the ways we try to prevent that is doing the concept called rehabilitation. Your penis is like your biceps, Mr. Jones, right? You heard that story, right? This is pertaining to prostatectomy. We do the same thing in our radiation patients. We do the same thing in our androgen deprivation therapy patients. We do the same thing in our diabetic patients, even those who don't respond to Viagra. We rehab them, okay? In fact, the evidence now is crystal clear that those men who are using Viagra-type pills on a regular basis have lower rates of cardiovascular events. Remember how they got introduced? It was an anti-angina pill back in 1992 in England, Clive Gingell in Bristol in England. And in the trial, it wasn't a very good anti-anginal agent, but men were not giving the pills back. When inquired, when asked, the reason they weren't giving the pills back is that men were getting better erections. And it took several years for those investigators to convince Pfizer to run with the ball, and that's how Viagra happened. So it started in the cardiovascular space. We've known for years that these are endothelial protectants. In fact, the heart attack rates in men in the trials, Viagra, Levitra, Cialis, who use pills versus placebo, are dramatically lower in those men in the pill arm than in those men in the placebo arm. So, we love to see patients before surgery. At Memorial Sloan Kettering Cancer Center, we still only see 17% of our patients before surgery. Those patients who come in see us before surgery, before radiation, before prostate gland ablation, focal therapy, are always those who are most informed and can make the best decisions. If you're before surgery, if you're before radiation, if you're before focal therapy, we suggest that you go on low-dose Viagra or Cialis on a daily basis beforehand. The concept is called endothelial preconditioning, that we're trying to ramp up your endothelial function so when the intervention which hurts your endothelium happens, your endothelium is upregulated and it's in a better starting place than if you're not on the pills. We see patients very, very early after radical prostatectomy. We see them 6 weeks after prostatectomy. They don't all come in at 6 weeks, but we want to see them at 6 weeks. Why? It gives them enough time to answer the question when they take the maximum dose Viagra or Cialis. Are they getting a penetration hardness erection? But Dr. Mulhall, why do you need me to get a penetration hardness erection? Because that's the average erection you get 3 times every night of your life. And evolutionarily, there must be a reason why we're getting nocturnal erections that are 6 to a 7 on a 10-point scale, where 6 is just about good enough for penetration, and that's a 10 mark, okay? And that erection lasts 10 to 15 minutes. There's a reason that happens, and that's what we drive people to for rehab. So when we have patients coming at 6 weeks after surgery, and they've tried full dose Viagra in weeks 3, 4, 5, and 6, only 15% of them are a pill responder. But my surgeon said my nerves were saved. Yes, but the maneuvers that Dr. X used to protect your nerves, Mr. Jones, cause those nerves to go to sleep. And those nerves go to sleep for 9 to 12 months, and it takes another 9 to 12 months for them to wake up fully. And that's why erection function recovery is an 18 to 24-month time. On the left-hand side, if you're a pill responder, right, then you've got all kinds of options. Viagra going to bed at night, and twice a week you're going to take a full dose, and we want you getting at least 2 erections a week. I don't care if you have sex, Mr. Jones. I want you getting an erection, which brings in blood, which carries oxygen and stretches the muscle. Okay? If you're a Cialis responder, use 5 milligrams a day. That gives you an 8 milligram dose in your blood. If that works, that's great. If not, you take an extra 5 milligram booster or a 10 milligram booster. That booster should be taken at least 4 hours before sex and is good for 24 hours. If you're on the other side of the algorithm here, which is the 85% slide, you're going straight to injection therapy. We'll say to you, we think you should be going straight to injection therapy. If intercourse is an important part of your life, if you want to maximize the chance of getting back to where you were before surgery, we want you to be getting erections. I don't care if you have sex, I don't care if you have an orgasm, get erections. And if you're not responding to pills at this stage, straight to injection therapy. Almost everyone starts training. It's interesting, even though we've had a man the other day sitting in a chair, introduced the concept of injection therapy, eyes roll back in his head, he passes out, literally sitting in a chair. So we understand it, but you must not base a decision on mental imagery. That's a bad thing in medicine, right? Come in and try an injection. If that day you tell me, I can't do this, I know I can't do this, that's an informed decision. But people sit there like needle, penis, oh my goodness, right? That's not what you really should be doing. Erections are so important that you have to be getting them. And if you don't, it's important that you understand what I want you to do, Mr. Jones. Get erections. Why? Protect the muscle. But the implications of not doing it. And you have these men go away and they come back 3 months later, now they're 5 months after surgery, and they say, okay, now we're ready. And it might actually by then be too late. The accumulating evidence is that if you're not on rehab by the 3rd month and getting erections by the 3rd month, that's a problem. Now that's more likely in older men, more likely in men who've got multiple risk factors for ED, more likely in men who have poor baseline erectile function. But even in younger men, getting people on rehab as early as possible. If you're going to do it, if you're not going to do it, fine. And you're going to live with that decision for the rest of your sex life. But if you're going to do it early.
So ICI on the right side, that means injection.
Penis intracavernosal injection. Penis injections, yeah.
And then C on the left side, that is for Cialis. V is Viagra. Yep. Right, QHS?
Every night.
Every night.
Medical terminology.
But I kid you not, 30 years later, I've met maybe 1 or 2 people that after 6 weeks of no response to pills, then were allowed to do injection therapies or were offered the option to do injection therapies. Don't you find it? I mean, I just talked to a guy in California, they waited about 7 or 8 months.
And that would be routine. It's not routine at Memorial.
I know, but
right.
You're saying this is the data that shows that you only let it go 6 weeks before you start injections if you're not responding to the pill, right?
Yeah. And that'll be the first time that man will have gone a day without an erection, almost certainly, since he was 12 years of age, right? So what muscle in your body, your arm in a plaster cast for 6 weeks, atrophy? The same thing is happening in the penis, right? It never goes a day without an erection, unless you're really sick. But you're getting nocturnal erections that bring in blood, oxygen, and stretch the muscle, okay? Critically important. If there's one thing you leave this conference, this lecture, remembering, it is this.
The only thing I brought up here is that there's all these options now. There's the pills, there's lifestyle. You've always told me that being heart healthy, going into any procedure, they're more likely to recover their erectile function. Okay, the other things I just want to mention, vacuum erection device. Do you recommend a vacuum erection device or not?
So if you believe the vacuum device manufacturers, and there are many of them, then every man in this room should be going back to your room right now and should be putting a vacuum device on. So good is it for your penis. From a rehab standpoint, it doesn't oxygenate the penis, right? It brings old blood back in. That's why it looks, if you've ever had a blood pressure cuff left in your arm for too long, the nurse steps out of the room and your arm is blue-gray, that's what your penis will look like with a vacuum device, right? Because it brings old blood back into the penis, right? There's no oxygen. So it's not a rehab strategy. It does preserve penile length. There's good literature that it preserves penile length, but so too does daily pills. Okay? And I have no relationship with industry. So you don't need to, I have no conflict in making that statement. And I've been doing this for 30 years and I haven't changed.
This is the first product that ever became available with the FDA nod over the counter for erectile dysfunction. It's a gel, you put it on the head of the penis, it's supposed to work quickly. If someone comes to your office and says, I want to try this also, your response is?
No.
Really?
No. Do you want to know the Eroxon story?
I know well, no, I'm not going to spoil it. Go ahead.
Okay, there was a trial done of a gel, which the gel had nitroglycerin in it, right? Now, nitroglycerin is a vasodilator, right? So like Viagra, that's why you use nitroglycerin for patients who have coronary artery disease. And so what they showed was that the erectile function response was almost just as good with the placebo as it was with the drug. And so the drug didn't get approved in the United States of America. This is the placebo. And it's kind of menthol-infused gel, and you rub it on your penis. And so menthol is going to cause a vasodilation, okay? And it causes tingling. And there is no credible evidence in the medical literature that Eroxon is better than a placebo. The problem in the ED space, this is very important that you understand this, when you go to the health food store and you see male enhancing this, that, and the other, is that there's a 30% placebo response rate in ED drug trials. That every man, even with physically based ED, has a secondary psychological component, and that is assuaged by giving somebody aspirin or using Eroxon. So there's no harm trying it. It's not going to hurt you. For sure, it's not going to hurt you. And I think if you want to try it, that's fine. But I would want you to have realistic expectations about what the outcome might be.
Kind of a bummer there. Let's go with slide 12.
You told me it didn't work on you, Mark.
Look at it. I'm a man. If you put any lubricant of any, it's a lubricant, actually. It's got lubricant. If you put any type of gel down there, things might happen. That's all I'm trying to say. So I just thought maybe you weren't.
Next question.
Next question.
That's just TMI.
All this talk of erections is making me nuts. This is a really important point because I find that most men don't know they're going to have dry orgasms after treatment, right? And then they don't know they're going to have climacteria. They know that something comes out, like you said, it's urine. And the other thing is, so you mentioned two things, climacteria and foreplay incontinence.
Yeah.
But if you have that after treatment, is it treatable?
Okay. So I told you that climacteria, which is much more common than arousal incontinence, 60% of men have it on at least one occasion, 20% consistently in the first year. It tends to go away of its own accord. If you have persistent climacteria, or it's bothersome early on, then there's a number of strategies. So the historical strategy is put on a condom, right? So you take the 68-year-old man, and he's been married for 35 years to the same woman, and he hasn't had a condom on in 35 years, and he's going to ejaculate an ounce of urine into the condom, that's not a great strategy, right? So we use a band, it's called a Eurostop, and it goes over the penis, and it's variable tension, okay? So it's not like a constriction band that's really tight, okay? It just has to be tight enough to compress the urethra. But it only works if there's a good rigid erection. You need a backboard against which to compress the urethra. If you have a good erection and you have climacteria and you use the Eurostop, you have a 90% chance of having no climacteria. It's a really effective strategy. However, for those men who don't respond to that or who don't like to use that, then there is sling surgery. For those of you who might have had an incontinence discussion with an incontinence expert, there's a surgical sling procedure which has been used in men with climacteria very effectively. They tend to be the patients who've had it long term, and it's just not going to go away.
Okay, now we're down to the rapid moments. Ready?
Yeah.
Do about 30 to 60 seconds per slide. So there's a lot of advertising in California for something that's called low-intensity shockwave therapy.
Yeah.
They go into the office. Sometimes they're paying a lot of cash. And can you explain what this is? And do you recommend it for erectile dysfunction?
So low-intensity shockwave therapy belongs to a category of treatments called restorative therapies. And that includes stem cell therapy, and includes a thing called PRP, platelet-rich plasma. And the Sexual Medicine Society of North America, the American Urological Association, say that these should be considered investigational because there doesn't exist enough literature to definitively answer the question whether they're really effective or not. Now, for the vast majority of patients, they're safe. There is some concern, not particularly with me, but there are some authorities who believe that using this in men who've got prostate cancer might reactivate cancer cells in the pelvis. Because what these do is they stimulate stem cell infusion into the penis. They draw stem cells into the penis. The bottom line is that there are 47 papers in the literature on Liswit as of last week, because we've just reviewed the literature. And there's not a single paper out there that the FDA would use to say, yes, we're approving it. It's not FDA approved. And the other side of the coin, of course, is it's cash business. So by definition, when you go in to anyone who's doing this, and by the way, most of the people who are doing it are not urologists, can you really get a balanced, fair discussion when you're churning out $2,500 for 6 sessions of shockwave therapy that's administered by a medical assistant in the office and you never see the doctor, right? So I think just be very cautious. The only thing it's really going to hurt most probably is your wallet. So I don't think it's in any way dangerous. But none of these restorative therapies have ever been shown definitively to be really good, and especially in the radical prostatectomy, prostate radiation, or the androgen deprivation therapy patient.
So the other thing they're advertising is nerve grafts, or they can do stem cells. This is all advertising in PRP, platelet-rich plasma. People get it for their shoulders. They get it all over the place. All these are going on in advertising. What say you about them?
Yeah, PRP started in the orthopedic literature. So I had a friend who was running the New York Marathon 20 years ago, and he tore his hamstring 4 weeks before, and he went to a very famous orthopedic hospital, and they injected PRP. Even in the orthopedic literature, the Cochrane reviews, which are like the holy grail of medical evidence, the Cochrane reviews show no evidence, demonstrate no evidence to that PRP is of benefit in soft tissue injury. So PRP, low-intensity shockwave therapy, stem cell therapy, in the same category. Everything I said is relevant.
Okay.
From a nerve grafting standpoint, that's really interesting. First of all, it's the minority of patients who have deliberate nerve resection, right? There are companies that are developing nerve grafts that hopefully will be used to go in at the time of surgery that are seeded with special growth factors, et cetera. So stay tuned. That's not dead yet.
That's getting interesting. What I want to ask you here quickly is that you also are a world-renowned expert in Peyronie's disease. Can you explain what is Peyronie's disease and why does it apply to the prostate cancer world?
Yeah. So it applies to the prostatectomy patient. So Peyronie's disease is a genetic condition that classically occurs in European Caucasians predominantly, where a man has acquired penile deformity. Changes in the shape of his penis, curvature, indentations, hourglass deformity, volume loss, length loss, etc. It can be associated with pain, it can be associated with erection problems, difficulty having sexual intercourse, and then of course the psychological response to the penile shape changes. It occurs in probably somewhere in the range of 8 to 10% of men in the general population. It is at least that common after radical prostatectomy. We see men who come in to see us post-prostatectomy. They come in for the first injection visit 8 weeks after surgery, and on the first injection, they never had Peyronie's before, and they have penile curvature in the office. It is quite remarkable. If people say to us all the time, well, it's the injection that's causing it. The injection allows you to see the hard erection, that the man can see that he's got curvature. We have many men who get Peyronie's disease post-prostatectomy who've never used injections, who are using pills. Okay? So it's not the needle that's the problem. There's something about radical prostatectomy that accelerates the onset of the condition in men who are predisposed to the development of Peyronie's disease. I think it accelerates the onset of the condition. If you have PD, then you should go see a urologist who specializes in PD. Most urologists don't do PD. They don't know a lot about PD. They don't really care about PD, and you're not going to get optimal care.
You said, I want to repeat this, that when you get a testosterone done, it should be a fasting?
Nope.
Not fasting?
Didn't say that.
But it should be morning, you said.
It should be early morning.
What are we defining as when to go in early morning?
Yes, that's an excellent question. So the AUA guideline says early morning without mentioning a time. We couldn't agree on a time. At my institution, it's before 10 in the morning. Why is that? There's a circadian rhythm. It's high, your T level is highest in the morning. It's lowest in the afternoon. There's a circadian rhythm up and down. Lowest at 4 to 8. So men who've got T deficiency, when do they start feeling tired? 3, 5 o'clock. Doc, I got to take a nap, right? Because their T is at their low point. Okay, so if you're going to get T tested, and by the way, I would say that every man, the US Preventive Task Force is probably going to go crazy when I say this, every man at 40 years of age should have a T level checked. Why? Because when you come in to see me at 65 years of age and you're complaining of symptoms and your T is borderline, it would be really great for me to know where were you when you were 40. And we just don't have that. It's never done. It's never done. So early in the morning, because of circadian rhythm, that circadian rhythm is blunted in older men, but we still check it in the morning limit. By the way, there is no menopause. Menopause is a moment in time when the ovary stops functioning, right? No estrogen production, 60% of testosterone drop in menopausal women. There is no such stop in time unless you have both testicles removed. There is no menopause. There is a time-dependent drop in T levels, 10 to 15% per decade of life.
Okay, early in the morning, and you define that. I still think it might be a fasting test one day, but we can argue about that.
In Europe, they have patients fast. The AUA guidelines does not require fasting.
I don't agree with that. Why not fast? There's been plenty of studies showing that if you eat a meal in the morning, it could, in a small percentage of cases, impact testosterone. I don't want to take the stage from you. We'll fight about this later.
We'll agree to
But you will be offered 2 types of testosterone tests or not by your doctor. He's going to want a total testosterone, and then someone's going to do their own reading and saying, wait, there's this other testosterone called free testosterone. Do I get one or both? Do I get free testosterone and a total? What am I asking for here?
Just a total and free. Get both. Because you could have normal totals with very low frees or vice versa because of how there's 4% of testosterone is supposed to be free. It's bound to proteins. Depending on the protein levels, then your free levels change.
But this is what's making me wacky. Okay, so let's just say someone's coming off ADT, they're coming off treatment, the doctor says, I'm going to pull testosterone. Then you're saying, even if their testosterone is low, 150, 175, they should still get a free to see how they're doing, right? Because that...
We're interested in the velocity of recovery.
Right, so it doesn't make sense just to do a testosterone by itself like many people get.
Total and free.
Thank you. My gosh, why are we making this so difficult? What the HE double toothpicks ever happened to female sexual dysfunction? There's so much off-label use I've been seeing in LA. In other words, they're using basically all these different types of drugs on women. Pardon?
Flavanserin, bremelanotide.
So I know there's a couple drugs out, but then you can give me your take.
Yeah.
And here's the interesting thing. Every time I read about these female sexual dysfunction drugs, some of them that are out there, they're like, oh, they're so great, they're not cheap. And then some of the side effects are headache, nausea, stomach ache. And I'm thinking, yeah, that's when I come to bed at night and I want my wife to be all excited that I'm naked. I want her to feel nausea. What? Isn't that counterintuitive? So can you tell me, did any of these really do anything?
Well, listen, so first of all, in the female sexual medicine space, there are hormonally based medications, selective estrogen receptor modulators, right? And then there's non-hormonally based, so drugs like flavanserin and bremelanotide, right? In the studies that were done with those 2 agents, there is a significant difference based on the endpoints in the trials in how women responded to those 2 drugs, okay? Definitively.
Okay.
The magnitude of the difference was not the kind of magnitude of difference that you saw in the Viagra or Cialis trials.
Right.
Right? Ultimately, it requires you to go speak to a doctor, explain your concern, and try the medication. You have side effects, you don't use it. You don't have side effects, it's working for you, you use it. It's a trial and error phenomenon for sure.
Okay.
What I thought you were going to ask me about the role of these drugs in men. So
yeah, that's the off-label use in LA for men. That's what
bremelanotide is a drug that potentially increases erectile function, libido, and flibanserin libido, and it's being used in men. There are no randomized placebo-controlled trials yet that answer that question. So it will be considered investigational, and I think these drugs are generally very safe.
Yeah.
Okay. Listen, you look up aspirin in the physician pharmacy directory, it's going to have all kinds of problems associated with it. So every drug has some potential problems.
So for you to finish tonight, when we give you your presentation or your gift, I want to play the Grazie game. Which two on this list are not really Irish? Okay, because we call him the Conor McGregor of urology behind the scenes. He's Mr. Irish. So all of these things are Irish except two things. Do you want to guess which two things?
I'm not going to guess. I'm going to tell you what they are. It's okay. Mark Scholz and it's Irish Spring soap.
Let's go to the next slide to see if he's correct. And he is correct. That is excellent. Irish Spring is not actually. Thank you. And now, should we bring this gift
Lucky
up
Charms,
here?
by the way. So. Yeah.
A lot of people think Irish Spring is Irish. It's not. It's all right. So I'm going to leave you with a quick story I've never revealed to this audience. So when I see him, when it's not a work situation, and I see him, there was a couple years ago. I want to reveal this story about our friendship. I told him I was so sick about hearing about sexual dysfunction. Nothing against it, but there's all these ads on TV. We're being hammered by all this stuff: sexual dysfunction, erectile dysfunction, all this stuff. I said, can we just take a break and you and I just go do something zen and just get away from all the poster boards and do all this kind of stuff? And he said, yeah, I'm going to take you to my favorite place. It's in the middle of nowhere in Arizona. And I said, all right, great. So we don't have to think about medicine. We don't have to think about sexual dysfunction. I don't have to think about my erections. He said, you'll love this place. So he brings a friend, and I go with his friend, and the two of us go in the middle of nowhere in Arizona. And he goes, let's take a photo. This is my favorite place. And I thought, I got to share this with the audience for therapy. I've had enough of these guys. So sorry, that was just, this poor guy's heard every joke in the book. Let's bring up his gift, and please, and you'll make announcements, and then we're good, right?
Well, you got to talk about this gift.
Okay, so this gift is, I told you at the beginning, I don't want to make his head too big. I'm saying nice things, but the reality is, to me, he's always been number one out there, and that's great. So we call him the GOAT of urology. So we got him a goat, and you can read what it says. It says, the GOAT, Dr. John Mulhall, BFF of Dr. Mark Moyad, PCRI 2025. You will cherish this the rest of your life, my friend. Thank you very much. Thank you to Dr. Mulhall. He'll be going across. Someone going to guide him to, all right, we can get a guide.
I just wanted to remind you that before we get to our next session, go ahead and visit pcri.org/2025-conference. Our exhibit hall has a ton of information in it that can really be helpful for you. You can find out resources about the different treatments that we've talked about today and so much more. So again, visit pcri.org/2025-conference. Now, go ahead and click subscribe to our YouTube channel because it's a great way to stay up to date with the latest and greatest. And if you would like to help us out and support all the work we do here, like presenting this conference for free, you can go ahead and donate at pcri.org/donate. Now, let's get to our next speaker. Dr. Robert Newton is the Director of Exercise Medicine at the Edith Cowan University in Australia, and he's been a personal friend of our moderator, Dr. Mark Moyad, for years. One of the things we really love about Dr. Newton is he's not just talking about exercise, but he's talking about the power of exercise in prostate cancer and how it correlates and affects not only your overall health, but the disease itself, and how important it is to pay attention to weightlifting and exercise. And I know we hear Dr. Scholz and Dr. Moyad talk about the importance of it all the time, but we're going to get more detail of why and how and what you can do to help you through this process. So without further ado, thank you so much, Dr. Robert Newton.
Well, I could tell you I've been to Australia 3 times, and I met this gentleman 25, 30 years ago. Has it been that long? He's 92, I'm 88. And, okay, so you heard what I said about Dr. Mulhall. Let me reiterate, because some of you may be new, and a lot of physicians are new to the exercise game. No one on the planet has published more in the area of exercise and prostate cancer on the planet than Dr. Newton and Dr. Newton's team in Australia. In fact, I'm trying to give you an analogy. It's like comparing LeBron James with a high school basketball player or a grade school player. They have done hundreds upon hundreds, 400 or 500 of these studies and papers, and the nearest behind them may be me at like 20. So the truth of the matter is we wanted to finally get him out here, but it's tough to bring someone from Australia. I'm glad they have representation. And he's been a friend of mine for a long time. So this is who everyone listens to in the physician world. So we thought 1 year we've got to bring him in so that you get to see this superstar. And that's Dr. Newton, who came all the way from Australia. Hopefully you're not too jet lagged. Come on up, mate, as we say in Australia.
Thanks, Mark. Yeah, we have been friends a long time, and it's great to be here, have the opportunity to come and chat with you today. Please bear with me. English, of course, is my second language, being from Australia. So I'll try and speak slowly. Australians have a really bad habit of speaking really, really quickly when they get really excited, and then no one can understand them, okay? So I'll do my best. So I want to talk to you today about precision exercise medicine in the treatment of prostate cancer. Exercise alters the chemical, immunological, thermal, physical environment of every cell, tissue, organ and system in the body. Different types and dosages have vastly different effects. We are generating endogenous medicine, medicine from within. Now, this medicine has developed over millions of years as we have evolved as a species, as an animal. And it works in perfect harmony. When we try and manipulate individual components of these endogenous medicines, and we're going to talk about a few shortly, it tends to have problems. Because when we change individual chemicals within the body exogenously by injecting them or ingesting them, it's like having a beautiful symphony orchestra, but there's one Aussie guy down the front playing a harmonica, okay? It just doesn't quite work, okay? Now, exercise oncology, relatively new field, and that's the application of research and clinical within people with cancer in the oncology field. So let's get going. We've got lots and lots to cover. So this is a very nice diagram here, originally from Kerry Cornier's lab and Christine Friedenreich, and it's covering from the initial cancer diagnosis here. I'm going to be speaking today entirely about post-diagnosis, not pre-diagnosis. But of course, exercise is very important for reducing the risk of anyone getting a whole range of cancers, including prostate cancer. But once you have that diagnosis there, we're then looking at the application of exercise medicine as a pre-treatment. So it's said to be neoadjuvant. It's a treatment which is provided to the patient before they receive their primary treatment. And I think a good example with prostate cancer is preparing the patient for surgery, for prostatectomy. And it's at this point, and I'll show you some of our data, where it's very much about increasing the resilience of the patient, perhaps to improve their body composition, bring down their systemic inflammation, so there's much less issues around their surgery. Their sexual health will be more likely preserved and continence preserved as well. Now, in treatment, we're using exercise as a medicine here. It's said to be an adjuvant treatment here, so it's supportive of the main treatments. And I think probably the most prevalent example, I think, in prostate cancer would be the use of exercise with androgen deprivation therapy. So here, this is where our group first started our work back 2 decades ago now. It was very much about addressing the side effects of treatment. With androgen deprivation, although exceptionally effective at slowing the progression of prostate cancer, as many of you will know, it has considerable side effects as well. And our group has shown that we can prevent pretty much all of those side effects with appropriate exercise medicine. We then look at post-treatment here, rehabilitation. Certainly it's used post-prostatectomy to help the patient regain their physical capacity and their continence as well. And it's said to be rehabilitative here. Now, the patient's now disease-free. It's very much about the survivorship phase here. How do we keep them healthy into the long term? Here it's very much about preventing the big one, that concern of recurrence. And there's excellent evidence showing that being physically active, doing targeted exercise, actually reduces the risk of all cancers returning, reduces the risk of recurrence. But of course, it's also during this time that's very important to reduce the risk of all the other diseases. All the other chronic diseases, type 2 diabetes, Alzheimer's, cardiovascular disease, they don't care that you've had cancer, right? Your physiology marches on. And in particular, as many of you will know, cancer and its treatment exacerbates the risks of many of these diseases. So exercise medicine, absolutely crucial here in the survivorship to prevent you from having a stroke or a heart attack, for example. Then we move into stage 4 cancer. Here, the disease can no longer be cured, and they're very much in the survival phase here. And the exercise is critical at this point because, not the least of which, we find that it is very important for maintaining quality of life in the patient at this point, trying to maintain as much physical function, allowing them to do as many of the things which they would like to normally do. But emerging evidence is also indicating that targeted exercise actually increases survival. It extends out survival even in patients with stage 4 prostate cancer. Now, this was data from a colleague of mine, actually, Stacey Kenfield, University of California, San Francisco, published way back in 2011. Wow, time flies. And this is a very interesting study. It's an epidemiological study here, and what they looked at was men with prostate cancer and how much physical activity they did. In this case, it was walking predominantly. And what they found was in men that did 3 or more hours per week of vigorous activity, had a 49% lower risk of all-cause mortality. That's not terribly exciting. We do know that anyone who is more physically active tends to die less of anything, and so that's not unusual. However, they also reported a 61% lower risk of prostate cancer-specific death. They found also that the more vigorous the activity, the better the survival advantage. So it's not as though just being physically active, that's important, but it does appear that you need a threshold. You need to have it more moderate to vigorous rather than your light, gentle exercise. And that was the first study to demonstrate it wasn't just whether you were active or not and how much you did, but also an advantage if it was more intense or more vigorous. Now, these studies, and there's many of them now right across the board, breast cancer, lung cancer, colon cancer, you name it, showing around a 40 to 60% survival advantage in patients who are physically active. However, you've got a bit of a problem there of reverse causality. We don't know in these retrospective studies whether, well, the people who were doing better, felt better, their treatment was working, their cancer wasn't as aggressive, they felt better, so they exercised more. They played more golf or they walked the Labrador more often. We don't know that it's not reverse causality. There's been 4 major studies in the world conducted as randomised control trials. These are prospective studies. So this is where patients are recruited and then placed randomly into either a control or usual care group versus an exercise intervention group. The first one here is the colon health and lifelong exercise, what's called the challenge study, led by Professor Kerry Cornier out of Canada there in colon cancer. The next one here, this is a study in patients receiving allogeneic stem cell transplantation run out of Germany. This particular study is the interval gap 4 study, which I run, myself and a colleague in Canada, Professor Fred Sard, so we're the principal investigators on this study. This is in men with metastatic castrate-resistant prostate cancer. And then the fourth one here is a study being run out of Australia, actually, and that's in ovarian cancer called the ECHO trial. These are the results from the challenge study. And this study was published in the New England Journal of Medicine, not not a bad journal. I'm yet to get a publication in the New England Journal, but hopefully before I retire I'll get one up. But it's obviously one of the leading medical journals on the planet. This was only published in June of this year. And what they found was, comparing the exercise group to the health education group, a considerable survival advantage in a randomised controlled trial. So this is the first study in the world which has demonstrated a causative relationship between exercise and survival. Now, this was groundbreaking enough, but they also presented the results at ASCO, the American Society for Clinical Oncology in Chicago, also in June this year. It's the largest cancer conference on the planet. And one of the slides that was put up was this one. And one of my colleagues grabbed a shot of it. This is adjuvant exercise from the challenge study in colon cancer, 7% survival gain at 8 years there. And this is a comparison with some of the leading survival studies in chemotherapy. And we see for different cancers there. Exercise produced a similar or superior survival advantage in a randomised controlled trial design as several of the chemotherapy trials. We're seeing exercise medicine as a multi-therapy facilitation. So if we have a look at hormone therapy here in the context of prostate cancer, this is androgen deprivation therapy, so drugs which are given to block the production of testosterone. Again, highly effective at slowing the progress. Hormone-sensitive prostate cancer cells require testosterone for signalling for growth. And what we see here is that exercise actually suppresses the cancer progression. It actually slows it down through a whole series of mechanisms which I'm going to explain. Importantly, as I mentioned earlier, the exercise for men on hormone therapy is absolutely critical to ameliorate, to reduce, to suppress the toxicities of the treatment. And we'll go through those. It also has a critical role for many men now are on intermittent therapy. So we used to just have continuous ADT and the side effects were problematic. So many of you will be on intermittent therapy where we'll give you a little bit of time off. Exercise is absolutely critical at this point because what it does is it helps the body to recover. It helps the healthy cells in the body to also to be more resilient and to overcome a lot of the toxicities that are occurring. In surgery, here we're using exercise extensively. In the case of prostate cancer, it's really to slow the progression of the disease leading up to the surgery. So generally, surgery for prostatectomy is generally not a big rush. It could be 8 to 12 weeks out, and it's an opportunity to intervene with the patient to improve their physical fitness so they'll do better under anaesthesia, to perhaps drop a little bit of body fat, increase muscle mass, and I'll present some of our data on that, and to increase their resilience, just to make them more resilient. And that's absolutely critical, both physically and mentally. Now, prostatectomy, okay, it's not a majorly invasive surgery, but it's still a surgery. Now, you wouldn't rock up to the Los Angeles Marathon not having trained, would you? You wouldn't say, oh, it's this afternoon, I'll give it a crack. Why not? You are unlikely to finish, but regardless of whether you finish or not, tomorrow and the next week you're going to be very, very unwell. You're going to be very sore and sorry and you're going to wish you hadn't done it. Surgery, preparing for surgery is just, if not more important than preparing for a marathon. You want to be mentally and physically resilient for it. We do have strong data to show that if you have a period leading up to the surgery where you do increase your physical fitness and capacity, you'll have less complications. There'll be less complications under anaesthesia, you'll have less risk of infection, you'll have less hospital stay, the whole works. And your rehabilitation, of course, is a critical application there, rehabilitating you post-surgery. I'm going to talk a bit today as well about the use of exercise medicine around radiation therapy and a whole range of reasons there to reduce hypoxia within the tumour. I'll come back and talk extensively about that. To enhance the immune response to the radiation and to reduce the side effects, in particular fatigue, associated with radiation therapy. For chemotherapy, again, has a critical application here, in particular to enhance the delivery We are now exercising our patients throughout chemotherapy. We're certainly exercising them immediately before they receive their infusion. In some cases, we're exercising them whilst they're actually receiving their infusion. And this is to deliver more chemotherapy agent, to distribute it more effectively through the body, deliver more chemotherapy agent deeper into the tumour tissue. Now, exercise has been used for the last 2 decades or more during chemotherapy, predominantly to reduce the toxicities. We know that patients that are physically active over the course of their chemotherapy will have less neutropenia, less peripheral neuropathy, less fatigue. There will be less of a dose reduction. So if the patient becomes too unwell, the medical oncologist will have to reduce the dose of chemotherapy given. We know that if the patient is physically active, they exercise, that reduction will be less. That means more chemo into the patient. It means more likely to beat this bastard. Sorry, that's an Australian term. I don't even know if I can translate it. This is a paper we published in Nature Reviews Urology, and this is when we first presented a series of 10 mechanisms by which exercise actually suppresses the growth and aggressiveness of cancer. And I'm not going to go through them all. The ones I'll predominantly talk about is beneficial myokine and adipokine profile, improved immune function, alterations in androgen receptors, reduced systemic inflammation, oxidative stress, and then changes in tumour vascularisation. There's a few others here around epigenetic and genetic modulation, telomere changes, and modulation of circulating factors such as insulin, growth factor, and sex steroids, but I'm going to focus on just a few over here. Now, this is a paper we published in Nature Reviews Urology in 2021. And here we presented the mechanistic role of exercise as a medicine in suppressing the progression of cancer. We learned about 15 years ago that our skeletal muscles, okay, the muscles that produce movement in our body, are an endocrine organ. They're actually pouring out a whole range of hormones and other molecules, peptides called cytokines, and those molecules are signalling to all the other tissues in the body. And this is a bit of a revelation because it helped us to understand why some of these chronic diseases progress. So, when we exercise, we produce a range of what are called cytokines. They're small peptide molecules. When they're released from muscle, we call them myokines. And they include IL-6, irisin, decorin, etc. Now, these myokines, in experiments in the lab, when we take living prostate cancer cells and we pour, for example, decorin over those cells, it causes cell cycle arrest. It reduces their proliferation. If we subject living prostate cancer cells in a petri dish to OSM, irisin and spark, it actually drives apoptosis. It actually signals to those cancer cells to die. It's a direct signalling effect. Now, of course, we have a yin and a yang because our muscle system also interacts considerably with our adipocytes. These are our fat cells. And our fat cells are also signalling and doing a whole lot of things. In the main, their signalling is cancer supportive or cancer promoting. That's one of the main reasons why we're seeing an increase in incidence of many cancers and why some cancers are becoming more difficult to treat. Simply because as a population, as a species, we're changing our body composition towards higher levels of fat and lower levels of muscle. The problem is it's creating an imbalance in this signalling here where the fat tissue is overwhelming the signalling coming from our muscles. Now, when we exercise, our body produces catecholamines, okay, adrenaline and noradrenaline. And they stimulate the mobilisation of a very powerful immune cell called natural killer cells. And they're mobilised into your bloodstream, and then under the action of a myokine called IL-6, interleukin-6, it increases their infiltration and their cytotoxicity. So this is a myokine which is actually, if you like, switching these natural killer cells on. It's ramping them up. It's making them super soldiers. Now, we also have the action of two other myokines, IL-15 and IL-10. They increase the proliferation survival of memory T cells, another very effective immune cell. And when we exercise, we increase our circulation and that forces more blood and more of these immune factors and more of these myokines into the tumour. And that is probably one of the key mechanisms by which our body actually internally produces medicine to suppress the progression of tumours. So let's talk a little bit about this muscle, fat and survival relationship. So this is a paper we published in prostate cancer and prosthetic diseases in 2021. And we looked across a large number of studies here to look at the relationship between fat mass and muscle mass and survival. Interestingly, we didn't find a very strong relationship between fat mass and survival. We did find a strong effect of low muscle mass. So having low muscle mass really compromises the capacity of your body to survive your cancer. So we then did a whole series of work to see, well, can we actually can we actually reduce fat mass but maintain muscle mass? And this was from work we did with one of our local urologists here. In Australia, about 2 in 3 men will be overweight or obese, and that's a problem when it comes to prostate cancer, in particular for surgery. And so we were putting these men through very rapid weight loss programs. But what we found was they also lost a lot of muscle mass as well. So we said, well, can we prevent that? This is very prevalent at the moment because a lot of our patients are also going on the GLP-1, GIP drugs as well, which are very effective for weight loss. The problem is 1/3 of the weight that they lose is actually muscle mass. And that's absolutely catastrophic for a person with cancer. So this is a 12-week intervention. We had a lot of aerobic exercise and we made them do resistance training, and we had a fairly large energy deficit. The good news is they got stronger and their fitness improved, so that worked. We also saw that most of the patients lost fat mass. On average, there was no change in muscle mass. That was a fantastic outcome. We're very pleased with that. However, that's not the full story. If you have a look at the individual patient data here, half the patients still lost muscle, which is a problem. So we're going to have to be a lot more sophisticated with how we actually prescribe medicine as exercise to prevent that. Changing tack. I want to talk a little bit about our work that we're doing around tumour vasculature. So this is the normal vasculature that you have in all of your tissues here. So you have your arterioles, your capillaries and your venules. It's nice and organised, it has good blood flow, and the tissues has good access to nutrients, immune factors and to oxygen. As a tumour develops though, the vasculature does not grow in that same organised way. It's very disorganised, it's very inefficient. The result is it has poor blood flow and has low levels of oxygen, has high levels of lactate. Now, that's a problem for a whole range of reasons, not the least of which it compromises the capacity of radiation therapy to work. One of the main mechanisms by which radiation therapy kills cancer cells is by activating oxygen and water to create quite radical oxygen species which are quite damaging to the DNA of the cancer cells and destroys them. If there's not sufficient oxygen available, that mechanism is compromised. The other problem, of course, with cancers that develop like this is it's harder to deliver chemotherapy. It's harder for the body to deliver its own immune cells as well into that tissue. So what we did is we had a look at this is a prostate here with a tumour. This is our MRI scan. And what we said, well, can we actually increase the blood perfusion through these tumours? And we put these men through about 10 to 15 minutes of just aerobic exercise. They were either stepping up and down on a little step, or they're riding on a cycle. And then we stuck them in the MRI machine. And this is at rest, and you can see the perfusion map here. There's not a lot of oxygenation and blood flow in the actual tumour itself. But what we saw here in some men was a 900-fold increase in the amount of oxygenation and blood through the tumour. What we're doing now is our recommendation is that our patients exercise immediately before they receive their radiation therapy fraction. Some of the clinicians freak out a little bit about that. It can be difficult because the guys will have a full bladder, so they have to drink As many of you, I'm telling you your own business here. Many of you have already done this, but of course, you're given fluids to drink to fill your bladder so that the radiation therapy can be done. We're finding that the men can exercise with a full bladder. A couple of radiation oncologists says, no, you can't do that. It interferes with my therapy, and the man's going to void himself on the table. And it doesn't work like that. Exercise actually reduces the urinary flow. So they're less likely to void themselves on the table. But anyway, we're working through that. A long time ago, I presented some of our work at a conference I think it was in the Gold Coast actually, in Australia. And I presented all my work on cardiovascular risk, the problem of ADT and heart attack and stroke. And, you finish these and you come down and people come and talk and say, oh, wow, that was great. Thanks, Prof. And a couple of the guys said, and their partners said, your talk was sort of semi-interesting, but you're not addressing the main problems. And I'm going, shit, that's another Australian term. Heart attack, sudden death from a stroke. I'm thinking this, didn't say this out. And they said, no. Urinary incontinence and sexual function. If I would have known I was going to end up like this, I'd rather be dead. I would never have chosen the treatment. So we went, okay, bit of a learning lesson here. And so we went off and we did a whole series of research, in particular around sexual function. Now, our latest research, which we published this year in JAMA, Network Open, was around exercise combined with psychosexual education to improve sexual function in these men. So these were men on androgen deprivation therapy. And what we found quite excitingly was a considerable improvement. There's a randomised control trial. So there was actually 3 groups: usual care, exercise only, and exercise plus psychosexual education. There was no effect or additional benefit of psychosexual education, so we pooled those people with the exercise group. Now, what we found, very encouraging, we had significant improvement in erectile function, in intercourse satisfaction, and almost an improvement in the EPIC in terms of sexual function. And this was quite meaningful for us. When we then had a look and delved down a little bit deeper, what we found was that those men with the lowest reported levels of intercourse satisfaction, sexual function, erectile function, had the greatest improvement. So that's quite important. So that's our finding from that particular study, which was quite exciting. All right, let's change a little bit, go a different area again. This is a paper we published way back in 2008. This is one of our early studies here where we're really looking at the side effects of androgen deprivation therapy, and we published this in the British Journal of Urology International here. And this is men commencing androgen deprivation therapy, 36 weeks of maximum oxygen blockade, androgen blockade. Now what we see is it works. Huge decrease in in testosterone, huge decrease in PSA, but huge loss of lean muscle mass, increase in fat mass, and also a great reduction in bone mineral density. These men are losing bone at a catastrophic rate, about 3 times the rate of what a menopausal woman loses. So, what can we do about that? Well, this was a study that we implemented here. This is exercise training which we called impact loading. So the men are doing marching, skipping, all these sort of things, okay? Now, don't go out after this talk and start jumping down the stairs, okay? What we did is with considerable preparation of these men, they did around 4 to 12 weeks of heavy resistance training to get them resilient enough first. So what do we find? This is a usual care group here, and over 6 months, in terms of their lumbar bone mineral density, they lost about 3%. That is a catastrophic rate of bone loss. But this was a group that did resistance training, so they were lifting weights. There was hardly any benefit, in fact, no significant benefit. It was only this group here that did a combination of resistance and impact loading that actually pretty much blocked that bone loss. So the message here is exercise is not a single medicine. It's many different types of medicine, and how it's prescribed and dosed makes a huge difference to the outcome. Many groups have compared resistance training to usual care and have concluded that exercise is ineffective for preventing bone loss in men on ADT. It's not the case. They just used the wrong medicine. Metastatic prostate cancer, I'll go quickly through this one. Look, survival for people stage 1 to 3 is quite good. But as soon as it metastasises to another part of the body, then the survival outcome is much, much worse. It's much harder to treat. So the recommendation back in the day was that these men should avoid physical activity. They have metastases. Most of those metastases will be in their skeleton. That's a point of weakness. So be careful. Don't do too much. Don't walk downstairs. Don't go outside. You might break something. Now, the problem with that recommendation was our oncologist said to us, guys, these men are not doing well. They're dying very quickly because they're being told to rest. We've totally rejected that rest strategy, but we said, well, how the heck can we exercise them without breaking something? And so we implemented this, which we termed our M3EP, for modular multimodal exercise programming, and we just exercised the bits that weren't broken. So we get a PET scan for all of our patients. If they have a lesion on their right humerus, then we just exercise the living daylights, another Australian expression, out of the other arm and all the other bits that aren't broken or aren't affected. Next thing, can they do it? Well, yes, they can. Very high attendance, no skeletal-related adverse events, no increase in bone pain medication. And they also responded quite well with improvements. I'm picking up the speed because I see I've only got 20 minutes left. Preclinical work, so animal work has come out, and this particular one, I'll just pick this particular one because it's in rabbits and I love bunnies. And this particular one here, what they did is they injected human breast cancer cells into the tibia of bunny rabbits, and they then suspended one of their limbs. So one of their limbs was loaded, the other one was not. And then they looked at how did the tumour actually grow. And what they found in the loaded animals, at 6 weeks, they still had 100% tibial integrity, where it was only down around 20-25% in the non-loaded. And when they looked at tumour growth, they had very little growth of the tumours in the loaded condition, but massive growth in the unloaded. Now what's happening here, of course, is that when we move and we put stress on our bones, there's cells in our bones and they signal to each other electrically and chemically. And what it appears is that those signals are also signalling to the cancer cells, hey guys, let's settle down here. Let's just stay cool, okay? And that's what's happening then. So what do we do about that? Well, okay, maybe we should be loading these guys and loading the sites of their bone mets. But we have to be really careful because it is a possible site for fracture. And so we did 2 studies, one in breast cancer with osteolytic bone metastases, the other one in prostate cancer. And I can't present the actual growth study because we're still analysing the MRI. We hope to submit that this year for publication. But what we saw in the men with prostate cancer, you see there, we had no vertebral compressions, no change in bone pain or fragility fractures. But what we did was isometric contractions. So they were doing exercises like planks and side planks, etc., where they were just putting some controlled isometric compression on the site of their bony lesion. They had no problems, no serious adverse events, and none related to the exercise program. I talked a little bit about the study, the Movember funded interval gap 4 study right at the start there. So this was the first RCT in the world to test if exercise medicine increases survival in patients with metastatic castrate-resistant prostate cancer. It's a worldwide study in 10 countries. And this is the protocol paper here. We implemented an intense exercise program. This was heavy resistance training. We used aerobic exercise, including high-intensity interval training. This was intense. These guys have metastatic cancer. At this stage, back then, their median survival was 33 months. We programmed or powered the study to try and push that out to 40 months. Okay. It was auto-regulated, which means that as they turn up on the day, we adjust the dosage of exercise medicine they receive. It was periodised, which means the exercise changes over the week, the month, and over three monthly periods as well. Now, all I'm going to present today is the safety data. We had no serious adverse events, none which were related to the actual exercise trial. We had 49 exercise-related adverse events, which were mainly muscle strains, bit of muscle soreness, etc. They were all less than grade 3. So it appears at this stage, high-intensity exercise, when it's well monitored, this was supervised by exercise physiologists, appears safe even in men with advanced metastatic cancer. Now, let's change tack a little bit here. We took some blood from these men at this first point when the baseline started. We then took it again at 6 months. We extracted their serum and we also put them through body composition analysis using dual energy X-ray absorptiometry, which is the gold standard for measuring muscle and fat and bone. And we looked at their circulating myokine levels. We also took their serum, so the liquid part of their blood, and we poured it over living prostate cancer cells, and we looked at how well they grew. What we found was at 6 months, there was significant elevation of these anti-cancer or cancer suppressive myokines. This is at rest. So the 6 months of training they've done has actually altered their internal chemistry to be more suppressive of the cancer. When we took their serum and poured it over these living prostate cancer cells, we observed a 20% reduction in rate of growth. This is at rest. We then said, well, okay, well, what happens if we give them an acute bout of exercise? So we got them in again, and we put them through 44 minutes roughly of high-intensity interval training on a cycloergometer, took blood pre, immediately post, and 30 minutes later we did our same cell studies and cytokine analysis, and what we saw again, lovely elevation of myokines, particularly immediately post-exercise, and we also saw a significant suppression of the cancer cells using the blood taken immediately after exercise, and even 30 minutes later. So, training long-term creates a more cancer suppressive environment, and every exercise bout that you do gives another surge of anti-cancer medicine. We're now moving, based on this enormous volume of research which is now being completed, we're moving to now a level of precision exercise oncology. So our first recommendations 20 years ago were just do anything, just as long as you move, don't be sedentary. That's still the key recommendation. All right, if you sit on the couch watching Netflix, you are putting your body in a very difficult position for it to be able to fight your cancer and for you to be able to tolerate the treatments you receive. Any movement is better than none, more is better than a little, okay? But we can be a lot better than that. So precision exercise oncology applies extensive biological, health and fitness assessment, integration with wearable sensors to deliver a dynamic, individualised exercise prescription. Exercise is treated now as first-line therapy. Wow. It's first-line therapy because of the challenge study. We now have an RCT in a large number of patients that shows it has a direct causative effect in increasing survival. The prescription is constantly adjusted to optimise cancer suppression, enhance survival, improve the effectiveness of other treatments and reduce their side effects. So we are now undergoing extensive, comprehensive assessment of our patients. A whole range of things, and this is too small on my screen, I can't read any of these, but it is the entire spectrum. It is their radiology, it is their immune system. We are looking at all their blood markers, we are looking at their genetics, their epigenetics, we are looking at their microbiome, both mouth, gut and skin. We are looking at their psychology, what is their status? Because all of these things impact everything else. So we assess, we then prescribe a tailored exercise intervention. All right, the current guidelines in the countries around the world, America, Australia, is all patients with cancer should do 75 to 150 minutes of exercise each week and 2 or more resistance training sessions and some balance training, okay? That's okay if you're doing all right and you're pretty damn healthy, okay? But a large number of patients find that absolutely impossible to fit in. The other aspect to it is they've got a lot of other stuff going on. So we're looking at doing the assessment and then prescribing, instead of a generic recommendation, a highly targeted exercise prescription. And I'll show you an example in a moment. With continuous monitoring, it's not, oh, good luck, I'll see you in 6 months. No, it doesn't work like that. We have to continually monitor the patient. So here's a body composition example. One of the key assessments which we do, which I believe is absolutely critical, and I have no interest in the companies, I don't own a DEXA, I work at a university which has a DEXA, but I don't own it and I don't make any money out of it, is to assess body composition, muscle, fat and bone health. So you've got a patient comes in, they've got prostate cancer and they've been on ADT for 5 years. Their BMI is normal or they're overweight. So you go, oh, okay, that's okay. But the DEXA indicates that they're pre-sarcopenic. They have exceptionally low muscle mass, and this is very, very common in men that have been on ADT. Interpretation, their overall cancer and specific mortality risk is much, much higher. They are at risk of frailty. They have poor treatment tolerance. They are at huge risk of diabetes and cardiovascular disease. We have to prioritise muscle hypertrophy in terms of our intervention. Nothing else matters. Forget about all the other stuff. Aerobic fitness doesn't matter. Being a little bit overweight doesn't matter. Don't worry about it. All right? The low muscle mass will kill a patient long beforehand. And so what do? High volume resistance training, large muscles, compound movements, accentuated eccentric. Okay? Maybe tomorrow, we're going to go through all this tomorrow. Make sure you come to my session tomorrow. Mark's actually paying me based on how many people turn up. Periodise, we talked about that earlier. Protein and energy supplementation. Limit aerobic exercise. We may do no aerobic exercise because it compromises the body's ability to grow muscle when men are on ADT, and look at recovery strategies. Another application as well, we're using exercise priming. I talked about this a little bit when we looked at radiation therapy. So this is using real-time monitoring. We use a lot of wearables on the patient. We're monitoring heart rate variability, heart rate acceleration, temperature, O2 saturation, and a whole bunch of other metrics. We then optimise the priming exercise to the individual based on their prior assessments and how they respond on any particular day. This enhances tumour perfusion, reduces hypoxia, and activates their immune cells before they go into the LINAC, the linear accelerator. Now, why? This increases the oxygen enhancement effect. It delivers more of the radiation sensitizers if they're getting that drug, have greater immune response, and it protects the normal tissues. You have a much better effectiveness of the radiation therapy and much lower side effects. Next example, we're using this extensively now as well, ubiquitous monitoring, the early warning system. So this is looking at alterations in physical characteristics in terms of activity. How much the patient is spending time seated, moving, vigorous activity. What is their sleep quality? These things reflect very, very subtle changes in the patient's health. This could indicate disease progression, treatment toxicities accumulating, or mental health issues starting to overwhelm them. So we're monitoring using the wearables into an app, pumping it up to the cloud for AI to analyse it, look for very subtle changes in pattern recognition, to look for any downturn, and then to raise a red flag, and then you can call them in for some more investigation, blood test, radiology, whatever. The problem we have is that the patient doesn't really notice too much that they're starting to actually slip. Oh, no, I'm seeing Dr. Moyad in another 2 months, I'll wait till then, okay? This continuous monitoring allows us to intervene before then if there's something going wrong. So we've been doing this in Australia for some time now. The last 5 years we've really ramped it up, working with a company FitMed, which we've established. We're now in Australia, Singapore and the UK. Got a good announcement in a minute. And it's very much about bringing this precision exercise medicine approach to the patient. But we also incorporating the other 2 pillars, which are absolutely essential in supportive care, being nutrition and psychology. And the final one is patient education. An educated patient is a much more successful patient. I'm really proud to announce today that on September 18, we'll be launching FitMed in the United States. That launch will be at the New York Stock Exchange. We've been listed as a finalist in the Garmin Health Awards. Now, we use the Garmin. I've got an Apple Watch. This is not being recorded, is it? Oh, that's good. That's all right. I've got an Apple Watch, which is very good as well. But the work that we're doing with our patients with Garmin, we've been listed as a finalist there. So fingers crossed we'll get the gong on the 18th of September. But of course, that will be when we'll officially launch FitMed in the United States. If you're interested, you can pre-register. There's a QR code there that you can scan, also a website as well. And I want to finish with a shameless plug, but Dr. Moyad said it'd be okay. So I'm very proud to launch today my next book at the PCRI conference 2025, My Exercise Medicine for Cancer, and you can pre-order on Amazon. I'm also pretty active. I try to stay active because my university tells me I have to, on social media. So there's my Instagram, LinkedIn and Twitter accounts, and I go by the handle at Prof. Rob Newton. So thank you very much. I've deliberately left little time for questions because I don't want to get grilled too much by Mark. Thank you very much, everyone.
Bring up my first slide, please. Are you heir to the Fig Newton? Are you heir to this?
No, I'm not, but I'll tell you a very quick anecdote. Is when I've lived in the US quite a number of times. I lived in Indiana for a while.
Ball State
University. And I went into the bank and I said, I want to open a bank account. And they said, yes, certainly, sir. What's your name? And I said, it's Robert Newton. And they went, what's your last name? Newton. And I went, is that with an L? I went, no, it doesn't got an L in it. And they said, how do you spell it? Newton. I went, like Isaac Newton. And she went, like, who the hell's that? So I said, Fig Newton. Newton. Robert Newton. So now and for the rest of my time living in the States, what's your name? I go, Rob Newton. Sorry, Mark, you wanted to ask a question. I'm just trying to stall.
That's all right. Quickly tell the audience about 10 to 11 tomorrow. Can you tell us in 20 seconds what you're going to be doing from 10 to 11? It's not a straight talk. Tell them what they're going to see.
So what we're going to do is go through some actual exercise protocols. Don't worry, you don't have to exercise, but what I'll be doing is taking you through what sort of prescriptions we would give to a man with low bone density, for example, to a man who has low muscle mass or someone who has metastatic prostate cancer. What do the actual protocols look like?
Yeah. Whose idea was that, to do a Sunday morning session separately? What?
Yours.
Yeah, exactly. Exercise, I thought you said extra fries. Does refusing to go to the gym count as resistance training? I don't know. I've known him 30 years, but still, we all try to say we practice what we preach. You know that I practice what I preach. I don't know if he's kept up with exercise or not. So in the morning, this morning, I know he likes to work out early in the morning. I snuck into the gym and I took a quick photo of him. Can you show that photo? Yeah, that's looks a lot like Dr. Mulhall, but it's not. It's different. So I think that's exceptional. You have an exceptional tone to your buttocks. I appreciate that. If you don't think my wife and I work out, please show the next slide. Yeah, that's me. How do you like that? You like that? All right, so I want to introduce you to the United States. I know we're going to run a little long. It's our presenter who's come the longest way in the history of this conference, so I have to go over to be in deference to you. That's okay, we'll get through this really quickly. I want to introduce you to the United States. Let's start with let's introduce you to Las Vegas. Next slide. That's the exercise slot machine.
Yes.
As long as you're willing to pedal, you can play the machine. The moment you stop pedaling, the machine shuts off and you lose your money, and therein lies the incentive. You don't have to comment on it, I'm just showing you. If you don't know much about Californian exercise, I think this is a good welcome to California, where we have 24-hour ironic fitness centers.
Yes.
Right? This crowd's easy. We give out free booze.
I warmed them up for you.
My favorite slide for you to answer this question, because I looked it up in Australia, and this is a big deal. Next slide, can you please comment? Dr. Newton, is pickleball considered a form of exercise? You're allowed the choice of no way, no, maybe, yes, but only because I'm terrified of upsetting the pickleballers. Definitely.
Definitely. It's movement, it's good.
That's
pickleball's good.
All right. We'll talk afterward. I do want you to comment on this. You and I have never talked about this through all the years that I've known you since the pandemic. We've talked a bunch of times on the phone. I want to show slide 8. So this was done at Kaiser, which is a large hospital chain here. And what they found, one of the largest looks, they found that other than advanced age and a history of organ transplant, physical inactivity was the strongest risk factor for severe COVID outcomes. And then they showed with COVID vaccinations and other vaccinations that it enhanced the effect of the vaccine.
Yep.
So I don't know what happened in Australia, but we never got to the point here. We were recommending all these things, masking, doing all this, but we weren't coming out and saying, exercise can't hurt, might help, and certainly might make our medicines work better. So I don't know if you have a comment on infectious disease, COVID, or what you did in Australia, but I felt like we lost a chance there.
Yeah, it's a really good point. We've got actually one of the top exercise immunologists in the world, a guy by the name of Dr. John Campbell. He's at the University of Bath in the UK. He's actually with us for 6 months on a sabbatical. This is a key one here. If you're going for your COVID or any sort of vaccine, you should exercise immediately beforehand. The reason why is it activates your immune cells, so that when you receive the antigen, it actually makes it more effective to respond. It also reduces the side effects that you might have as well. Being physically fit gives you a much better immune response. Exercise is the best way to supercharge your immune system, and that's why it's so effective against cancer. That's probably the major mechanism by which exercise settles cancer down, because it just helps, it actually turns your own immune system on to help it say, guys, okay, I know you're here, I know you're upset, but let's just chill out a bit. And that's the sort of signalling that goes on, and that's very important.
Okay. Next slide. This is a trial done in Canada. It got a lot of attention, one of our main medical journals. You and I cited this in one of our recent publications. They took a bunch of men on active surveillance. Some of them worked out several times a week doing high-intensity interval training. The other ones did not work out. They think they saw an anti-cancer effect, but the most interesting thing of all, in the next slide, was this should have been front row. This should have been front page in the United States, but it wasn't. So what else did they find in these exercisers? They found that it reduced their anxiety, it reduced their fear of progression, it helped their hormonal symptoms, reduced their stress, helped their self-esteem, and reduced their fatigue. But other than that, it didn't do anything.
See, bloody exercise is useless.
And so I don't know if you have to comment, if you're seeing this kind of mental health effect in your studies. I mean, this would be breaking news if it was a frickin' drug, right? But this is just exercise during prostate cancer.
Yeah, look, we've just finished a very large trial in men on active surveillance, and it follows up a lot from some early work was done by Dan Ornish. And in that study, what they did was they put men with early stage disease, recommended to active surveillance, a lot of exercise, but they also put them on a vegan diet. That's a bit tough, I couldn't do it. And they gave mindfulness meditation work as well. Compared to the control group, they had hardly any progression of disease. And so the men didn't have to move on to active treatment like prostatectomy. We followed it up with a very large study. We've seen the same thing. If you are physically active, the body's own medicines kick in and they hold the disease down, they suppress it. A lot of work being done now about, let's not try and kill the cancer here, we're just pissing it off, okay? We're upsetting it. Well, don't stab the bear, poke the bear. Exercise seems to put the body's own mechanisms in place to negotiate with the cancer cells and say, hey, come on guys, through various signalling. So what we saw again was much lower proportion of men on active surveillance. If they did our exercise program, much less likely to progress. Mark's made a really good point. If your mental health's not good, it doesn't matter what treatment you get and how it goes, the outcomes are still going to be bad. And the most important thing is to maintain quality of life and mental health. It's a bit of a no-brainer that with your exercise, that your mental health will be better. One of the largest studies done, particularly around depression, that's very common in men with cancer, is they found a 60% reduction in clinical depression in those men that lifted heavy weights compared to those that received routine MD care.
This is one of your studies from your group. You can see he's the final author there. And this was one I started using since 2017. And the kind of concept was here, men on androgen deprivation, if they did aerobic exercise and just lifted a few times a week, and they did just these 6 exercises. So what I'm seeing here is you're just doing a couple exercises lower body, below the belt. You're doing another 2 or 3 above the belt. So you're doing legs and arms and chest. This is very simple. This would probably take me 30 minutes. I don't know.
Almost, yeah.
Right? And you're seeing this dramatic effect in the reduction of side effects. And so my question is, when you recommend the amount of lifting, is this something as simple as this? They just have to do these 6 a couple times a week to get these benefits? I mean, you continue to see these few lifting exercises will give you those benefits?
First off, we've had too much of an emphasis on cardio exercise, cardiorespiratory aerobic exercise, so getting out for long walks and things like that. It's still important, but we have to emphasise resistance training more. One of the major factors we face with cancer is loss of muscle mass. All right, now as we've seen, our muscle mass is our drugstore. If you have a small drugstore, you can't produce a lot of medicine. You want a big Walgreens, okay? Yes, look, this is fantastic. It's great and it works. We're at the stage now, though, with precision exercise oncology where we figure out what's going to kill the patient first and then focus on that. If it is low muscle mass, we'd ramp up those exercises. They do more, less emphasis. As an overall prescription though, in general, generic, this is very good and it works. Okay?
Yeah, I like it because this is what I use because it's quick, it's simple. You're paying attention to upper and lower body, not just focusing on one or the other.
You don't have to spend a lot of time. You don't have to spend an hour, 2 hours in the gym. Who's got time? I don't have time for that.
Yeah. So I want you to now go to slide 17. We're going to finish up here in a moment, but I decided to make you a master slide for the audience. And I know this looks overwhelming, but these are 30-minute answers because I thought in my head, if I'm sitting in that audience, what do I want to know if I don't know much about this? So I'm going to take you through each one and just give me your quick...
I could be really cheeky and say get my book because it's all covered in my book.
Yeah, no, the book is fine. We'll make sure we get the book. I'm sure... Wait, did you acknowledge me in the book? Jesus, criminy. I changed my mind. Don't get this book.
I'd like to announce at this time how important it is, and I'd like to ask Dr. Moyad. 30 years
of friendship. I published with him just recently. We published an incredible article.
Mark, would you write the foreword for my book?
Oh, that's very sweet. That feels a little forced. Anyway, okay. Let's go through this. Ready? Yep. I'm going to give you what I would be thinking when I'm flying in the airplane and I see source, Moyad's brain. Breathing. Please tell me. Well, first of all, I know if I'm lifting weights, I don't hold my breath. There's too much intra-abdominal pressure. Say hello to a hernia and all sorts of problems. The idea, and this happens all the time as we get older and we get more frail. And when I'm exhaling on exertion, right? Yep. Can you give us the quick exhale on exertion, inhale on?
The lowering, yes.
Okay, that's important. Okay, I only have 1 or 2 days a week to lift weights or do special. Let's talk about lifting weights. If I want to do them Monday, let's say I lift weights on a Monday, do I have to take 3 or 4 days off? What if I only have Monday and Tuesday free? So that's why I call it consecutive versus non-consecutive. Some of the trainers tell me you've got to take 2 or 3 days off between weightlifting to let muscles heal. Other ones tell me that makes no difference, just put the time in.
You need 48 hours between exercising the same muscle group. So just do upper body on Monday and do lower body on Tuesday. Ideally, you want to stimulus each muscle twice a week. So that's preferable that you hit each muscle at least twice a week.
Okay. So you're recommending number of days a week of lifting, 1, 2, or 3? You're recommending... I don't want to do more than 3. I 2
or more. 2's a minimum.
Okay.
You can do a total body workout on one day, say on a Monday, and you can do the same total body workout on a Thursday or Friday. That's fine.
Do you recommend your lifting exercises be done after your aerobic workout, before your aerobic workout, or not even on the same day?
Just make sure you do them.
So it doesn't matter?
Not really, no. It matters to an athlete, but not for the rest of us, it doesn't really matter.
And do you like to see the lower and upper body exercises combined on the same day, ideally, just to get them? I think when I go to the gym, I find that a lot of people just focus in on either upper or lower a lot of times. And I find that frustrating. Like they're missing out on the benefits of whole body exercise.
Given time constraints, if you can only lift weights, now everyone should be lifting weights twice a week. Sorry people, that's just the way it is. So what that means is you're going to have to do a total body workout on each of those days. You have to provide 2 training stimuli to each muscle group per week. So if you're going to do a whole body workout and you've only got 2 days, you have to do it.
Okay, that's fine. I just wanted to...
But it's not a problem. A lot of my patients will resistance train 4, 5, 6 days a week. Okay, but then they split the program up.
Do you reckon...
We're covering all this tomorrow. We don't have to do our session tomorrow.
No, we'll have to do the session.
No, we could go to the pub.
We definitely have to, because we have to work...
It's Sunday.
I know, but you have to work on my acknowledgements tonight. If you had your druthers... If you could pick for a prostate patient, would you pick them to do free weights, Nautilus, resistance band, Pilates? I mean...
Definitely not Pilates.
No?
No, look, Pilates is great for some things. It just doesn't provide enough stimulus to the muscle. It provides 0 stimulus to the bone.
Because
so if your issue is muscle and bone loss, Pilates is just a nice chance to spend some time with some nice people.
But my wife officially doesn't like you right now. So, but it's also, they're on a drug, they're on a treatment that's accelerating muscle loss. They have to really go after it. So would you say if I had to tell prostate cancer patients free weights is prime, if they could ideally do free weights?
Ideally, if they could do free weights, but that takes technique and a bit of learning.
Yeah.
I always start them out on machines.
Okay.
First, the pin-loaded machines.
Okay.
Resistance bands are good if you've got nothing else you need to exercise at home. But again, they don't produce much feedback and a lot of stimulus. Okay. And let's avoid the Pilates.
Heavier, less reps, or lighter. In other words, when I'm lifting, am I looking as I increase my strength to go to heavier and heavier weights, or am I just keeping low amount of weight and just doing more reps? I get worried that as men get older and women get older, as they try to increase the weight more and more, they increase the risk of injury. So I've also been told that I just should do more reps with lighter weight until I feel fatigued. But how do you feel about that?
No, I mean, in our prescription, we'll generally have our patients, it doesn't matter whether they're a 30-year-old man with testicular cancer or an 86-year-old woman with ovarian cancer who's I have to convert it, 40 kilos, what's that, 80 pounds sopping wet. We still have them lifting weights that they can only lift between 6 and 12 times. It has to be heavy, but it's all relative. Now, we always have 1 to 2 reps in reserve. So you don't lift the weight until you go, oh, the brain's going to explode. There's no point in doing that. You stop a couple of reps before that. Okay, that makes sense. Okay, I want to look cool at the gym, so do I buy a lifting belt and wear gloves? Do any of these lifting belt or gloves, do these... You have to have spandex. Yeah, I have spandex too. I look incredible in spandex. So lifting belt... And keep your wallet in your front. I don't need to do that. Well, some of us do. Well, I know you do. I've seen you naked. Anyway, so lifting belt or gloves? No, seriously, because these guys come in with these belts. Do I need to buy these belts? No, you don't need a belt. It's preferable if you wear pants. Okay. Touché. Okay, should I stretch before I lift or stretch when I'm done lifting? Stretch after. So I don't need to stretch before. But why stretch after? Just because it tightens up? Well, it's a good time to recover and rest, and it's, your blood pressure comes back down. It's a good time. Your muscles are nice and warm, so it's a good time to stretch them. You don't want to stretch them at the start when you're cold. Okay. You do a warm-up, of course, so you might get on and do a little bit of aerobic exercise for 3 to 5 minutes just to warm the body up, but then you're into it. Okay, we got 2 minutes and 40 seconds. We're going to cover all this tomorrow, Mark. No, I got 2 minutes of... No, this is the time where everybody's here. No, but it's the time of the beers. I know. This is more important than beer for a few minutes. Oh. Sorry, for only a couple seconds. Who votes that it's more important than beer? One person. So I know what you've been saying. You actually think all these treatments work better if we exercise around them. Radiation works better. This ADT works better. I know you feel strongly about that. We talked about mental health. You used to write about hand grip strength. Can you tell the audience what hand grip strength is and why someone should have it measured, or do you not recommend that anymore? Look, it's in what's NHANES, okay, which is the National Survey of Health. It's in there for a predictor of sarcopenia. Okay, sarcopenia is a major problem facing most of the planet, which is low muscle mass. Okay, it's going to cause enormous amount of disability and frailty and cost to us, the taxpayer. And one of the ways to assess that is with simple hand grip. Okay, so it's nice and easy to do. Does it reflect your whole body strength? No, not really, but it is a rough indicator as well. Yeah, because some of the doctor's offices have them now where you test it. Okay. Particularly in men where your testosterone's dropping. If your testosterone's low, we do see that the forearm strength actually is highly reflective of lowered strength, and that's why it's a good canary in the coal mine. After I work out, I live in California, I always want to do something cool, so do I take a cold plunge? Or do I just take a whirlpool bath? Does any of that help if I do a cold plunge or whirlpool, like anything like that afterward? Look, I do whirlpool, I do hot baths and magnesium baths and things like that, because it's a good time to sit with my wife and talk about life. Okay. And we go to a nice gym as well, and there's a lot of younger people there, which is always, it's something to watch. And I also do the cold plunges as well. It does have no benefit in terms of recovery. Okay, the research is it does not facilitate recovery. In fact, it actually dampens the capacity of your body to grow muscle.
Thank you. That was a setup, and I've never talked to you about it. See, everyone's not looking at the research. I don't do cold plunge
You're just
either.
trying to get back in the acknowledgements.
I don't do cold plunge either for a variety of reasons. Plus, if you do cold plunge, it gets cold down here.
Why do you worry?
So all I'm telling you is people don't realize that some of the signals after you work out, evolutionarily, right?
Yep.
The signals, I mean, how does your body know you're working out? There are signals sent from the muscles, and some of those are suppressed with cold.
Absolutely.
And so people should know that. It doesn't mean that people shouldn't do it. It just means that we're not seeing an enhancement of exercise. All right, that makes me feel better.
Snap pop test. What's the number one strategy for recovery? Oh, you already knew. Have you read my book?
What's the number one strategy?
Sleep.
Okay. But you get better sleep when you exercise.
Yep.
Okay. So protein, are you a big fan of this protein environment?
No.
Get more protein as you get older, or is the recommended daily allowance right now? Fine. So let me just put it in quick terms. The recommended daily allowance in the United States is about 0.36 times your weight. So if you take your weight, 0.36, that's how much grams of protein that's recommended. In the metric system, which my 5th grade teacher told me we'd be moving to any day now in the United States, which you've moved to, it's 0.8 grams per kilogram of body weight, right? What do you recommend for protein amount?
For our patients, we recommend between 1.2 and 1.6
so a little bit
grams
more
per kilogram per body weight.
Okay.
I want to point out, I just reviewed a position statement for the American College of Sports Medicine, and extensive review of protein supplementation and resistance training for growing muscle.
Yeah.
And they concluded that 90% of the stimulus to grow muscle is lifting weights. Okay? Only 10% or less is actually what you eat. So people who, you see the bodybuilders sitting there worrying about their, what's in here and what's in there and how much they're doing it and timing and everything like that.
Okay.
It's so small in terms of impact, you wouldn't worry about it. We do supplement protein. All of our patients that we're trying to build muscle, we supplement them at between 1.2 and 1.6 grams per kilogram per body weight per day.
So what he's saying is it's a little bit more than the recommended daily allowance in the United States.
Definitely more than 0.8, absolutely.
So that's interesting. That's interesting. Some people say that what you're saying by maximum is you take your weight, you divide it in half. So if you're 200 pounds, you divide it in half, you're 100 pounds, and then you add a gram to there, so it's 100 grams maximum you should get. So you take your body weight, divide it by half, that's the number of grams you should get maximum. That's maximum. Okay, so that you're kind of leaning toward that end. Okay, you did a study last year.
I just want to put a caveat on. Check with your doctor, okay, and your dietitian, because certain issues and conditions will mean that you may not tolerate that amount of protein.
Okay.
99% of you will, but if you do have kidney issues or some other conditions, then that level of protein could be problematic.
You did a study last year that you published it, you sent it to me, you studied men on prostate cancer treatment, ADT, and one group did creatine supplementation and the other. What did you find? How much did creatine help these men or not?
In that particular study, we found no benefit of the creatine. However, there was a flaw with the study. Creatine helps you to do more work during a session. We fixed the amount of work that they did. That was a flaw. That was my fault. Okay? The reason why you take creatine is it gives you more energy, and so you can complete more reps. Growth of muscle is determined by what's called volume load. Volume load is the number of exercises by the number of sets, by the number of repetitions, by the load lifted. So if you lift 10 tonne during your workout, that's an indication of volume load. We know if you take creatine, that 10 tonne, you may be able to lift 11 tonne. That is a stronger stimulus for your muscles to grow. It was a problem with the design of the study. Having said that, there is now very strong evidence coming out that creatine is very supportive of cognitive function. And so I recommend my patients, and I also take creatine daily as well, mainly for the cognitive benefit.
We can agree to disagree, but creatine at least is cheap.
Cheap, yep.
Creatine
and it has no side effects apart from a bit of fluid gain.
But I think you use creatine monohydrate. I think you use that. Okay. So that's the cheap one. That's good. That makes me happy. Oh, by the way, I didn't ask you the one question. When you lift in the United States, there's two types of lifters. People that yell and scream like they're having a baby or something. And then the other ones are very quiet. You see these guys in really tight shorts. They're like, ah! And then these other people that are kind of saying, you can do it. They say all these dumb things like, you can do it, you're the man, you can do this. And it's really obnoxious. Do you support that or more quiet lifting?
I'm a fan of quiet lifting.
Thank you.
Yes.
I want to show you when people tell me, have told me for 30 years, why don't you hear more about exercise and diet? See, in my world, your physician does hear about it. It depends where they look. This is a paper that we did in 2016 for androgen deprivation patients. It's been downloaded by physicians, I believe, 10,000 times. Okay? So these are physicians all around the world. Now go to my next slide, please. These are all open journals that anybody can get. We just published this in SIU. So you can see that I'm the first author because I'm just more important than Robert. But Robert's the senior author, which means he oversees everything, so I've got to answer to him. But my real point of this ran #1 the whole summer for physicians to download on what to do. So when I hear that physicians aren't paying attention to this, I don't know where people are looking. The physicians are watching this. So that's important to just get in there. So before you answer, this is the shake weight. I went to Catholic school for 9 years. And the nuns told me that if I did this, I could lose my sight. So I don't personally use this. Do you use this? Do you recommend it?
I've normally got an answer for everything, but I'm dumbfounded, Mark. I'm sorry. I got no response.
Okay. All right, my last 3 slides, and I'm going to let you go, and I apologize, but again, he came so far that let's play Moyad says it this way, Newton says it that way. All right? Good day, mate.
Good day, mate. How you going?
Yeah, there you go. Put another shrimp on the Barbie.
No. No one ever said that.
No? Wanker.
Yeah.
But you didn't say wanker. You didn't say it. How do you say it?
Oh, I'm not a wanker. You're a wanker.
Oh, okay, that's very good. Aussie, oi, oi, oi. How do you say it?
Aussie, oi, oi, oi.
Okay. Vegemite.
I love Vegemite. It's good.
Yeah?
Yeah, it's good.
Okay, can I have his gifts? How do you say Outback Steakhouse?
Do you know, when we lived in Muncie, we used to actually go to the Outback Steakhouse.
Yeah?
And it was nothing like home.
So how do you say Outback Steakhouse?
Same as you, Outback Steakhouse.
This is one of your gifts. We're giving you an Outback Steakhouse
cap.
Thank
you.
That's the official cap.
Yeah.
We're giving you the official socks.
They have official socks.
And we're giving you a Crocodile Dundee cup. Okay? And before I give him his final gift,
look like that now.
Before I give him his final gift, I'm going to share with them a story that they have no idea in 1 minute. And this is one of my greatest moments in the history of medical conference. I've been waiting for this moment for 15 years. Go to my next slide, please. Okay, let's play Dr. Moyad. Do you remember 15 years ago when your research team took me out for beers and food? First I went to Sydney, but you were in Perth. So I went to your initial colleagues in Sydney. I was a visiting professor for almost a month there. It was a really great honor. But I had this experience out there. So they first took me to Sydney, and then they took me around to this one area. They said, you have to hold a koala bear. One of their colleagues said, and I said, sure. So go to my next slide. So this is me in 2007, okay? So they said, hold the koala bear. And then they're all standing around, all the doctors. And I said, well, okay. So what you don't see in this slide, I'm setting you up for what happened in Perth.
What are you wearing on your head?
I'm just wearing a cap. I don't know. It was just like I was trying to look hip. I was young.
It looked like a Cooperberg hat on you.
Okay. So I'm holding this koala bear, and you see how it's got some of its hair gone on the back. So I'm holding him, and it's got these claws on me. And I said to all the docs and the zookeeper, I said, why is part of its hair gone in the back? They said, well, it's a common disease in koala bears. And I said, what's the disease? And the guys say, right in unison, they go, it's chlamydia. And I went, wait, what? It's true. It's true. They get a form of chlamydia, which is why they lose hair. So that was my first introduction to the Aussie humor, which turned out to be true.
Yeah,
all right.
Can I just say that we washed and cooked them thoroughly before we eat them?
Then I go to Perth, and then I go have beers with these guys, and they say, we got you the ultimate gift. This is over a decade ago. And you were a part of this. I said, what's the gift? Like, they're going to treat me nicely. They gave me this exact hat.
Oh, it's beautiful.
That says, it's got kangaroos on it with all these corks. And I went to wear it that evening. And so I thought, I've been waiting 15 years for this moment. I'm giving it back to you to
No, you
wear
have to keep it.
at this conference. I haven't even taken the label off. You got to wear it.
Okay.
And I walked around. These guys were laughing at me the whole night. But I wore it. I wore it. Right? However, in the end, I have to tell you, this is one of my superheroes in all of prostate cancer, probably all of cancer, and we couldn't have you leave here without something serious. So this year we gave you the Oscar, Robert Newton, PhD, for Best Exercise Doctor, PCRI 2025. Thank you so much for coming. Thank you.
Thank you, Dr. Newton, and thank you, Dr. Moyad. We really appreciate it. That was great. Now, if you would like more information on exercise, we do have our exercise protocol that we are going to go ahead and link in the comment section below. And also it's available at our exhibit hall at pcri.org/2025-conference. Again, there's some incredible resources for you there, and I would encourage you to see it. One of the honors that we have here at PCRI is being able to showcase and highlight some incredible people who have done work in prostate cancer for years. And they may not be as well known as some of the people on our videos, but they have done such incredible work on a mass scale tirelessly when a lot of times no one else was doing it in those areas. The two people we get to honor is one with our Harry Pinshot Award, which is Mr. Mark Lichty. He is with Active Surveillance Patients International. He founded that organization. He has been our support group leader for active surveillance for years, and he has literally spent decades working in advocacy for prostate cancer from his own experience. The other person we got to honor is Mr. Jonathan Levy, and we gave him the Bob Each Award. Bob Each was a facilitator who was on our helpline for quite a long time, and he fought prostate cancer for over 25 years, and he worked with Jonathan Levy, and Jonathan Levy, many of you have spoken to on our helpline. He is a personal hero of mine, and he's done some incredible work just talking to thousands upon thousands of prostate cancer patients and helping give people information that can help lead to a better quality of life, overall survival, and so much more. The impact of what Mark Lichty and Jonathan Levy has done is incredible. So here you're going to see us getting to honor them and give them the awards at our in-person conference. We get to do something really special. We're going to take a couple of minutes to honor some people who have done such tremendous work in prostate cancer. But before I get to that part, we're going to bring up somebody who's very, very, very important to PCRI, and I wouldn't be here without him. So his name is Mr. Chet Swenson, and he has done so much in his career with marketing and Disney, and he's had more adventures than I can even count. We should write books about him, and we're going to interview him so we can capture his story. But he has been the board president of PCRI for over 25 years. I mean, he has gotten us through I have a lapel on too. He's gotten us through so many hurdles. PCRI was not always, it's not easy to start an organization. It's not easy to figure out what your mission is and then execute it. And Chet was our North Star and guiding light for that entire time, through thick and thin, no matter what, if it wasn't for him. I can't tell you the amount of times I've called him going, Chet, I need you, please. And he has answered the call of duty, and honestly, PCRI would not be here without him. So everybody, please welcome up our board president, Chet Swenson.
Well, that was quite the introduction. Thank you, Alex. I'm leaning forward to make sure you can hear me. Can you hear me okay? Yeah, this is a very special moment for me because today we have an opportunity to acknowledge and recognize some extraordinary people. And in today's world, there are so many challenges that we have. There are people that truly can make a difference. And we have challenges, as we all know in this room, that we're combating daily. We have fear. And we have folks that can help us, that dedicate their lives to helping others. And Dr. Moyad, when he left, he says there's he was a wonderful person, the last speaker, and the people we're talking about are wonderful people. I've had the privilege to know these people upwards of 15 to 20 years and have seen them in action. And when I see them, I miss them. I realize that I haven't had enough time to be around them. And when you have an organization like this, as an ordinary man, which I am, I learned a long time ago that you want to surround yourself with extraordinary people. And these people that are going to receive this award today are exactly that. They've given their time, their heart, and they've given to humanity to make it a better place. And the awards that are given today will exemplify that. And I couldn't be more proud that these individuals are the recipients of the award. And what they've done to help us will resonate for years to come. It will not go unrecognized, and they're going to make it a much better world going forward. So with that, I would like to have Alex come up and present these two awards to the individual. There she is. I couldn't see you. She's behind me, as always. She's always supporting everyone, so you know. I want to have her announce the awards to the recipients. So with that, thank you.
Thank you. So the first awardee is the Catalyst Award. Now, this person is not here today. They actually retired about, almost 7-8 years ago. But it's Dr. Snuffy Myers, and I know Dr. Moyad mentioned him earlier, but we do want to just take a moment and say he has done such incredible work, and we wouldn't even have our YouTube channel without him. So he decided that he, as a medical oncologist, he thought very outside the box, and he would just tackle people's problems head on. He would advocate for patients like no other. Him and his wife, Rose, just did an incredible job. And they had a nonprofit organization called PCRI, and his daughter really carried the mantle with him. How many of you are familiar with Dr. Myers? That's awesome. He would appreciate that. And so he does have Parkinson's. That is the reason he retired. And we couldn't get a video with him because he is currently dealing with some things. But he is doing quite well. He's still traveling. He's still seeing his grandkids. He wanted everybody to know that and just asked that I would speak on behalf of him. But if it wasn't for him, there are so many men that we know that just wouldn't be here. He did such an amazing job with his care. And they took their nonprofit. When they dissolved it, they donated the rest of the money to support the PCRI YouTube channel, because he was the one that started the YouTube videos back in the day before PCRI ever existed. He would sit on his living room floor as an oncologist and just start making videos, even before YouTube was popular. So we really appreciate him. And if you would like to send a note to Dr. Myers, many of you have, or if you would like to, there is still a portal and page on our website, and he really does appreciate them. We've actually made him a book that we're sending him, an updated version of what we sent him a couple years ago with all of the notes from his patients. And so let's just give an applause to Dr. Myers. So the next person that we get to talk about is very special. I've both of them, the two people that are coming up today, I know personally quite well. But Harry Pinchot was the founder of our helpline and the founder of really PCRI and a lot of our programs. So he would go into the UCLA libraries before the internet was around. He would do all these amounts of research and do all of this. And then he'd provide that education to patients over the phone. And if, for those of you who don't know, we do have a PCRI helpline that's 100% free. And they are prostate cancer patients who can explain education and pieces of information to everybody. And Harry Pinchot was the start of it. So that's why we named this award after him. He did end up passing away from prostate cancer, but he is one of our legendary heroes in the PCRI lore, and he's just somebody that we honor. And through that, we get to honor other people who the prostate cancer community nominates. And this person that we're bringing up today has been nominated like 5 times. So he's very loved and cherished. His name is Mr. Mark Lichty. And Mr. Lichty is an incredible friend. I'm gonna tear up, but he is the reason we have active surveillance support groups at this conference. He would walk up to our team and go, hey, active surveillance is becoming more and more popular. I'm on active surveillance. Can we create a support group? And so not only did he do that, he started helping out in his support groups, helping other men with active surveillance. And as we know now, 50% of prostate cancers can be monitored, Gleason 6 prostate cancer, but he has pushed forward so much education and even starting an organization, which is the first and only nonprofit organization specifically designed for active surveillance patients, and that's Active Surveillance Patients International, and he is the founder of that. He came up to us at the PCRI conference and he said, would you help us make another nonprofit? Can we make this part? What can we do? And so now they are educating active surveillance patients with webinars and all sorts of resources with Bill Manning, his executive director, and they have done such an incredible job. And Mark is just a personal friend. He's one of the sweetest people I have ever met. Our team is so happy that he is getting this award, and thank you so much for all of you who nominated him. So without further ado, Mark Lichty.
I'm touched by your words. I can think of no other organization that I would rather be recognized by than yours. And in accepting this award, I honor my father, who died of prostate cancer in 1996. Died because he was overtreated. Died stoically suffering. And he's the reason that I'm here today. He never said, Mark, go do something with prostate cancer. I could see in his suffering that I did not want to be treated. I've been on active surveillance for 20 years. I still don't want to be treated. But for my father, Active Surveillance Patients International would not exist. But for PCRI, Active Surveillance Patients would not exist. It was created here at one of these conferences. And these conferences are so unusual. It's not just what happens here on stage, it's what's happening between each of you in the audience here, and the knowledge that goes back and forth. A dear friend of mine, co-founder of ASPI, Howard Walensky, who writes the Active Surveillance. If you haven't signed up for that newsletter, the Active Surveiller, sign up for it. It's a wonderful newsletter. But he and I kid, and we say that all this chaos and friction we see in the world around us, in the political world around us, if we just spoke about prostates, we wouldn't have this all going on. And so, actually, today, I want to announce the formation of a prostate peace party. And Alex, you're going to be my first nominee.
Oh, wow.
So obviously, I say that with humor, but if we stick to prostates, there is peace there. There is peace. And so, and I speak of active surveillance and the fact that we can reach a place of peaceful vigilance if we are actively involved in monitoring our prostate cancer. But by the way, I not only accept this award on behalf of my father, who I honor here, but also on behalf of a terrific board. We have an amazing board on behalf of all the men that follow us too. So thank you again for this award. Much appreciated.
Mark is one of the sweetest people. I got to join the Active Surveillance Patients International Board for a couple years. The video life took over my life a little bit, so I had to step down, but I still get to work with them very closely, and Mark means a lot to me. He has been an incredible friend and an incredible advocate. So the next award is quite special. I don't know if you guys have seen these, but these bracelets outside that say never give in, if you flip them, it says in honor of Bob Each. So Bob Each was a personal friend of mine. When I was 22 years old, he was working on the helpline, and he volunteered and was a support group leader here. He was diagnosed with Gleason 9 metastatic prostate cancer at age 52 and told he was given 6 months to live. And he lived for 25 years. Metastatic, Lupron worked for him forever. It was kind of crazy. Lupron typically has like a 13-year time span according to clinical trials, and for 25 years it worked. He was such an advocate because he was in a place of despair, and then all of a sudden, he started working with Harry Pinshot. He was one of our early founders, and he really advocated for himself. And he's one of the stories I love to tell, because to be diagnosed that young with Gleason 9 prostate cancer that had metastasized, and to be living for 25 years later is absolutely incredible. And it just shows the hope that's out there and the options if you educate yourself, fight for yourself, and really create that research and that education and stand up for yourself, which is really important. So he joined our helpline, and we created an award for him. And on his deathbed, I was with him 8 hours before he passed. And he was legendary. He had gone to the Amazon and been chased by barracudas. I mean, all sorts of insane things. Like, I would just sit there and listen to him for hours. He loved flying model planes, and built them, which was really cool. And when he was on Helpline, he got to work with Jonathan Levy. And Jonathan, how many of you have talked to Jonathan or met Jonathan Levy? Many of you in this room. So I call Jonathan my rock star. He hates it. I call him that anyway. But he really is, because he's a prostate cancer patient who decided that he was going to take his journey and help other people. I don't know if he knew he was going to be helping thousands of other people, but he ended up doing so time and time again. His dedication has been absolutely incredible. When I was with Bob on his deathbed, he picked the first 5 winners of who would win his award, and Jonathan was on that list. So Jonathan has been with PCRI for longer than I have. He has had so much compassion and love towards these patients. He's been there for so many people, and I can't tell you how many times I just get phone calls of, that guy Jonathan, he knows so much, and he's so kind, and he's just willing to talk. And how many people do you know that'll talk to you on the phone all day long about prostate cancer, and pick up the phone constantly and just handles people's cases, their emotions, their fears? But Jonathan does all of that. And so he is a member of the PCRI team. I'm so proud to know him. It makes my job so much easier just knowing that Jonathan's there to be able to answer people for free and give them that resource. But he has just been a huge supporter. He's educated our team, and I just cannot say enough about him. And I would stand here and keep going if I don't shut up, so I'm going to. So without further ado, here's Jonathan.
Bob Each is still always in my heart. I spent time with him when he was in hospice. Bob was my buddy. We would hang around together at the conferences. I can't tell you how much I loved Bob and miss him all the time, that I don't have him to hug also. My wife Doris came with me to this conference because she also knew Bob and met him several times. And this award is really for Bob, in my view. This has been a spiritual journey for me, in the finest sense. It has taken me out of myself. and become all of you. I am all of you, and you're me, too. We all experience the same fears, the same dread, the same love, and we're all appreciating, I hope, our own lives. Prostate cancer does not take your life away from you. And what I learned most of all is to just survive and keep going. Keep going. For me, it's not about science. I know the science and I do deal with the science, but for me, it's more about heart and love and just giving some kind of shared decision-making is one of my goals in my own treatment, and that I try to give to other people. It came to my life out of this. I didn't know anything until this fly wanted to come into my life. And I went to a conference once for PCRI, and it was a room this size of all physicians, no patients. And I couldn't understand, what am I supposed to do here? And shared decision-making came up and became my talk to them. And after my talk, as I was circulating through the exhibitors and all these doctors came up to me and said, I am so thrilled that you came here and talked to us from the patient's point of view, because we don't get that enough. And that kind of lit me up, and so that's what I do on the phone with all of you, basically try to give you the same direction that I've found. You're in charge, okay? You work with your doctor. It's the two of you as a pair or more than two, but you are in charge. And we kind of lose track of that. He said I was supposed to do this and I should do that and I can't have that and I can't. You can. And that's what Prostate Cancer Research Institute gives you, that gift to be able to have the strength and the compassion for yourself and for others. And also the science and the knowledge that you have to have. But keep that in mind. You are really in charge. You can't do anything. They can't do anything. Nothing can happen without you approving of it. So you have power, okay? Just get engaged completely with your own life. And I just thank you, Bob. That's all I can say for what you gave me. Okay.
I know you see Dr. Scholz and I on the videos, but there's a whole host of people in a team like Jonathan and like Bob that do such an incredible job supporting all of us. So I would encourage you, if you have questions, call the helpline. That we have email, we have phone. It's very helpful. Now, while our team is getting the stage set for our two wonderful next speakers, can I get the other slide up that we were talking about, Bobby? I don't think he hyped this up enough, so I'm going to go back to it. So the team's going to bring the table up. So obviously I can't run, so Dr. Moyad's going to run for me. I'm very excited about this, but I don't know any 60-year-old personally that's running the New York Marathon. I think this is one of the coolest things I have ever seen. And when he called me and he told me, I thought he was lying, because I said, you can do that? How cool is that? And he goes, well, not only am I going to do it, I'm going to do it for charity. So I would encourage you, as a PCRI community, Dr. Moyad does so much for us, and I want to support him. We're going to be there. We're going to be filming it. We're going to be talking about it. He's running in the name of PCRI, and he's running in the name of unpaid medical debt in the New York Marathon. We are so excited for him. So please, go to this page, donate to unpaid medical debt. We're so excited to support him. And you could also, check out PCRI as well. But I am so excited of what they do, and I'm so excited that he gets to be a legend, which is his new nickname, and go in and run this. And so you can check out the PCRI YouTube channel just a couple months after, because we're going to be filming and promoting that, and I'm so excited about it. So can we give it up for Dr. Moyad running the New York Marathon? Thanks so much for joining us and honoring these two. If you have someone in your life or someone that you know of that is tirelessly working in these fields when it comes to prostate cancer advocacy and helping men, you can go ahead and email us at info@pcri.org and nominate them. Basically, you write up a synopsis of the work that they've done and send us some information. And it even helps if you kind of get some of the other people maybe in your support group or your community involved. It just gives us a bigger picture of who this person is. We want to honor our heroes in prostate cancer, people who have done so much to help others, and that's just really the essence of what we do here at PCRI. Now, we're going to go ahead and move on to our next speaker, but before I do, I just want to thank our sponsors: Bayer, Pfizer, Astellas, Janssen, Novartis, Dendreon, Miradex, Blue Earth, Foundation Medicine, and AstraZeneca. Our next speaker is Dr. Matthew Cooperberg, and he is the professor of urology at University of California, San Francisco, UCSF. He's been an incredible contributor to PCRI. You may have seen him before, speaking on active surveillance and so much more. But today he's going to give us an update on active surveillance, biomarkers, and genetic testing in 2025. Dr. Mark Moyad, along with Dr. Cooperberg, do a great job of educating us in this space, and I really think you're going to find it educational. So without further ado, here is Dr. Cooperberg.
We've been waiting to have this moment for a decade, and up comes, and then we take a break, up comes Dr. Cooperberg from UCSF, the top-notch surgeon in active surveillance.
Thank you. Pleasure to be here. Tough act to follow. I will say I'm not going to talk much about exercise and active surveillance, but I agree completely with everything said except for the comment about Vegemite. And in fact, Dr. Newton mentioned Stacy Kenfield, who's with us at UCSF and has done a ton of work on the benefits of both diet and exercise for men on surveillance specifically. So diving in, why did we talk about active surveillance at the opposite end of the spectrum from a lot of the morning sessions? If we step back and think about where we are with this disease nationally, prostate cancer remains on the left by far the most common cancer diagnosed among men. On the right, second leading cause of cancer mortality among men in the US. These are numbers that we repeat every year. I will say for a few years it looked like colorectal was going to overtake prostate cancer in terms of the mortality rankings, and thanks to the USPSTF and the drop in screening rates, prostate cancer mortality rates unfortunately have actually been rising fairly substantially in recent years. And this is a look at the trends over time. On the left here is incidence, how many cancers we find. These are data going back to the 1930s. That big spike you see in the 90s, of course, is the introduction of PSA. And when PSA hit the market, every man and his uncle ran out and got a PSA test, age 60, 70, 80, 90, from their primary care docs. We found all these cases, men who had just been living with it, unknown for years. So the incidence rate shot up, then things stabilized. And then what you see in the 2010s, in 2008, we got this recommendation from the US Task Force saying, we don't really like PSA. Then in 2012, they said, don't screen anybody ever, which is what the D recommendation meant. And that's what primary care heard. And the incidence rate plummeted, not because it went away, but because we stopped looking for it. Incidence rates fell 25% literally overnight, down to the lowest numbers we've seen since the 1980s, not because prostate cancer went away, but because primary care stopped looking for it. Now things are swinging back again. I'm sure most of you know in 2018 we got this C recommendation, which again is, well, we don't think this is a great idea, but you should have a conversation between the men and the primary care doc about whether to do a PSA test. Rates are going up again. Rates of screening are going up again, so the incidence rate is going up again. In the meantime, the mortality rate, which is the curve on the right, these data go back to the 30s. Sorry, the incidence data go back to the 70s. The mortality rates go back to the 30s. And prostate cancer mortality rates, you can see since the 90s have been falling at a steeper clip than any other cancer except lung cancer. We know the reason for lung cancer is smoking cessation. The reason prostate cancer mortality rates have fallen this much is PSA testing, period. There's a lot of buzz and noise about the controversies around this. It's not that complicated. It's PSA testing, early detection, and aggressive management of high-risk prostate cancer that has driven down the mortality rates. And if you look carefully, what you see is after 2010, that curve flattens and has actually been going up a little bit. Now, it started flattening quite early, so it's unclear whether this is 100% because of the drop in screening rates. There are probably other things going on as well. Men are living longer, less likely to die early of cardiac disease, things like this. So it was probably the exact wrong time to stop screening in the early 2010s, but certainly the drop in screening is a major factor in the fact that the mortality rates have stopped declining. Why am I talking about all this launching off into active surveillance? Because the fundamental reason that the task force came out so strongly against screening, there's a number of reasons. One is that they got the data completely wrong and they grossly misinterpreted a number of really important studies in this space. But more fundamentally, it was a reaction to overdiagnosis and overtreatment of low-risk disease. And the fact that, and this is obviously true, many, many, many thousands of men received radiation, surgery, and other treatments that they did not need for tumors that they never would have known they had we not found them. And too many of those men suffered long-term consequences. And primary care looked at this and said, well, we're not sure about the benefits. We know the harms are terrible. We need to just stop doing this. And the baby went straight out the window with the bathwater. And of course, we now know how to do this all much better. And I would make the point, by the way, that we talk a lot about the racial disparity in prostate cancer, which is the greatest of any of the major cancers, and this has gotten no better over the years. In the middle here, you see the excess rate ratio. It's a 2.5-fold higher mortality burden borne by black men compared to white men in this country. Rates have fallen for all men, but the gap has not gotten any narrower over time. And the curve on the left, the circle there, the mortality rates appear to actually be rising faster for black men than for other men. So again, it was the wrong time to stop screening in 2012. Now fundamentally, the problem here ultimately is actually a linguistics problem. I'm an English major, going back, and ultimately this comes down to the problem that we use the word cancer to define an unbelievable spectrum of things that can happen to a human body, and everybody hears the word and they think pancreatic, they think terrible things, they think months or maybe years to live. And the reality is what we're talking about in many cases is cells that look funny under the microscope and maybe no more than that. And this is a terrific cartoon from an article which is almost 15 years old, more than 15 years old now, from Ian Thompson, who's a urologist in Texas, and Laura Esterman, who's a breast surgeon with us at UCSF, thinking about screening for cancer in general. And each vertical interval here is a screening test. It can be a PSA, a colonoscopy, a mammogram, pap smear, what have you. And the idea is if you get to the far right, you die to something else, usually cardiac disease. If you get to the top, you've actually died of the cancer. And we know that even with PSA testing, there are many cancers that we do not find. That's the snails. They never get out of the microscopic range on this graph here. There are others, these are the turtles, where we can find them when they are confined to the prostate. That's the second vertical band. We can treat them, we can quote unquote cure them, but had we not find them, man would have had no idea he had it. That is the definition of overdiagnosis. And when we treat those, we are over-treating. Then there's the rabbits. These are the ones, this is what the whole screening endeavor is about. These are tumors that we can find when they are localized, we can treat them, we can cure them, and had we not, this would have progressed to lethal disease. And then finally, the birds are very rare in prostate cancer. The birds are why we can't screen for pancreatic cancer, because pancreatic cancers typically grow very quickly. Prostate cancers usually grow over decades. So the birds are very uncommon in prostate cancer. We don't really worry about the snails. The issue is all about the turtles versus the rabbits and the damage to the turtle population in the course of chasing rabbits. So as I said, most men, and this is obviously I'm sure old news to everyone here, most diagnoses of prostate cancer, you would never know you had it if we hadn't gone testing. Most men with a prostate cancer diagnosis die of other causes. And the part you might not know is that most men have prostate cancer. The majority of men, if you live long enough, have these microscopic cells. The issue is that the aggressive subtype, all of which we're categorizing under this concept of cancer, the aggressive subversion, these are the ones that kill more men than any cancer except lung cancer. So it's our job in medicine, especially in urology, because we're usually the ones that do the diagnosis, it's our job to risk stratify and get the treatment conversation going at the right level of intensity. So low-risk disease today should be managed with active surveillance, period. And the same is true for a lot of what we call intermediate risk disease. There is an increasing role, we think, or at least an evolving role for focal therapy, meaning treat the tumor, leave the rest of the prostate alone. I'll talk about that a little bit near the end. Then, of course, we have surgery and radiation therapy, or maybe a combination of those two for men who have higher risk disease. And then finally, we bring in systemic therapy for the highest risk bands. And what this means in terms of looking at risk, we look at multiple factors. We look at the PSA, the grade, that's how the cells look under the microscope to the pathologists, the stage, that's how, can we feel a tumor, how extensive is it within the prostate, and other factors. And the question is, will this one spread? Is this one actually at risk of causing symptoms, causing harm, and threatening life? We don't have to in all cases, we can augment standard risk stratification with tests like Decipher, like Polaris, Oncotype, the newest one is Artera. I'll talk about those a little bit near the end. The biggest driver amongst these risk factors, though, is grade. And again, this is how the glands look under the microscope to the pathologist. And if you want a concept of what they're looking at, what is the prostate? Well, it's a gland. It produces fluid. Its main job is to make a lot of the seminal fluid, the semen, that comes out surrounding the sperm. So how do you actually do that? You have a whole bunch of little microscopic tubes, and the tubes produce this fluid, and the fluid comes out when you have an ejaculation. Well, if you cut across a whole bunch of tubes in cross-section and look at them, you get a bunch of circles. And a normal prostate gland is just an irregular-looking circle with 2 layers to it. All cancer really is, a low-grade cancer, is circles that are too small, they're too packed in, and they've lost their basal cell layer. That is the hallmark to the pathologist. If it is a 1-layered gland instead of a 2-layered gland, that is the definition today of cancer. Okay, and we'll come back to whether that should be how we define cancer, maybe near the end. Now, when the circles start to lose their architecture, that's when we get into the higher grade ones. When they start to fuse with each other, they get these other patterns. So grade group 1, which is just too many circles, too packed in, but they're still circles, that is the lowest grade cancer. We do not treat that. We probably should not call it cancer. The higher grade ones, so grade group 2s, some of them need treatment, some of them don't. Most of the grade group 3s do, not all of them, most, and then almost all grade group 4 and 5. So there's a really important paper that came out last year from a group of pathologists led out of the Cleveland Clinic, but it's a big sort of multi-institutional effort to really rethink histology, the way the pathologists are interpreting these abnormal glands under the microscope. And it basically breaks down the entire Gleason scoring system, which goes back to the 1970s, and dichotomizes the entire thing into favorable and unfavorable. I think this is one of the biggest newspapers of the last several years, honestly. Because basically what you have is unfavorable, which is Gleason 5, traditional high-grade Gleason 5, cribriform, large cribriform, and intraductal, which we've been recognizing for a while now in academic pathology circles, and then 3 rarer patterns, which I had never heard of before this paper came out. Apparently they happen pretty uncommonly. Those are unfavorable. Everything else is favorable. So all the grade group 1s, and the other types of grade group 2s, so the things that the pathologists call fused gland, poorly formed gland, simple cribriform, all these are favorable. Okay? And it's a lot of words, there's a lot of details in terms of what the pathologists are seeing. But the bottom line is on the right here. These are the curves, and remember, in a Kaplan-Meier curve like this, you want to stay at the top, right? The line is showing you the percentage of the men over time. The x-axis is time. You want to stay at the top, and you want to go as far to the right as possible, staying at the top of the curve. It means you have not had the event. The more the curve is falling off the top of the graph, more and more of the men are having some event. So the top graph is recurrence, metastasis, and actually cancer mortality at the bottom here. And the bottom line is, in this cohort of hundreds of men with prostatectomy, there was not a single metastatic event or lethal event in somebody that had favorable histology. Not one. This is a big deal. I've been doing biomarker research in prostate cancer for 15 years. I have never seen a survival curve split this dramatically. This is a big, big deal. And it does emphasize the point, one of the most important points we can make in terms of take-home messages: get your slides reviewed by an academic pathologist 100% of the time, period. Okay, it's just easy advice. There may be a small charge to it. It doesn't take any additional effort. It's not more biopsies. They can ship slides all around the country. And it's an easy thing to do. These days, it's all digitized. They can just send this, they can often just send the images over the internet, literally. So with that in mind, how do we roll this all together and think about risk? This is the NCCN risk classification, which is still the one that's used the most often by clinicians today. It's honestly gotten quite cumbersome. It's not very good. It sort of exists because it's a consensus and there's a lot of inertia around changing it. The very low risk group needs to disappear. The AUA has already dropped the very low risk group from their classification. Somebody that has such a tiny tumor that they meet these criteria should never have been diagnosed in the first place. This goes back to, this definition was derived in the 1990s when we were doing 6-core biopsies. So this idea that if you have more than 2 cores positive, you're out of that box, it's really has no applicability today. We have not found one of these at UCSF in the last 4 years. So, the problem with having a very low risk group is if you're low but not very low, you think, oh, well, I'm not the lowest risk group. I'm not, I need to think about treating this. And it causes a lot of unnecessary anxiety. So forget very low. Low risk is fairly consistent, but the way the classification splits up favorable and unfavorable, intermediate and high risk is really not adequate for contemporary practice. 20 years ago now, we published the CAPRA score, which does a better job, although it's still based on these same standard variables. This gives you a 1 to 10 score using the same traditional PSA Gleason score, extent of biopsy, core involvement. This does a much better job identifying granular level of risk. This is going from 0, CAPRA 0 at the top to 10 at the bottom. And we can predict the likelihood of actually dying of the cancer across different treatments out to 20 years now, ranging from absolutely nobody to over 70% for the men with the worst tumors. And the problem is the treatment recommendations, if someone is just kind of really in lockstep with the guideline and they're not really thinking beyond the guidelines at all, we can overtreat pretty substantially or we can undertreat pretty substantially. So these two patients are both quote unquote unfavorable intermediate according to the NCCN risk classification. The guy on the left who has a low PSA density, meaning he's got a big prostate, which explains part of the PSA level. He's got 3+4 and it's only 10% of one core that has the pattern 4. It's a favorable histology subtype. He's a chip shot for active surveillance in my mind. And yet he's called unfavorable intermediate. A lot of radiation oncologists would give him 2 years of hormonal therapy together with radiation. It's tremendous driver for overtreatment. The guy on the right in the meantime, PSA is nearly 20, much higher density. He's got 4+3 in most of the cores. He's got an unfavorable histology. Not only is this a real tumor, this I would think is a pretty high probability of at least micrometastatic disease. Completely different tumors, but they get lumped into this intermediate box. And we can do a much better job, again, with the Capra score, lots of other risk classifications that are out there. So this is all prelude to the fact that for low risk and for a lot of the intermediate risk tumors, the ones like that patient on the left, surveillance is now our standard of care. And surveillance, of course, means keeping an eye on the cancer with every intent and expectation of curing it if we see signs of progression. And this is not the same as watchful waiting. Those two terms still kind of get conflated. Watchful waiting applies to men who are older, have a lot of comorbidity. The idea is, Mr. Jones, you've got this prostate cancer, but you had 2 heart attacks and a stroke last week, and this is not going to be an issue for you. If by some unlikely chance you develop symptoms in the future, we have hormonal therapy available, but we're not even going to follow this. That is the watchful waiting concept. Okay? Active surveillance is very different. It says we've found this. This is not a problem today. This is probably not going to be a problem in the near future. Over the long term, we don't know. So we're going to watch it and expect to cure it if we see signs of progression. This has been a 25-year journey led by Peter Carroll, Laurie Klotz, and Bal Carter at UCSF, Toronto, and Hopkins, respectively. When I first got to UCSF in 2000, this was kind of just getting going. The graph at the bottom here is an early UCSF paper. When I joined the faculty in 2009, we had about 100 patients in our surveillance cohort. Now it's over 3,000. And it's great to say 25 years later, surveillance is the standard of care for active surveillance, period. Full stop. In every major guideline. For men that meet the criteria for low risk. And I would say anybody with grade group 1, even if the PSA is a little high, even if they've got higher volume disease, surveillance is the right way to manage it for the vast majority of men. Not 100%, but 90, 95% of the time. Okay? And the guideline does point out, by the way, that for men who have low-risk disease plus limited life expectancy because of cardiac disease and other factors, watchful waiting is actually quite reasonable. We don't need to put everybody through repeat biopsies and frequent PSA testing, et cetera. So who should be on surveillance? Again, everybody with grade group 1, period. And which of the men with the intermediate risk disease? Well, the men who have a grade group 2, the 3+4s, and have favorable histology are certainly eligible. And I would say this also applies, technically speaking, if your PSA is 12, you're not low risk according to the classifications, but plenty of men have a PSA of 12 because they've got a 150 gram prostate. Okay, and remember, PSA, that's not even that big. I know it sounds big, we've seen hundreds. PSA is prostate-specific antigen, not prostate cancer-specific, and anything that happens as you get older will drive the PSA up. And there's plenty of men that wind up inappropriately classified to high risk just because the PSA is high or because of these other factors. Age is really not a factor. There was this old thought that if you were 48 and got a cancer diagnosis, we got to go right to treatment because you're too young for surveillance. That is crazy. We are increasingly clear that the right age to screen is probably between 45 and 55 or 60, and we have no business screening in that age range if we're going to overtreat men when we find it. A 48-year-old who has a low-risk prostate cancer is not going to make it to 80 without doing something about it, but I would much rather be treated at 58 than 48. I'd rather be treated in 2035 than 2025 because the treatments continue to get better. And we're doing better nationally. These are data from the AQUA registry, which the AUA launched a decade ago, captures about 25% of all the urologists in the country. And the bars in green at the bottom there are the surveillance rates. So in a decade ago, barely a quarter of men with low-risk prostate cancer in the US were getting active surveillance. And this is 15 years after the academic centers showed this to be safe. By 2021, we're up to 60%. That's rapid. It's actually quite rapid. If you think about pace of adoption of things in prostate cancer, this line is moving pretty quickly in the right direction. However, that means we're still over-treating like 40% of the low-risk disease, which remains a problem. And there's huge variability. This plot here shows individual urology practices on the x-axis and individual urologists on the y, and the circle is the proportion of men with low-risk prostate cancer that get active surveillance. And the bottom line is, depending on whose door you happen to knock on, your likelihood of getting AS ranges from 0% to 100%. Okay? That is obviously problematic. That is nowhere near unique to active surveillance or to prostate cancer or to urology. We see this everywhere in healthcare that we have the courage to pick up the rock and see what's under it. This is called the small area variations problem, and we see it everywhere. But it is certainly an ongoing problem. There are lots of urologists and radiation oncologists out there that still pervasively overtreat. Which again is a reason to always get a second opinion. Prostate cancer is never an emergency, even the high-grade ones. And these days, everybody is doing Zoom visits. It is incredibly easy to pop on Zoom and get a second opinion, get a third opinion. You have plenty of time to collect opinions, especially if something seems like somebody is really rushing and being over-aggressive. So what's involved in surveillance? This has really evolved. The old thinking was you needed a biopsy every year, then it was every 2 years. Now things are really getting a little bit more tailored. The PSA, we check every 3 months for the first year just to kind of make sure it's not rising quickly, and then we back off to no more often than twice a year. You definitely need a confirmatory biopsy with a high-quality MRI first within the first 12 months or so. We call this the confirmatory biopsy because we know that the first biopsy can miss higher grade disease, and we want to make sure that we're surveilling what we think we are surveilling. After that, these days we're really tailoring things depending on the details. How, was it a grade group 1 or a grade group 2? Was it 1 core? Was it 12 cores? How old is the patient? Is there family history? Is there a BRCA mutation? All these things that are in the subtleties, that will drive how often we're really going to recommend a biopsy, an MRI, PSA testing, et cetera, after the confirmatory. Do we get genomic testing? Do we get other testing? It is very much customized. People ask all the time about additional imaging. You definitely do not need bone scans or CAT scans for low-risk disease. You definitely do need a multiparametric MRI, and it's got to be done at a high-quality center. You can get a CAT scan of the kidneys done anywhere. You can get a PET CT done in most places, although you don't need one for low-risk prostate cancer. Those are fairly reliable center to center. MRI of the prostate is incredibly center specific. You need a lot of expertise just to set up the machine properly, and especially to read the MRI properly. So that has to be done at a center of excellence. Not necessarily an academic center, but a place where the radiologist is doing prostate MR all day, every day, not reading mammograms all morning and picking up a couple prostates a week. And again, a PET scan right now has no role in low-risk disease or surveillance. That may change. We're running some trials. But currently, if you have low risk or favorable or even kind of low volume unfavorable risk tumors, PSMA PET is a waste of money. It's a $9,000 test, and there's no reason to get it when we know that it's going to be negative in terms of distant staging. Now, the flip side question, why do I have to get biopsies? Can't we just do MRI? And this is actually a paradigm which is becoming increasingly popular in the UK. There's folks that are arguing for this explicitly. I would say we're not there yet, but we're getting pretty close. MRI will still miss about 25% of the upgrading events, meaning we thought it was a grade group 1, turns out to actually be a grade group 2. So and there is variability about this. There are guidelines out there, there are protocols out there that allow for an MR to replace the biopsy. I do not think we're there for the confirmatory biopsy. Now, once we have that second one done, if we've verified that this is low risk or just a little bit of intermediate, then beyond that, I am increasingly comfortable with following PSA and MR and stretching out the interval of the next biopsy to 4 years, 5 years. My record so far, I've had a patient on surveillance who got to 8 years, and because I feel like we kind of have to do a biopsy just because it's been 8 years and there was nothing there. So, once we have the confidence of the second biopsy, I think we're going to be doing fewer biopsies in the future as the imaging gets better. And the imaging is going to get better very, very quickly. This is ground zero for AI. And everything is going to change in radiology and pathology in a very, very small number of years. Do you need a biomarker done? Do you need a Decipher score, an Oncotype, or Polaris? Not always. I think they're very helpful for tiebreakers. So we do tend to order them for men who have grade group 2, so who have the 3+4s. For guys who have a really high volume grade group 1, if there's a strong family history, certainly if they have a BRCA mutation, if anything, if they're really anxious, we'll get one too, but you do not need one in every case of active surveillance. And if you have otherwise low risk disease and a high Decipher, it does not mean rush forward and get treated. It means we have to follow this a little bit more carefully. There's also Artera, which is a pathology AI tool, which currently has no role in active surveillance, although we're certainly doing a lot of active studies with the company to try to figure out what that role may be. But they've so far published no data in AS. And again, AI is coming hard and fast in both the pathology space and the radiology space, and there are many, many tools. We can talk about it in Q&A or whatever you guys like, but it's evolving very, very quickly. And the issue with the markers, honestly, that we've had biomarker Decipher, Prolaris, and Oncotype. I'll go back to the early 2010s. They all work quite well. They can all add information above and beyond Kappa score, nomogram, what have you. The issue is that we're already throwing a ton of numbers at patients, and just throwing a Decipher score at you does not necessarily solve the problem, because half the time the docs don't really know how to use these score reports any more than the patient does. So just adding a score, adding a genomic test, does not make a complex clinical decision easy. And there's just the reality of the spectrum of prostate cancer biology. Everybody wants these to be dichotomized and the test will tell you what to do. It's just not that easy. So the one that we use the most is the Decipher. This has been run on literally hundreds of thousands of cases at this point. The problem with all these tests is that the companies work with us and academics to develop the test, to figure out the genes, to figure out the validation of the test, to do all the science. And then the test report is invented by the marketing department. And there is a whole science around how to communicate complicated quantitative information to a lay audience. None of those people are involved with these conversations. These are literally just, they run an ad board and come up with a report. And there's a lot of problems with these reports. The Decipher is one of the least problematic, although even the Decipher, the only thing I really care about here is the number. The thresholds between low and intermediate are completely arbitrary. There's high risk, quote unquote. The high risk ones in the 60s are not that worrisome. High risk in the 80s and 90s is quite aggressive and problematic. And these numbers about percent likelihood of metastasis and all this causes an incredible amount of anxiety. These numbers come from people diagnosed literally decades ago, because that's how long it takes to check these boxes. If you have metastatic disease, this was patients diagnosed many, many, many years ago, and it creates a lot of anxiety, and it's not that helpful, honestly. So I always tell folks to ignore everything on this except for the number, the Decipher number. Artera, again, I mentioned, this is a pathology AI test. It's moving very quickly. The company was launched about 2 years ago. They're already in the NCCN guidelines for the very specific question of, should you add hormonal therapy to radiation therapy? That is the question that Artera is validated to answer. They have this box down in the corner of their report, making totally unfounded recommendations about active surveillance, and it's driving a lot of us really crazy in the field that are working with the company currently on active surveillance validation studies. We will answer this question, but as of now, there are zero published data on whether Artera can help with active surveillance decision-making. They're marketing it, and it's driving us all a little bit crazy. This should not be used in AS today. Maybe by next year, but not in 2025. The worst right now is the Prolaris test, which literally tells you should do surveillance. You should do single modal, meaning surgery or radiation. You should do multimodal treatment based on the Prolaris test alone. This is nonsense. None of these tests can tell you what to do. Okay, everybody wants that, right? Everybody wants a pregnancy test, and if it turns blue, you take out the prostate. Okay, that's just not the way the biology works. Every single one of these diagnoses is a continuum, and every conversation that we have with you, that the patient has with the physician, these are nuanced, complicated, difficult conversations that need to reflect all of the clinical variables that we've been talking about, plus your urinary function, your sexual function, relationship status, where you are in life, other comorbidities. There is an incredible amount of nuance and art of medicine that still comes in to the practice in prostate cancer. And the idea that I'm going to look at a biomarker report and say, oh yeah, you're going to do surveillance because your Prolaris is a 6, is garbage, and it drives me absolutely crazy. And I wrote the original validation paper for Prolaris. I mean, we've been working with these companies forever. They're great tests. It's the way they're actually being reported that drives us all a little bit crazy. Surveillance, generally speaking, is very safe. There is obviously a risk every time we do a biopsy. The biopsies are uncomfortable. There is a risk of bleeding. There's a risk of infection. There's a lot of noise out there right now about transperineal versus transrectal. It's much more heat than light, if you ask me. The infection rates are a little bit lower with transperineal. The transperineals are also a lot more uncomfortable. It's just the reality. People ask whether the biopsies will spread the cancer. It absolutely does not in active surveillance. We have done millions of prostate biopsies, and it does not spread the cancer. You can find case reports in these dedifferentiated neuroendocrine, horribly aggressive prostate cancers. That's not what we're talking about here. And even those, we're talking about 1, 2 out of tens of millions of biopsies. And then, of course, there's the anxiety around not treating the cancer. We see this all the time. I went through all the options with Mr. Jones, and he really wants, he's anxious about it. We're just going to do radiation therapy. That is my failure if that happens. Okay, a big part of our job in urology, radiation oncology, medical oncology is dealing with the anxiety. There's a lot of psychology in this practice, and somebody that walks out of my office or hangs up the Zoom after a grade group 1 diagnosis and is still worried about the cancer, I've done a terrible job as the urologist that day. Okay. Now, how long can we stay on surveillance? This is also a moving target. The quote over the years has been about half of all men who start on surveillance are still on surveillance after 5 years. That's probably still about true. We're trying to keep men on AS longer as the years are going by, and I think we're doing a better job with that. But we're also putting men with higher risk disease on surveillance than we used to. So, this used to be men with like one core of 3+3. Now it's guys with a lot of 3+3, a little bit of 3+4. So how long you stay on really depends on where you were coming into it and how significant the cancer is at diagnosis. So to sum up, AS, and this is literally one opinion, and this is variable even within our group at UCSF. What I'd say is for folks who have low volume grade group 1, low PSA density, the ones that we should never have found in the first place, because they're not really cancers. If the life expectancy is low, this is really where watchful waiting is entirely appropriate. For men with longer life expectancy, we are trying to de-intensify surveillance, do fewer biopsies in particular, and use, really rely on the PSA and the MRI once we have that confirmatory biopsy done. For the more marginal ones, high volume, grade group 1, now we're talking about grade group 2, high PSA density, maybe a bigger lesion on MRI, that's what the PIRADS 5 means, then these men need to be on more of what we would have called a standard surveillance protocol. So periodic MRI, periodic biopsy. We know it's a question of when, not if, we're going to need to do something about it, and we want to make sure we catch it within that window of opportunity. And then at the bottom, there's lots of folks that come to the practice who frankly should get treated. They've got a real grade group 2, maybe even a little bit of grade group 3. They've got strong family history, BRCA mutation, big lesion on MR. We're telling them to get treated. They really don't want to. And I'll say, fine, you've got probably some time. Treatment is definitely if not when. It's definitely when, not if. But it's probably reasonable to wait a little bit of time. But we know we are just kicking the can down the road. And it's for that latter category, by the way, that focal therapy, I think, is really kind of evolving. So I'm not going to spend a ton of time on focal, but I know there's no other session on it during this weekend. So briefly, we're doing more and more of this. We're talking more and more about this. Focal therapy is the equivalent of a lumpectomy for breast cancer, right? And people ask this all the time. Why can't you just take out the cancer and leave the rest of the prostate alone? It's harder to do than for breast cancer or kidney cancer because the tumors don't grow as balls of cells the way some other cancers do. They tend to be infiltrating. They tend to be in different parts of the prostate. And doing the studies to show, is this better or worse than surgery or radiation are really difficult. You show me a focal therapy trial versus prostatectomy, I already know the answer. For sure, the side effects are less than surgery. Done. You don't have to do the trial. You want to ask me, does it cure the cancer as effectively as surgery? Well, come back to me in 25 years and we'll give you an answer. Okay, and nobody, and I'm serious about that time frame, and nobody's going to run a trial that long. So it's been very hard to do high quality research here. But I think as we're coming to understand where focal therapy should have a role, it is not an alternative to surgery and radiation. It is an adjunct to active surveillance for men that are kind of borderline candidates for AS. And first of all, even the term focal has a lot of variability in terms of what it means. We can just treat a visible lesion on MRI or ultrasound with a margin around it. We can wipe out half the prostate. We can even do more than half the prostate. And this all gets kind of lumped into the focal therapy rubric. There are many different ways to do this. Classically, we would do it with ice, called cryotherapy. Now we're using heat. That's called HIFU, high-intensity focused ultrasound. There's something called IRE, which is irreversible electroporation. There's focal laser ablation. There is alcohol injections. There is eye of newt. There are a million different ways to destroy a piece of the prostate, and it's not. There's a lot of vigorous debates about the best energy modality. It doesn't matter. The question is, do we know what we're treating? And that is the critical question that we've not answered yet. Okay. The imaging is just not quite there yet. MRI can undersample the tumor. PSMA PET can undersample the tumor. And we're still trying to really figure out how exactly to use it. The thing about focal therapy, though, is we're not burning any bridges. If we do radiation therapy, try to come in with surgery, it's a big deal. There's a lot of scarring, et cetera. If we do focal therapy and the cancer comes back, which it does very frequently, 30%, 50%, maybe even more, depending on what series you look at, we haven't burned any bridges. We can do another round of ablation. We can do radiation, we can do surgery without too much loss of ability to spare nerves and maintain quality of life. So it's a means, like I said, of kind of extending the criteria for surveillance for folks that are probably heading for surgery or RT eventually, but we're probably able to kick the can a little bit further down the road. But there's a lot of maybes and probablys and equivocating language here because we are still very much trying to figure out what to do with focal. And there's a lot of, I'd say, fairly unscrupulous practices out there. There was a time urologists were taking patients to Mexico and Canada to do HIFU for cash, where there's no legal recourse. There's this California HIFU Institute we used to have here, where they were treating every tumor under the sun. It is getting better in that I think academic centers are driving the conversation to a growing extent, but there's still a lot of unanswered questions. So we have a pan-UC, so the 5 UC campuses put a consensus statement together a couple years ago. So focal therapy, first of all, we have to acknowledge is investigational. It should be patients with a good life expectancy who have at least a grade group 2. It's over-treatment for grade group 1, no less than surgery is, or radiation therapy. So we're targeting grade group 2s or grade group 3s where we can see it on imaging. And there's no more than a grade group 1 somewhere else that we know we're not treating. It is essential that you get a biopsy 1 year later, and a lot of these folks are going to stay on some version of surveillance long term. Now, I want to leave, because we talk a lot about imaging and finding the high-grade cancers, making sure we're not missing something, making sure we're not missing an undersampling event, et cetera. But I do want to go back to a very old trial of surgery versus not active surveillance, but watchful waiting, okay, done in the VA system in the 1990s called PIVOT. And for low-risk patients in PIVOT, these were men diagnosed with a sextant biopsy, a 6-core biopsy done usually by a resident in the VA system with no MRI and hardly a functional ultrasound machine. And all that background is to say that these were grossly undersampled tumors. By definition, we know this. And we know this from the big UK trial called PROTECT, which kicked off around the same time and had the same 10-core non-image guided biopsy and quantified sort of what the undersampling looks like. A lot of these folks that had what we thought was low-risk disease had pretty aggressive tumors. And after 12 years here, these Kaplan-Meier curves are superimposed. It's not that somebody's arguing about the statistics and is there a meaningful difference and can you see daylight? These curves are the same. We did not save a single life, not one, by doing surgery over watchful waiting in this setting. So we have to be very careful about how hard we're looking for every little speck of increased grade, which is a great segue to where I want to leave, which is to get a little bit philosophical here, which on the note that I sort of led with, which is, why are we calling all these things cancer in the first place? Okay, so what is cancer, right? This word literally goes back to Hippocrates, Greek physician, 400 BC, 2,500 years ago, dubbed the karkinos, the crab, because literally you would see the tendrils of cancer spreading under the skin or basically spreading through the lymphatics for a terrible, incurable cancer. And for thousands, literally thousands of years, cancer meant you're dead, period, right? And this was known in every medical culture in the West and the East, and this has a very, very deep cultural resonance. About 150 years ago, we started looking under the microscope and looking at these things, and pathologists started classifying cancers based on how they looked under the microscope. So now we could say, well, we took out this clinically symptomatic tumor, gave it to the pathologist, and they would say, well, this is an adeno, this is a that. Only since the 70s have we really been screening. We got pap smears, then we got mammograms, we've had PSA, of course, since the 90s. So what happens is now we get a little bit of tissue from a patient with absolutely no symptoms, send it to the pathologist, and they say, well, this looks like the thing that 50 years ago you sent me when the patient already had a pretty aggressive tumor. It looks like that thing, we're going to call it cancer. And without a lot of intent, we evolved our definition of cancer from a clinical one to a pathologic one. And it's the pathologists that diagnose cancer. But the human psyche and the culture over the last 2,000 years has not caught up with that evolution. And people, when they hear cancer, still think the right side of the slide, not the left. And the fact of the matter is, when we think about low-grade prostate cancer, grade group 1, the pathologist is calling it, this goes back to what I was telling you earlier about the circles. That red circle at the top, those are 3 cancer glands hiding amongst normal glands. Okay? It is a pretty subtle change in pathology. Those are single-layered glands instead of double-layered glands, which are the bigger ones. That's it. Okay? And those things, when we start to get into the modern era, where we're not just looking under the microscope, but we're querying genomic expression, DNA regulation, the way the cancer is actually acting biologically, when you start to tally up the molecular and clinical features of a grade group 1 prostate cancer, it looks more like the normal tissue sitting right next door than it does like a cancer. So we can say it looks like a duck under the microscope, but it doesn't quack, fly, or squawk like one. This really could be thought of as more of a decoy. And the fact of the matter is that when we look at autopsy studies, I mentioned the snails earlier, right? The ones that we don't find even in a screening paradigm, and we're happy not to find them. If you live long enough, you make it to your 70s as a black man in this country, your 80s as a white man, and eventually get hit by a bus or die of a heart attack or something else, and we do an autopsy, we will find cells that look funny under the microscope that we call cancer 50% of the time. So we can almost think of this as a normal feature of aging. And we're trying really hard not to find these. So I mentioned the biomarkers that we're using for men who have a diagnosis of prostate cancer. We've got a whole other set of biomarkers that we're using for men with an elevated PSA. So these days, if you have an elevated PSA, we should not rush to biopsy. We should come in with an MRI, with one of literally 9 different blood and urine tests to try to figure out who, with an elevated PSA, needs a biopsy. And the way all these tests are set up, both the MRI and all these markers, if the test is positive, we think there might be a grade group 2 or higher, and you should get a biopsy. If the test is negative, it means either there is nothing there or there's a grade group 1, and in either case, we're not going to do the biopsy. So we are implicitly, or maybe explicitly saying, if all you have is grade group 1, we are perfectly happy to not know about it. We are not even going to look for it. So if we find it, it is an incidentaloma. It's an accidental diagnosis. So why on earth would we rush forward and treat it? And why should we even give you a cancer diagnosis and raise your insurance rates and cause all this anxiety? And this is all working, okay? So in the era when active surveillance first started, on the left here, I know the numbers are hard to see, but 2001 to 2002 is the far right in the black and white graph. Almost 50% of all the cancers we found in this country were low risk. Today, in the Aqua registry, this is the contemporary one, it's fewer than 20%. In the UK, where you basically cannot get a biopsy unless you have an MRI lesion, it's down to about 7%. So we are trying and succeeding in not finding the grade group 1 prostate cancers. And this is really important because if we want to save lives, like I said at the beginning, what we really need is for our primary care colleagues to screen everybody between 45 and 55 or 60. And the only way we can do that is if we tone down overdiagnosis. So we had a long conversation with our colleagues at UCSF and finally actually do have a screening paradigm baked into the EMR system now at UCSF. The docs should be offering PSA testing to men, understanding that we are only going to do a biopsy if we have a secondary test suggesting clinically relevant disease, and we're only going to treat if we find high-grade disease. And by the way, that workup starts with a PSA over 1, not 4. You got to forget all about 4.0. In midlife, for men in their 40s and 50s, 70% of the population has a PSA under 1 and can stop thinking about the prostate for the rest of their life, okay? Or at least for 25 years, which is why PSA is such an incredibly good test when it's done early. Okay, so it's incredibly good when there's not a lot of BPH clouding the picture. And we're making some progress, PSA, but we have a long way to go. So this is screening rates at UCSF. We're up to about 40%, okay? 50% for black men, which is the green line there. So this is progress, but not nearly enough, okay? We spend a lot of time talking about new medications and all the wonderful advances for men with advanced disease. This is all fantastic. But if we want to save tens of thousands of lives, not just thousands, what we need is screening. That's just, not really a question, not an argument. We need this curve on the right there to start going down again. And the solution there is screening. And the task force is pretty explicit about this. When they went from a D, meaning don't screen anybody, to a C, meaning we don't really love it, but at least have the conversation, they explicitly cited one of our studies from UCSF saying that while urology is doing more active surveillance, so the harm to benefit ratio looks a little bit better, and that's why we're giving it a C. So, if we really want to change the public health, I do think this is the biggest impact we can have. So that's where I will wrap up. I think this is kind of the end game around active surveillance. One of the end games around active surveillance is this conversation around grade group 1, and it's starting to get some real traction. This is an incredibly common feature of aging. We can think of it as an incidentaloma. To be very clear, if we found this, if we called it something other than cancer, we would still 100% be recommending active surveillance, because grade group 1 can ultimately either lead to grade group 2 or higher, or we can find a grade group 2 or higher in somebody who has a grade group 1. This is a continuum of biology from truly normal to things that are altered molecularly but look normal under the microscope, to things that look funny under the microscope, to things that are actually clinically meaningful. And there's no particular reason we can't just shift that barrier, that line where we define cancer one step to the right. And I would wrap up by just saying our understanding here has evolved tremendously in the last couple decades, and it is in very, very large part due to federally funded research at academic institutions. So if any of you have the ears of your congressman, please tell them to stop the madness and keep us able to continue researching for you guys. So.
He's one of my favorites in the sense that, man, he moves. And the one thing that that hurts me today is I'm not going to get a lot of time with him because we want to make sure he gets in the back room before he catches his flight. And so that means I get very little time with him. But that being said, some of the more popular conference moments in other conferences in the past few years is when I get to interview him. Over the past, I think, 3 years, we've done 2 interviews. You can find it on YouTube at the PCRI, where we go for 2-3 hours, just questions. And so make sure you check that out. So that's going to break my heart. So you're going to be able, I'd rather have them ask you questions than me get through my stuff, but I do want to ask you a couple. Is that good?
Of course.
Okay, so we gave him a Yale School of Public Health shirt. He said he wears it. Then it made me think of 2 questions when I think of you. Why do you tweet so much? You tweet more than anyone in urology and oncology I've ever met. And so it's like you're always tweeting. Tell me why you tweet so much. And I know a lot of this is prostate. And then tell people how they can see your tweets, because I have no idea. I don't do social media. So there you go. And then I know why you like to run and jog so much. It's good therapy like I do.
Exactly.
We're big runners, both of us.
Exactly.
And so why do you tweet so much? And how do I see your tweets?
It's much less than I used to, honestly. Unfortunately, Twitter is kind of a casualty of the last several years of mayhem. It has been a very good medium for conversation amongst researchers, between doctors and patients. It's really cool how everybody's kind of there. And it is what really struck me when it's first kind of got going 10 plus years ago now, is just how fast news could spread. You give a talk, and instead of somebody from a minor newsletter waiting to talk to you about back and put something on the web the next day, somebody snaps a picture of a slide and it goes around the world in seconds, right? So I think that speed has been really cool, and it's great to be able to engage with people all around the world. Asynchronously, there's a lot of things that have been great about it. The shine is obviously off with, since it got bought and became X, and a lot of medical folks left for a variety of reasons. But it's still the one that most people are on. I'm Dr. _Coops, if anybody's looking.
You're Dr. what
_ Coops.
Coops.
Seat of LPS.
The ones that I've seen, he puts up the latest data. He puts a lot of just breaking news. I think a lot of those are good.
Yeah.
When you do innuendo on other stuff, I start laughing. But when you put the medical stuff up there, it's really good. So I do recommend that people take a look, because I think he gives a really objective, quick look at data that's just breaking. Yeah. And you still do that, right, for meetings? Yeah. Okay. So that's kind of good. Let's keep the picture there, because you're wearing one of our gifts. We've given you a lot of gifts through the years. Do you believe in spontaneous regression of tumors like in active surveillance? So let me tee this up. In breast cancer, a lot of people believe, and they've done the mammogram studies to suggest, that some women with low-grade tumors, they can't find them in the future, and they think some of these spontaneously regress and go away because of maybe immune surveillance, maybe they didn't hit the right spot. So there's a discussion of spontaneous regression in prostate cancer with some tumors. Have you seen it? Do you believe in it?
Probably not. It's funny, there was literally just a conversation about this on Twitter today. I'm not even kidding.
No.
I think it's probably incredibly uncommon. I think it's much more likely that you put a biopsy into a tumor, you happen to hit the corner the next time the biopsy misses it, because it was such a small needle, you can't, needle in the haystack, it's such a small location, that you don't find it with the next biopsy. If you actually do a prostatectomy, the pathologist will almost always find some little speck, and you say, oh yeah, that was the cancer, although it might not actually be the spot that you biopsied. So I think it's uncommon that it's really going to go away completely, but the immune system does keep them in check to the point that it doesn't really matter.
Okay. And you said something interesting I've never heard you say in one of your talks. You said everyone should essentially get a second opinion on their pathology, especially if they're a non-academic center. Yeah. And it's interesting, because I say all the time, I find it interesting that pathology drives almost everything, right? Yep. But yet, you get one score one time, and you count that as sort of God's word.
Yep.
And that's why I was really glad that you said that. So can you repeat that you want people to send out for second opinions at various places and pay for it once they get pathology, right?
Yep. Medicare, a lot of insurers will pay for a second opinion, and if they don't, honestly, it's a few $100, and it's the best thing you'll spend in the treatment journey. If it's a marginal case, if it's a Gleason 4+5 and 6 quarters, nobody's going to disagree about that. But if it's a grade group 2, 3+4, 4+3, or if it's a really small grade group 1, sometimes our folks will come back and say they overcalled this, it should not be called cancer. So it is definitely worth it. We do them at UCSF. Hopkins does a lot of these. Mayo, the usual centers.
Yeah, but you were talking about subtypes.
Yes, that too.
Right,
yeah.
and that's what I'll see. Like I will see some pathologists won't tell you what type of 4 it is.
Correct.
So can you repeat that again?
So what we're looking for years has been cribriform. Now the question is expansile cribriform or large cribriform. Those are synonyms for the same thing. Or intraductal cancer. Those terms capture the vast majority of the unfavorable, the bad pattern 4s. And then there are those rare ones that I mentioned, which most pathologists are not calling yet, although this unfavorable, favorable paper is picking up a lot of traction in pathology. So I think we're going to be seeing them more and more. The ones on the other side, when we see fused gland, poorly formed gland, glomerular, these are all the favorable pattern 4s that biologically and clinically are probably not that different from grade group 1s.
So you're saying there are shades of 4, and the good pathologist will tell you what type of shade you have.
Exactly. Yep.
When you send someone for an MRI, how do you feel about them getting contrast these days?
We still do it, so that's a great question. The PIRADS system, which is how the MRIs are read, is still based on getting a gadolinium injection. Okay, because one of the sequences on the MRI is called dynamic contrast. It's looking to see how the tumor takes up and gets rid of the contrast. It's looking at the blood vessel density, basically, within the tumor. It's still part of the system. We've done it. Most prostate-focused radiologists have done it this way forever. Having said that, there's a big movement toward going to a biparametric, which is just the T2 and the DWI, so dropping the contrast. We're going to get there eventually. The problem, it's a whole other conversation about MRI. The problem with MR is not the MR scan, it's the variability in radiologist interpretation. There was a great study out of Stanford, which is pretty high volume. They're not quite our volume at UCSF, but it's still a big center, a lot of MRI. The likelihood of having a high-grade cancer when you had a PIRADS 5 on your MRI at Stanford University ranged from 40% to 80%, depending on which Stanford University radiologist happened to pull your scan off the queue. Now, at UCSF, the situation is completely different because we have not yet had the courage to do the study. And I can promise you, when we do, we will see the same thing. So this has been shown over and over again. And this is absolutely ground zero for AI. There's this wonderful study called PICAI that came out last year. They trained open source. They put 10,000 MRIs on the internet and said, go at it, world. They got 250 different AI teams from 45 different countries submitting AI algorithms. It's really cool. They took the top 5, which happened to be from 5 different countries, and they do this sort of mathematical merge of the best 5 models, and the winner, this merged model, beat 75% of the human radiologists in version 1, and it's free. So this is going to change, and that's based on biparametric. That is based on no contrast. So this world is going to change incredibly, incredibly fast. The same exact thing is happening in pathology as we speak. There's a consortium called PANDA. Again, 10,000 biopsies on the internet. You can download them and start writing AI algorithms when you get home if you like.
The more things get complicated and high tech, the more the simple get missed.
Yep.
I find it amazing that some of the top active surveillance surgeons in the world, I think, you're obviously one. We have one called, Todd Morgan. You know Todd, he's a good friend of mine.
Sure.
He did an interview with me for PCRI in the spring. You guys always throw out, and gals, always throw out PSA density. PSA density, you gotta know your PSA density.
Yep.
I would bet you that less than half, I'm even being nice, that less than half of patients are either told or understand what their PSA density is when they're on active surveillance across the country. Do you agree or disagree? And then tell us why PSA density is so critical and how simple a measurement it is.
I don't have to have an opinion. Show of hands, how many people know their PSA density?
Wow, a whopping 8.
Yeah, okay. So, but these are selected attendees of this meeting, right? So PSA density, like I said, PSA is prostate-specific antigen, not prostate cancer-specific antigen. Anything that affects the prostate will make the PSA go up. And as you get older, the thing that happens almost 100% of the time is the prostate grows to some extent. That's BPH, right? Benign prostatic hyperplasia. So the biggest problem with PSA, what killed PSA is the best screening marker in the history of oncology. Period. The reason it has been so controversial for so many years is because it was developed and validated mostly among men in their late 60s and 70s who all had BPH. So you're trying to distinguish the PSA made by a cancer from PSA made by benign enlarged prostate. That's how we got the 4.0 threshold, and that's how we got all this murk and controversy about PSA as a screening marker for cancer. So PSA density is literally the simplest arithmetic you can imagine. It's literally just the PSA divided by the size of the prostate. So you do need an ultrasound or an MRI to measure the size of the prostate to calculate your density. If the density is under 0.15, that's usually a pretty reassuring threshold. Okay, over 0.15, we get more worried. Like everything else, it's not a bright line. You know, the lower the better, the higher the more concerning. It's something we know for free on everybody, because everybody has had at least an ultrasound to get the diagnosis. So it is an easy marker to track, for sure.
Here's Matthew Cooperberg, screening for prostate cancer, just came out a few weeks ago. By the way, he's prolific. He's not just, doesn't just tweet, or is it tweeter? Is that the word, tweeter? Sounds funny. Anyway, he's out. He's constantly publishing. He's got to be the most prolific, one of the most prolific people in medicine right now, publishing it all over the place. So he commented on a fairly amazing study that looked at polygenic risk scores, and it helped tell us possibly, right, who should be treated or not. Can you first explain what polygenic risk scores are, and what was your conclusion here? Are you more excited about them or less?
Sure.
And I see it coming.
It's coming. Like many things, it's coming. So this was a letter to the editor in reply to a paper that came out from Jana McHugh and her colleagues. We were literally just this week, this is all very timely, we were literally just on a call this week through the Prostate Cancer Foundation that she was on, presenting this trial called Barcode, which was in the New England Journal of Medicine a couple months ago. And what Barcode did was they compared traditional PSA screening with upfront screening using PSA combined with a polygenic risk score. So this is a genetic test where you look, not just looking for mutations in things like BRCA and ATM, but looking at a whole bunch of SNPs. SNPs are called single nucleotide polymorphisms. They're just changes in the letters. They're not even changes. They're just differences in individual letters in the alphabet of your DNA, right? You've got 3,000 letters that make you, that can comprise the DNA. We chop up those letters into 30,000 paragraphs. Those are the genes. And depending on how we spell the words in each of those genes, the proteins that the genes are specifying are slightly different. And you can start to look for differences in the letters and track them across populations. And by looking at sets of polymorphisms, so not to say mutations, not to say errors, just differences in DNA, you can tell people you are higher or lower risk for various things. So there are a number now of these polygenic risk scores. It's about 250 different markers they look at that can tell us something about your risk of having prostate cancer, yes or no. There's an argument, and they try to make the argument that our letter was basically in reply because the argument that we are going to do a first screen by reading your DNA and trying to come up with the likelihood of prostate cancer with a somewhat complicated genetic test and trying to get a primary care doctor to do this is just not happening. PSA is $20, under 1, you're done. That's 75% of the population, you're done. I think where these tests will be very helpful is for the other 25%. So if your PSA is over 1, then this is now in the space with MRI, with all these other tests to say, how do we interpret the PSA? Okay, if your PSA is 1.8, but you've got a really favorable PRS score, we're not going to worry about this. On the other hand, if you've got an unfavorable score, family history is more likely, et cetera, we need to track this much more commonly. Now, where the other place this is going to happen is as people start to get their whole genome read for no particular medical reason, just like they get their whole body MRI at Pronuvo for absolutely no particular reason, this will be one of the things that we just happen to read off the whole body, the whole genome. And you can bring this to your primary care doc and say, look, I'm a low PRS, I'm not going to do a PSA test. Okay, maybe. But that's not, when we talk about screening and saving lives, it's the folks that don't have access to whole genetics that we really need to be focusing on.
Okay. So you just talked about little snippets, but every patient has this potentially available today. It's germline testing, right? Just the genes you were born with and looking for main mutations in those, BRCA, ATM, or maybe they have a certain syndrome. So let me set this up because I don't know what his answer is. I sat at this meeting 10 years ago and I said, well, okay, why aren't we just doing this for advanced patients? And they said, well, we don't have the data. So today, if you have advanced prostate cancer, everybody automatically gets this test, right?
They should.
So what I said to him 2 or 3 years ago, I said, Cooperberg, it's coming. Which I mean is, look, why isn't every man diagnosed with prostate cancer today automatically offered germline testing if, at the very least, it tells you that you might have a gene that might make you a bad active surveillance patient, it might change your prognosis so you want to get treated, any patient can get this and pay for it. Why isn't this offered to everyone diagnosed now? Give me the answer I want, Cooperberg. What's your answer? Tell me why everyone in this audience who has been diagnosed with prostate cancer should not get a germline test?
So the answer to that question, the answer to the hard part of that question is that the yield is actually really low.
Right.
It's the same as the general population. So if you have low-risk prostate cancer, or even intermediate-risk prostate cancer, and you run one of these tests, about 3% of men will find something which is comparable to the population of men without prostate cancer. So the guidelines now, every time we talk, the guidelines include more and more people.
That's right.
In like who should get a test. So it was everybody with metastatic disease. Now it's everybody with high-risk disease, everybody with unfavorable intermediate-risk disease, everybody who's Ashkenazi Jewish, everybody who's got a family history of prostate cancer, of breast and ovarian cancer in the family. You know, it's more and more and more of the the pie chart of men with prostate cancer is more and more slices who should get a test. It is still not low-risk disease or favorable intermediate-risk disease because they look no different than the general population, because again, they don't really have cancer. There is a really interesting debate going on, which I don't have any updates since we talked about this last year. Should men with a BRCA mutation be eligible for surveillance? There's still only one paper published which shows a higher rate of reclassification to high-grade disease if you have a BRCA2 mutation.
Yes.
And I have colleagues in the country who are good, big advocates for surveillance who say they treat everybody with a BRCA2 mutation because they're worried about this. I don't think that's correct. If I have someone with a BRCA2 and a grade group 1, we say, look, you're more likely to need treatment at some point. That day is not today. We're going to follow you more carefully, but I will absolutely surveil them. And you have to be really careful about these mutations. It's really interesting, and they're still sorting out why. Yeah. There are some families with a BRCA2 running through the family where all the men have prostate cancer. There's other families where all the women have breast and ovarian cancer and none of the men have prostate cancer. So there are details about which letter is altered, which mutation happens to run in the family that affect its what we call penetrance, its ability to actually cause problems. And you really need to drill into these details before we overtreat grade group 1.
So every man on active surveillance is not offered this right now, this testing, or is it at least discussed?
Not routinely discussed, not for low risk.
Okay, so we said it's about 3%?
3% will have something. Okay.
So that means if I take the conference registration here, that means 15, 20 of you in this conference. Yeah, have a nice day. It's a large number.
Yeah.
And so I'm just telling you, I don't get this because I just think, I don't understand why it's not even a discussion. I don't get it.
The reason is it is supposed to be, and how much people actually do this in practice is variable. It is supposed to be a whole discussion before you order one of these tests, because in theory, there are risks of losing insurance coverage, et cetera. Once you are known to have a mutation, you can't sort of unknow it. It's in the medical record. There's supposed to be this whole consent process. The reality is, I think these days we order pretty frequently and save the counseling for if we actually find something. But there is not, because of that issue of, you can't put that genie back in the bottle, there's not a general recommendation about broad genetic testing.
I appreciate that. Yeah. But I do also appreciate that a lot of men you told to be on active surveillance said, listen, Cooperberg, you're an amazing surgeon. I still want you to do surgery on me. And you didn't go, get the hell out of my office. You know what I'm saying?
Yeah,
so what I'm saying is that it was a pro and con discussion.
Absolutely.
And I'm just telling you, when you're here next year, I'm being optimistic of the year after, it's going to start moving into guidelines.
I think it will. I mean, I totally agree with you. It's incredible. It's a cheap test, and there's very little downside. But to answer the question is why we're not doing it pervasively. I think that's the reason.
Yeah, I'm not even saying everyone should have it. The discussion should be there, because I don't want to find out 3 years later that I had it and I could have had the test. Yeah. And if someone doesn't want the test, that's their prerogative. Anyway, I've got off my soapbox. Well, let's finish up with this. I went digging in the archives and I found, he's an incredibly skilled surgeon too. I found an amazing picture of you as a child, so I understand why you were going to be a prostate surgeon. You needed to spend your time being a prostate. Can you believe I found a picture of you as a little kid? Can we go to slide 18 and show that photo of him? Look at that. So
it's all right.
Right? So you needed to do something with a knife, and so you found a better way to utilize it, I guess, right?
I was such a towhead, wasn't I?
Yeah, I'm just saying, it's incredible I found that picture of you. All right, but I've given you already every gift, so then I thought, wait a second. He's such a nice guy, and I always found something the most fascinating about him is that he married a dermatologist. So that's like the ultimate couple at dinner. The ultimate couple. I can ask all the different questions on prostate. I can say, hey, check this out. And your wife was supposed to come with you on this trip, but I think you have to head back, so she couldn't, right? Yeah. So I thought, forget Cooperberg, see the male Cooperberg, I'm going to give his wife a gift. Are you ready for this? And it says, I don't know if we have a picture of it. Anyway, you can read it. I gave him a cup with a saying, and can you tell him what the saying is?
Yes, I am a dermatologist. No, I cannot look at something really quick.
Yes, I'm a dermatologist.
Really
no, I cannot look at something really quick, because all my dermatology friends, they go crazy,
awesome.
right? So I think she'll love that. Good seeing
Thanks
you,
so
my
much.
man.
Thank you, thank you.
Absolutely. See you soon. Definitely.
Thank you.
Thank you, Dr. Cooperberg, and thank you, Dr. Moyad, and thank you to all of you who are watching. Please, if this was helpful for you, go ahead and give us a thumbs up and click that like button. Also, you can comment or put your comments in the chat or in the comment section below. And please, if you would like to support the work we do here at PCRI, you can donate at pcri.org/donate. I would also like to say a big thank you to all of our sponsors who helped put on our event today: Bayer, Pfizer, Astellas, Janssen, Novartis, Dendreon, Miradex, Blue Earth, Foundation Medicine, and AstraZeneca. We truly appreciate it. Now, our next speaker is Dr. Amar Kishan. He is the professor in tenure and the executive vice chair of the radiation department for UCLA. He does an incredible job just educating us, but he actually did a huge talk on SBRT that got thousands of views on our channel before. And he's back here in 2025 at our conference in September again in person, and he's giving us that update in 2025 of what we're looking at when it comes to radiation. Dr. Mark Moyad did an incredible job with moderating and just getting out even more information from Dr. Kishan. We really appreciated their time, and without further ado, here is his presentation. So today we're going to be talking about radiation therapy and side effects in prostate cancer. Now, this doctor came on our channel a couple of years ago and did a talk, and it has had tens and tens and tens of thousands of views. He is an incredible doctor. He's with UCLA. He's actually the professor and executive vice chair of the Department of Radiation Oncology at UCLA. How many of you guys have heard of Dr. Amar Kishan before? How many of you knew that's how you say his name? Oh, good. Okay, well, now we all know. So, Dr. Kishan has been an incredible supporter of PCRI. I'm so excited that many of you have known him. And he is going to go ahead and give us a presentation, and then we will have our wonderful moderator, Dr. Mark Moyad, come up and do his Q&A as well.
It's really nice to be here again. I gave a talk 3.5 years ago, and it's really nice to come back. So I'll be talking about radiation therapy and side effects. So I divided the talk into 4 kind of basic subtopics: radiation overview and basics. Then I'll talk a little bit about something called SBRT, which I think a lot of people may have questions. Nice to be here again. I gave a talk 3.5 years ago, and it's really nice to come back. So I'll be talking about radiation therapy and side effects. So I divided the talk into 4 kind of basic subtopics: radiation overview and basics. Then I'll talk a little bit about something called SBRT, which I think a lot of people may have questions about, which is a 5-day course of radiation. The third part is going over general toxicity, and the fourth part is looking at novel approaches to toxicity reduction. I just want to start off by explaining how radiation kills cancer, because I'm always asked this. Surgery makes intuitive sense. You're cutting the prostate out and removing it. How does radiation kill the cancer while leaving it in place? So cancer cells are defined by an ability to divide uncontrollably. Right, and it turns out that if a cell's DNA, which is genetic blueprint within the cell, if the DNA is broken and the cell tries to divide, it dies by a fancy term called mitotic catastrophe. What radiation does is it causes cellular DNA damage by breaking those DNA strands apart. When the cell tries to divide, which a cancer cell likes to do, it dies off. Now you might ask, well, can it repair itself? Turns out because cancer cells divide so rapidly, sometimes their repair machinery is not fully functional. So that's why they preferentially die off from this type of treatment. Of course, there can be side effects from radiation. I'm going to be talking about that. And that's due to damage to normal tissues, but cancer cells can be preferentially killed by this treatment. So again, you're kind of sterilizing the cancer in place. When it tries to divide, it dies off. The basics of radiation, first to know is it is a standard of care option for prostate cancer. It's a curative intent treatment. There are 2 fundamentally different types: external beam radiotherapy, EBRT, and implanted radiation or brachytherapy. Brachytherapy is a great treatment. I'm not going to spend as much time on that. I'm going to be focusing on external beam radiotherapy, and specifically a type of radiation called SBRT. In general, radiation involves a patient getting high energy X-rays that are directed towards the prostate by a linear accelerator. You don't feel anything, there's no heating or burning involved, but the person is not made radioactive from this. It's kind of an outside-in process. It's completely non-invasive. What you can see there are 2 of the types of machines we have at UCLA, just as an example. Up top is the Meridian. It's an MRI-guided linear accelerator, and the bottom is something called Novalis TX. It's a CT-guided linear accelerator. Broadly speaking, radiation is delivered over multiple daily doses over a certain time period. Now, historically, we could only deliver a low daily dose safely, but we knew we needed to get to a high total dose to eradicate cancer, so the treatment tended to be lengthy. You can see in the table there something called conventional fractionation. That used to be the standard treatment. 1.8 to 2 gray per day is the units of radiation. 39 to 45 total treatments turns out to be 8 to 9 weeks or so, because generally we treat 5 days a week. Prostate cancer appears to be more sensitive to a higher dose per day. That's unique in radiation and cancer biology, that it's that sensitive to a higher dose per day. And that allows you to explore shorter and shorter courses of radiation, potentially for effectiveness reasons and also obviously for convenience reasons. Moderate hypofractionation is a slight increase in the dose per day to 2.5 to 3 gray per day. There's 20 to 28 treatments, and you're kind of shortening the treatment duration to 4 to 5.5 weeks. SBRT, which I'll spend more of the time talking about, is really a condensed form where you're really increasing the dose per day. It's 7.25 to 8 gray per day, 5 treatments, and that's 1.5 weeks of therapy. So what is this? It's stereotactic body radiotherapy. Sometimes people call it stereotactic ablative radiotherapy, or SABR. That may have been a better marketing name, but generally it's SBRT. It's a form of modern radiation treatment where advanced precision is used to deliver high doses per day. And again, generally 5 treatments. Now, SBRT is the name of the technique or paradigm, but there's a bunch of brand names out there that you might hear instead, like CyberKnife, Novalis TX, TrueBeam, Meridian. These are machine names. That's a brand name of a device. The general principle is just a shorter course of radiation, SBRT. So let's talk a little bit about that in more detail. I'll go over some evidence for this. It's now considered a standard of care option for all men with localized prostate cancer. The National Comprehensive Cancer Network guidelines, or NCCN guidelines, were just published for 2026 on Friday, August 29th, and they list this as a standard of care option for very low through very high risk prostate cancer. That decision is made based off of 4 and more, actually, but 4 that I'll highlight studies that really support this. 2 randomized trials, which I'll go through, HypoRT-PC and PACE-B, and then 2 UCLA studies that I was involved with. So the first study was a randomized trial out of Sweden called a HypoRT-PC trial. They took men and randomized them to either receive high dose per day radiation or the long course of radiation, which was 8 weeks, conventional fractionation. Now, this did not use SBRT technically because they didn't use modern high precision radiation. This was old types of radiation planning. They didn't have all the fancy machines we have now. This was just more of a test of the biology of the radiation. So it's called ultra hypofractionation, not SBRT specifically. But what they looked at was something called failure-free survival, which you can see on the curve there. So red is the ultra hypofractionation, which is the short course radiation. Blue is the longer course radiation, the 8 weeks. The y-axis vertical is failure-free survival, living without experiencing a recurrence of the cancer. You can see that that's completely overlapping, right? So that really is a test of the biology that it is as effective to do this shorter course of radiation. It also showed no difference in late side effects. I'll show some more slides on that. And what this really means is it provided high-level evidence that this biology assumption was correct. Higher dose per day can get you the same effectiveness without an increase in late side effects. Now, what's really exciting is what hopefully will be published soon. So this is the 10-year update of that study. It was presented in May. This is a kind of grainy cell phone capture of a slide that was shown. This is now with an average or median follow-up of 10.6 years. I'll draw your attention to the fact that those curves seem to be separating. So they were completely overlapping in the first part, but now they seem to be going apart. And actually, there's a significant difference. At 10 years, there's significantly higher failure-free survival with the high dose per day radiation. You can see there, it's 72% versus 65%. So there's a benefit potentially with longer-term follow-up to doing this higher dose per day. And that doesn't seem to come at the cost of increased toxicity. What you're looking at here, these are called cumulative incidence curves. Genitourinary means urinary toxicity. Gastrointestinal means bowel toxicity. The solid lines are grade 2 or moderate toxicity. That means, a medication can generally treat that, whereas the dashed lines is more significant, severe grade 3 toxicity. Those curves are also overlapping, the red and blue. There's no difference in the late incidence of moderate or severe bowel or urinary toxicity with this approach. So that's also pretty reassuring. The second randomized study in this space is something called the PACE-B trial. This was published more recently in the New England Journal of Medicine last year. This was a trial of SBRT proper. It was run in the UK, basically 5 fractions of radiation versus a mix of either the 4-week course or the 8-week course. In Britain and generally in the UK, that 4-week course is standard, so 2/3 of the patients on the control arm got that. They also looked at something called freedom from biochemical or clinical failure, which basically means not having a recurrence. Now, those outcomes are actually incredible. If you look at that graph, there doesn't even appear to be any events, because the 5-year freedom from biochemical or clinical progression was 95.8% with SBRT. Now, the longer course radiation also did well, but that means 96% of people were free of disease at 5 years with only 5 treatments. And this included people with unfavorable intermediate risk disease as well. It was not a trial of low risk prostate cancer. This is intermediate risk prostate cancer. So those are very exciting results. Now, if you really zoom in and you can see that inset curve there, then you can maybe see, they're still not significantly different, but there is a little bit of that separation that was appearing in the older study that I showed, that we saw with long-term follow-up. There does appear to potentially be a benefit to the 5-day course of radiation. It's not proven, but the curves appear to be separating. But at any rate, at least shows they're equivalent and both highly effective. Provides high-level evidence of this. Now, there was a slight signal of increased subacute urinary toxicity with this higher dose per day radiation, which I'll go over. If you look at the top graphics on the slide, you can see that at the upper left is kind of urinary toxicity, and on the upper right is bowel toxicity, right? And it's divided into mild, moderate, and severe. The first thing to point out is that the rates of toxicity are really low. So if you look at the moderate toxicity, for instance, it's less than 10% of patients experiencing this even at long-term follow-up, which is good. That means that modern radiation, I should say, is quite effective and safe. Now, early on, between 18 to 21 months or so, maybe a slightly earlier, around 9 to 21 months, you could say, there does appear to be a little bit more moderate urinary toxicity with SBRT. This is a flare of symptoms that occurs. There's no difference at later time points, but there is a signal there which we can't ignore. It doesn't seem to appear for bowel toxicity or for severe toxicity, but really for that moderate urinary toxicity. Why could this be? Either it's really that higher dose per day that's causing this, it's something related to the genetics or the precision of the radiation, and I'll get into those things as well. But another possibility is that this was a multi-institutional study across the entire United Kingdom. And the authors did publish that, centers that treat more SBRT cases, they had been doing it for longer, they had different machinery perhaps, had less toxicity. The toxicity rate actually ranged from 0 to 32% depending on the center. So that's something to keep in mind. But also importantly, if you look at the patient-reported outcomes, which are the bottom 4 curves there, looking at urinary incontinence, urinary obstruction, bowel, and sexual function, anything going down indicates a decrease in patient-reported quality of life. Many of you have probably filled out these questionnaires in a doctor's office, so you've seen some of these. This is what the result is when you add all the scores together. There is a slight dip in quality of life, generally, in the short term after radiation for obstruction, bowel, you can see that, but it tends to normalize pretty soon thereafter, and there's no significant difference between the types of radiation. So again, pretty reassuring. The third study I'll talk about is one that I had the fortune of leading at UCLA. This was a consortium study. In the US, North America, we did not have any randomized trials of SBRT. Instead, certain institutions decided to do their own small phase 2 trial, and Accuray, a vendor that makes the CyberKnife device, did 2 multi-institutional trials. They're all phase 2, meaning everyone got SBRT. So our idea was, well, a lot of patients have received SBRT. We should have data on them. Why don't we study, that pooled outcome? So these data are from 2,142 patients with a median follow-up of 7 years, which is pretty good. And you can see the control rates in the real world here are very good. So 7-year biochemical recurrence of 4.5% for low-risk prostate cancer, up to 14.9% for unfavorable intermediate-risk prostate cancer without hormone therapy is pretty good, right? And this is in the past. These men were treated from 2000 to 2012. So that was reassuring as well, and got this cited in the NCCN guidelines suggesting the safety of this approach and efficacy of this approach. And I think this is important too, At the bottom, you can see rates of toxicity, severe toxicity, which is grade 3 or greater. For urinary, it's 2.4% at 7 years, and for bowel, it's 0.4% at 7 years. The onset of these side effects tend to be within 3 years of radiation. And reassuring, if you look at those graphs, what those bar graphs are showing is essentially the rates of toxicity with different types of radiation on well-published trials. Something further to the right means a higher rate. The SBRT is way down at the bottom there and appears to compare really favorably to the other types of radiation. Now, everything I showed so far was predominantly in intermediate risk prostate cancer. The UCLA consortium did include some low-risk prostate cancer. The Swedish trial had some high-risk prostate cancer, about 11% of patients, but nothing specifically for high-risk prostate cancer. So we had a trial at UCLA for high-risk prostate cancer, SBRT. A couple of other institutions across the world did as well. So we pooled everything together. This was something called a SHARP consortium. It was published 4 years ago, so this is slightly outdated, but it was 344 men with high-risk prostate cancer, average follow-up of 4 years. And I'll draw your attention to the cure rate, which was at 4 years, 82% overall. And for men who got hormone therapy, which is part of the standard for high-risk prostate cancer, that's that blue line there, that was 87% at 4 years. So pretty effective as well, reassuring from those regards. And we do have an update pending of this. We presented it earlier this year, but this is now with 445 patients, so more patients, a median follow-up of 5 years, and really got the ability to look at different approaches with SBRT. And one thing we wanted to look at is something we think of as an extreme dose-escalated SBRT. I'm sure this may come up in the question session, with about 12 months of hormone therapy, which is kind of our standard for high-risk prostate cancer. That performed really well. The 5-year biochemical recurrence was 7.2%, and the distant metastasis was 3.6%. So considering for high-risk prostate cancer, including Gleason 9, Gleason 10, that's a very good outcome. So we're happy to see that. Now, how is SBRT delivered? And this applies to any form of radiation that's external as well. So the prostate is actually a moving target. We don't think about that, but over the span of 2 minutes, the prostate is moving front and back about 3 millimeters, up and down about 3 millimeters, and side to side maybe 2 to 3 millimeters. You take that, and you also take into account the fact that we're treating from the outside in. So the patient is lying on the table, we're trying to line up everything. There could be a little bit of uncertainty to that. If we treated just the prostate, we might risk missing things. So we need to treat the prostate with a margin around it. It's called a planning margin, to account for some of these uncertainties and particularly the motion. That margin depends on your confidence as the physician in terms of designing that radiation plan and the accuracy of delivering that, but it has to be some number. It used to be a broader margin, but with better technologies, we've kind of reduced that down. With CT-guided SBRT, and this applies again to other forms of radiation with different doses per day, the idea is you put metal markers into the prostate, 2 in the apex, 2 in the base and 1 in the apex typically. So that gives you kind of an ability to triangulate the prostate. You can't see the prostate well on an X-ray or a CT scan, but you can see markers easily on those images. So when a patient is on the table, we get these images, we are able to line up based on these metal markers, and then we initiate the treatment. Now, that controls motion between treatments, but during the treatment, we still need a margin to account for that. And that can range from generally around 4 to 5 millimeters. So for example, our practice had been to be a 4 millimeter margin around the prostate with this type of approach. You can repeat x-rays to try to realign during the treatment, or you can try to complete it very, very quickly. So those are different options there. This leads a little bit to something called MRI-guided SBRT, which is where you're using a different machine that has an onboard MRI. Now, in this approach, you don't need the markers because you have the MRI actually to visualize the prostate, but the true benefit really is the ability to visualize a lot better the prostate during the treatment. So for example, the Meridian platform, which is one of the 2 main MRI LINAC devices, you can get an MRI 4 to 8 times per second while the patient is being treated. If the radiation machine on the MRI detects that the prostate has moved too much, the beam can be stopped automatically. So that allows an extra degree of confidence and really allows you to kind of monitor the motion very closely, so you can shrink the margin from, say, 4 millimeters to, say, 2 millimeters. A picture is worth 1,000 words, but a video is worth 1,000,000, so this will be helpful. You can see outlined in red the prostate and outlined in yellow the gating margin around the prostate. This is a patient that's being treated. You can see there is some motion, even these sudden motions where you can see that prostate is moving forward. If we didn't see that and account for it, the front part of the rectum would be potentially overdosed with radiation, and the front part of the prostate would have been underdosed, right? So again, that's why we have a margin. But if you're able to see this and you're able to pause the beam, I don't know if you can see in the bottom there, there's something that says beam on or off. If that red is too much outside the yellow, the beam automatically turns off. That allows an extra layer of precision. So we did test this. We said, we're going to do a trial where either patients get a 4 millimeter CT guided SBRT, which is great and effective, and all the data I had shown so far were with that approach, or we'll use this new machine that can really track things more closely, and we reduce that margin to 2 millimeters. Reducing the margin to 2 millimeters means less bladder, rectum get exposed to radiation, so we would assume there'd be less toxicity. But the way to prove something is with a trial. So we did that randomized trial that ran from 2020 to 2021. It was called the Mirage trial. I like acronyms. It showed that there was a significant reduction in toxicity. We went from 43.4% moderate urinary toxicity to 24.4% within the first 3 months of radiation. And bowel toxicity went from 10.5% to 0% within the first 3 months of radiation. We also looked at patient-reported outcomes, and they appeared to be favorable as well. Obviously, short-term toxicity is one thing, but we want to look at long-term toxicity too. We just published this last year. It's a 2-year update of this group of patients, and you can see the benefit is still there. For urinary toxicity, grade 2 or greater, we're reducing that from 51% to 27%. And for bowel toxicity from 9% to 1.4%. So that's meaningful for patients. That's a big reduction in toxicity. But if we, this is even more important, if we ask patients themselves to tell us their quality of life, and again, many of you have filled out these forms, questions asking about urinary incontinence, urinary irritation, bowel function, sexual function, the International Prostate Symptom Score, which is a marker of kind of how much obstructive symptoms you have or how frequently you're urinating. And then sexual health inventory for men is a marker of erectile quality. What this table is showing you, what an odds ratio is how much are the odds reduced with one intervention versus the other. So anything less than 1 means less odds of problems in these areas if you have the MRI guidance. And you can see all of them are less than 1. There are 2 in particular that reach the level of clearly statistically significant, meaning without a doubt it is improved, and that's bowel function, which had a 56% reduction in odds of bowel bother with the MRI guidance, and sexual function, which had a 63% reduction in bother with the MRI guidance. So this is, again, very meaningful for patients. And on that note, I'll talk a little bit about SpaceOAR. Again, I'm sure that's something that would come up in the question session as well. Everyone asks about this. This is an absorbable gel that can be placed between the prostate and the rectum in patients who have a prostate. So not necessarily in the post-operative setting if someone is getting radiation after a prostatectomy. And it introduces a physical separation between the prostate and the rectum. You can see there on that image that moves the rectum outside of that margin area, and they could have less high-dose exposure to radiation. Radiation is like a light, as I explained to patients. The further you are from it, the less bright it is. The further you are from the target of the radiation here, the less dose it receives. Does that actually lead to less toxicity? Well, the SpaceOAR product specifically has been studied in a randomized trial, and it did. You can see that in the bottom there. Grade 2 rectal toxicity was reduced with the use of the spacer. Now, if you look at the y-axis, you can see that it actually goes from 0 to 20, and that reduction is really going from like 5% to 0%. So people without the spacer do quite well also, but it did reduce toxicity. Who's not a good candidate for this? Somebody that has cancer that's clearly extending out of the capsule of the prostate in the back is maybe not a great candidate for this. And anytime you have a procedure, there's a risk of infection, there's a risk of bleeding, there's a chance the gel could infiltrate in the rectum. So it does require a balanced discussion, but it does appear to do its stated function. And it can be confusing, but so what I showed was Spacer, OAR, which is a product. The general concept is called Spacer, like S-P-A-C-E-R. And there are different products on the market now, including Barrigel and BioProtect, that are FDA approved. This is a very recent paper that tried to put together all the clinical trial data, because each of these products does have a randomized trial. You can see grade 2 or greater toxicity means, again, moderate toxicity, you need a medicine for it. Grade 1 or greater is mild toxicity. These products in general seem to improve both grade 2 and grade 1 mild toxicity. Both grade 2 and grade 1 early toxicity, and clearly improve grade 1 late toxicity with an effect that appears to improve grade 2 late toxicity as well. It's that same thing with the statistical significance. It didn't quite meet that, but it's an effect that's clearly favoring the use of the spacer. Let's talk a little bit about other types of toxicity and in general what someone will experience with radiation. So the side effects from radiation can be divided into acute, which is within 90 days. Generally, this recovers, and late, which is beyond 90 days and tends to, can recover as well, but can be more bothersome. More people are concerned about late side effects. We're concerned about urinary, bowel, and sexual toxicity. Fatigue is another possible consequence of radiation. So urinary toxicity can really be encapsulated by something called the International Prostate Symptom Score. Everything that's listed there, straining, urinary frequency, incomplete emptying, weak stream, nocturia, which is getting up at night to urinate, those are the potential side effects in the short term of radiation. If I ask my patients to fill this out in clinic before they see me, and then I go over this with them and say, when you get the radiation, these numbers are maybe going to go to the right about 1 to 2 points, and that can peak about 1 month after the radiation is done and mostly recover, but maybe be a little bit worse than before, but kind of come down. But those are the main impacts of the radiation. Obstructive symptoms like weak stream, incomplete emptying can be treated with NSAIDs like ibuprofen or medications like tamsulosin, which is Flomax. Urgency and frequency, there are medications for that as well. Incontinence, which is leakage, is pretty rare with radiation. Bowel side effects, something called the EPIC 26 questionnaire that we also give to patients, kind of lists out what those could be. There's urgency, there's frequency, losing control, which is thankfully very rare, bloody stools and pain, which usually are in patients who have a hemorrhoid that gets exacerbated. Overall, bowel bother is less common than urinary bother. Diarrhea-like symptoms, if they occur, can be treated with medications like loperamide, which is Imodium. Rectal pain, if that happens, can be treated with either over-the-counter hemorrhoid medication, or there's actually a steroid suppository that's very effective as well. And I like to show this just to reassure patients, right, about what the time course of these side effects would be. This is from one of the trials, the PACE-B trial that I went over in more detail earlier, and it lists out patient-reported outcomes for different types of side effects: urinary incontinence, urinary obstruction, overall urinary bother, bowel bother, sexual toxicity, and hormonal toxicity. Anything going down means, there's a decrease in quality of life. You're experiencing those symptoms. If it goes back up, that means it's recovered. Reassuringly, all of these that tend to go down seem to come back up very close to how they were at baseline by about 12 weeks after radiation. The peak symptoms seem to be around 4 weeks, which is 1 month after radiation. So I tell patients, these symptoms can peak around the 1 month mark, and then they tend to recover close to baseline by about 3 months after radiation. Late toxicity can occur, of course. Serious, severe late toxicity is thankfully less frequent with modern radiation. Based on large trial data, it's about 2 to 3% chance of a significant urethritis, cystitis with modern radiation, and a 1% chance of significant proctitis or bowel side effects. These can be treated with hyperbaric oxygen. They may need a surgical procedure to fix as well, like an argon plasma coagulation or a cystoscopy or a dilation procedure. The chance of a radiation-induced cancer is not zero, but it is thankfully very low. Sexual toxicity is rare acutely unless you're on hormone therapy, although there can be a loss of ejaculate or very early after if you have fiducials placed or something, there could be blood in the semen. But the major long-term side effect is erectile dysfunction, which can occur. The estimated rate is about 23% of patients within 2 years of SBRT or any form of radiation. And it looks like it's more of a vasculature or blood vessel related phenomenon. So you can see the neurovascular bundle, which you hear a lot about in surgery, where it's really the nerve. Here's the vessels near the nerve that can be affected, and it can narrow the blood flow, essentially, or it can narrow these blood vessels, one way to think about it, to impede the blood flow. This can also impact the larger arteries called the internal pudendal arteries. Low daily doses of sildenafil, which is Viagra, or tadalafil Cialis may help limit this impact if taken for about 6 to 12 months during and after the radiation. And finally, the last portion of the talk, I'll go over some novel approaches to reduce toxicity. One is tighter planning margins, and I already talked about that with the Moyad study. That the proof of that is essentially if you treat, and it makes sense, obviously, if you treat less normal tissue, you'll have less side effects. So increasing the precision of radiation. We showed that with the MRI guidance. It may be possible to do this with advanced CT guidance as well. We actually have an ongoing trial called the Illusion trial where we're looking at that. I'll spend more detail on the other three things: adaptive radiotherapy, radiogenomics, and neurovascular sparing radiotherapy. So adaptive radiotherapy is really changing the radiation plan based on the anatomy of the day. So modern radiation plans are based on a planning scan. And then we assume that the anatomy is the same at the time of the treatment, and then we deliver the radiation. We can use all the fancy technology, but essentially we're delivering it to the anatomy that we had at the planning scan. Earlier studies, including our own, have shown that things can change. The prostate can swell during the course of radiation, the bladder, bowel, rectum may be different shapes and sizes, the seminal vesicles can rotate and be slightly misaligned. So real-time adaptive radiotherapy is adjusting the actual plan at the treatment console. And here's just an example of a patient that we treated. You can see the mapping anatomy, the second treatment, and the fifth treatment. The prostate is swelling, right? You can see the dimensions of the prostate are increasing in all three dimensions over time. And remember, I was talking about 2-4 millimeter margins. So when it goes from 5.1 to 5.7 centimeters, that's like a 6 millimeter change in size. So that this is actually could meaningfully impact things. And you can see the bladder and the rectum are different sizes as well and shapes. So we're looking at this, and other places are as well. We're looking at this with an ongoing trial and a planned trial, which I'll skip the details of for the sake of time, but essentially looking at intermediate risk prostate cancer patients and hopefully launching the spiritual successor to the Moyad's trial called the Manticore trial. We hope to open later this year, which will be making this available for patients with all risk categories of prostate cancer. Other thing I'll talk about in a little bit more detail is radiogenomics. So this is the concept that different patients may respond to radiation differently, which makes sense. We know this is true for medications and something called pharmacogenomics. It should be true for radiation as well. Dr. Joanne Wiedus, who's been interviewed on the PCRI channel before, is a tremendous scientist at UCLA that has really pioneered this concept. We worked together to develop something called the Prostox test. This is a cheek swab-based test that looks at your germline DNA. That's the DNA you're born with, to look to see if you have a biomarker that could predict for more side effects after radiation. Specifically after SBRT, we do have other tests looking at longer course of radiation too. And you can see there in the publication from 2022, kind of the original proof of this. So the blue line are patients we don't think based on their genes will have toxicity. They have a 5% risk of toxicity. And this is moderate toxicity, not severe, but moderate toxicity. And the patients that we predict of having a high risk of toxicity really do. They have about a 55% chance of side effects, and that's really occurring pretty early, within 3 years. So we have done a validation trial. It's not ready to publish yet, but we have some exciting recent data. Here is one that really proves that this works, at least in another cohort of patients. What you're looking at on the left, these can be complicated, is on the y-axis something called sensitivity, which is basically having a low false negative, and on the bottom, the x-axis is specificity, that's having a low false positive. Anything in the upper left is pretty good, and this test does pretty good, whether you get MRI-guided or CT-guided radiotherapy. And it looks like your score on the test actually correlates with the significance or severity of the toxicity as well. So this is something that we think is pretty exciting. If you can do this at initial consultation with a patient, take a cheek swab and say, this may be the better course of radiation for you, or maybe you want to look at another treatment option, that's obviously an important thing to be able to do. The last thing I'll talk about very quickly is neurovascular sparing radiotherapy. Improved radiation delivery techniques and a better understanding of why this happens offers the potential to spare some of the important structures, like the neurovascular bundles, the internal pudendal artery, the corpora cavernosa, and the penile bulb, which are kind of outlined there. There are 2 trials that have looked at this. They're very early, but were presented earlier this spring. They had promising results, and we plan on looking at this as well. So that's just something to keep in mind to be updated in the future. I'd like to thank all my patients, and many of who I see in the audience today, the PCRI, my chair, my team, and some of my sources of funding. Thank you very much.
Okay, first of all, that's a really nice suit. I mean, he's clearly, that looks like big money suit. So you look at me, right?
Your suit right there.
My wife went to Kmart, she got this, I don't know, I found some pants. That's big money radiation oncology suit, that's all I'm saying. Do you have kids?
I do.
Okay. This is helpful. Let me give some background. We did a thing together 2 years ago. It got enormous attention on YouTube. It was really great. But what bothered me at the time is I found out that he got into the Harvard MIT medical school program. And when I applied to Harvard MIT, I think they sent back the application the same day with sort of laughter. And I thought to myself, well, this is a stupid program. Who gets into this? It's like 4 people. It turns out he got into it. So that shows you what's going on with me. Anyway, so that's kind of the background. And then the other background is I want to get your opinion on something extremely important. Slide 1, please. What do you think of their engagement? Are you kind of excited about it? I mean,
my older daughter is a huge Taylor Swift fan, so she's just excited that Taylor is happy.
Wow, that's a really good answer. Happy for how long, though? This is what I do because I knew it was the end of the talk, so I want to make sure no one leaves here without getting the little tidbits right. Okay, so first I want to ask you before we start through all this, SBRT, I mean, I got to tell you, it's definitely one of the hottest things going on, whether people agree or not. And part of the attraction is the fewer treatments, no doubt, right? But I think what I'm starting to get confused, and so are patients, and let me just give you scenarios, who potentially qualifies for your SBRT?
Yeah.
I have localized prostate cancer and I want radiation over 4 or 5 days. I qualify? That's just general, right?
In general, you qualify. We do some of the tests, to check.
Yes, but I'm saying for localized.
Yes,
right.
It is a standard of care option now.
Standard of care. Locally advanced prostate cancer.
It depends. As long as it's confined to the prostate without positive nodes, technically still allowed per NCCN guidelines.
Okay, what if I have positive nodes near the prostate and also cancer in the prostate? Do I qualify for what you're delivering?
You may. So it then sometimes comes to an insurance approval question. My opinion, yes, we have treated patients in that situation, as have others across the world, but it may or may not be approved by insurance.
I've had a radical prostatectomy and my cancer's back in the prostate bed where the prostate used to be. Do I qualify for your treatment?
No. There are clinical trials looking at this, but it's not standard of care.
Have you done any yet?
We have. We started I'm happy to talk more about it if you want.
Yeah, absolutely, because I think what's confusing people is that, look, this is a no-brainer. If I'm going to get radiation to the prostate, rather than go 40 times, I don't care what number you pick, I just go for 5 days. That's enormously attractive. So the next question you get, well, what other scenarios can I get this option? And I'm just trying to see where you stand.
Yeah, no, it's a great question. So in theory, it should be just as effective the same way it was, because the prostate cancer itself is the same.
Yeah.
What's different is maybe that connection between the bladder and the urethra, this anastomosis. Maybe it's slightly more sensitive to the higher dose per day. We don't know. Therefore, it's still being studied on clinical trials. If you're asking my personal take, we've treated about 260 patients on our clinical trials of this since 2018. I think in well-selected patients, it does actually very well. I think someday it will be a standard option, but 2025, it's not standard.
What about combining it? Let's say you have more extensive nodal disease. Yeah. What about combining your type of radiation with another type? Does that happen?
It does happen in some places. They do SBRT as kind of a virtual brachytherapy boost. Yeah. So certain institutions do that. So it's a whole different talk, but essentially, yes, it can be used as a boost to standard radiation instead of brachytherapy.
Okay, so now you've answered my question. Who's a bad candidate for your radiation?
Someone that, in my opinion, someone that has a high-risk Prostox test, it's on that slide there, that concerns me because that means that they're genetically more likely to have a significant urinary problem with it. So that's number one. Okay. But other things can also impact this. Very big prostates may not be ideal. I'm talking like greater than 100 cc's. May not be ideal. If there's a lot of pre-existing urinary issues, then it may be optimal to spread out the radiation a little bit more. Some of this is not proven, but it's my judgment call.
So really big prostates might not be ideal for your situation. So Prostox test, for those of you who don't know, and he explained it, it started, I think, with you guys at UCLA and gals, right?
Yes.
And it's a cheek swab, and you now do it on every patient?
Yes.
And the cheek swab basically says, hey, you might get a lot of side effects from my treatment, or you may not, right? It's just basically, it's sort of binary. It kind of tells you whether or not you're a good candidate, and everybody gets it. Does everybody get that test at other institutions?
Not necessarily. There are a couple of other institutions, I think, that are part of an early access program, but it's not universally ordered. Yeah. Patients can try to get it, outside of that, but they might have to pay money for it.
Okay.
There are plans from the company is called MiraDX. I think they had a booth outside today. I believe they are approaching the CMS, Medicare, to see if there can be insurance coverage for the test.
If I come see you, that test is not covered. How much am I paying for it?
I believe the out-of-pocket cost is pretty high. It's like $500, but.
Yeah, but $500 to tell whether or not you might get a big complication or not. That's one dinner in LA. I'm sorry, that's one appetizer in LA. I asked your chairman this not too long ago. Let's say you get this Prostox cheek swab test. How long does it take to get the results?
Once we get it at the lab, it's like 72 hours.
Okay, so that's fast turnaround. Yeah. Here's the scenario. I come see you, you give me the test, I pay for the test. It says, oh, Moyad, you're high risk, but this test is not perfect. It's a good test. Mm-hmm. The data's okay. Some of it's retrospective. I've looked at the data, and I'm going to go, you know what? This is what I want. I want Dr. K to treat me. I'm high risk on your test. Will you still treat me if I want to be treated?
I will. I would, counsel you that it's a potential higher risk of side effects, but as you said, it's a predictive model. Yes. It's not 100% certainty. As you mentioned, it was validated in retrospective, or discovered in retrospective studies, et cetera. So yeah, I do offer treatment. I have some patients that have a high risk result that still want the SBRT.
So you would still let me do it?
Yeah.
That's awesome. Okay, I like that. People have that option. Let's go to the next thought I had. Fiducial markers, putting that in. How difficult is that? When you put these markers in, and so the point is, can you explain the point of putting these markers in before you start radiation?
Yeah, the point of putting them in is because on most machinery you can't actually see the prostate, and it may be in a different position both day to day, and then as I was saying, maybe during the treatment it can move a little bit. So by having these metal markers, they show up on a CT or X-ray and allow you to really more precisely adjust for that motion that can occur. It's generally put in through a transperineal approach with local anesthetic. What that means is you're going with a needle through the skin between the scrotum and the anus, 3 pokes of a needle to put this in. There does have to be an ultrasound probe in the rectum at the same time. So it's not the most comfortable thing. Yeah. It's not that difficult to put in, but it's not the most comfortable thing.
And when do you take those markers out?
We don't take them out, so they're left in permanently.
See how I set them up for that? Yeah. I'm sorry. You don't never take them out. Is it okay to have those there the rest of my life?
It is okay to have them there. There's no reports, I think, of a prostate fiducial migration, so it should be safe.
Okay. But they're critical. The other thing I'm reading with a lot of you sort of bigwig radiation oncologists is you want me to believe that the type of radiation you're now giving, SBRT, it's a heavy dose of radiation given only over a few days, but that heavy dose can generate an immune response, that the prostate is very sensitive to that kind of energy, that when you cross that energy threshold, you may actually get ancillary benefits. Do you believe in that theory?
I don't believe that's relevant for this situation of treating the prostate only. It may have a relevance in metastatic prostate cancer, but not in localized prostate cancer.
Okay, so you think that, we're going to talk about that, so you think it has relevance there. So MRI and CT guidance, this is giving me a headache on the internet. It's like, should everybody be getting MRI guidance? You know, can you just sort this out? It's like these institutions are fighting over MRI or CT guidance. You know, do you do both? Can you do both? Is it more expensive? Why isn't everyone just doing one or the other?
It's a great question. So the bottom line is it depends on the margin. Whether you're doing that with an MRI machine or a CT machine, whoever is treating has to have the confidence that they're going to accurately hit the target with the margin they design. So if you think you can do that with a CT-based machine, you can do that with a CT-based machine. You know, there are techniques that are developing that allow tighter margins on CT. CT-guided SBRT is what all the data outside of, you know, our recent trial showed, and it is safe and effective. So I don't think, you know, patients need to fly across the country and, you know, go somewhere to one of these restricted centers necessarily. But at the same time, I do think the precision of the radiation is important. We did show that. So bottom line, just, you know, try to understand the precision of the radiation, what margin is being used, and kind of some of the technical details are important.
Do you do mostly just MRI guidance?
Mostly, yes.
Well, isn't the advantage that you don't get extra radiation?
That's one advantage, yes.
Okay. I mean, that's a big advantage, right?
Yeah.
Wow, there's one of, is that one of your family members?
Yes.
Okay. Let's say that you take care of my prostate, you radiate, but it comes back. Can you re-radiate, or is that just crazy and out of the question?
It can be done. Reirradiation now has some good data behind it, both brachytherapy reirradiation and SBRT reirradiation. There are published series, and it is certainly doable.
So you've SBRT'd twice somebody?
If someone has a prior SBRT, I personally would direct them towards another form of radiation. So I've sent those patients to my colleagues who do brachytherapy, but it has been published. Some people have done SBRT twice.
Okay. And then tell me what happens when you deliver all this energy to my prostate. It's a lot of energy. I heard it shrinks by half or 2/3. I heard it can turn into sort of fibrose into a hard ball after a couple of years. What is happening to my prostate as you're drilling it with this radiation?
It's a great question. The prostate is kind of shrinking. The normal tissue is scarring a little bit. It doesn't go to nothing because the PSA levels are detectable afterwards. They don't go to zero like after a surgery. But we've looked at MRIs after radiation. The prostate tends to shrink about 30 to 40%. It's not like it goes away. There's still something there.
Yeah.
But it does shrink, and the prostate is less functional.
Okay.
So there's lower PSAs, and there's also no semen volume.
Well, that makes me think of PSA, because everybody's following PSA after, you know, how soon can I expect some type of result from SBRT? Why do people tell me that the PSA is different after radiation than just kind of walking around without radiation? There's some kind of change in the kinetics. Can you explain that?
Yeah, so both the cancer, which is producing some of the PSA, and the normal tissue, which is producing the rest of the PSA, are impacted by the radiation, and both sources of PSA kind of go down, but it is a little bit complicated. Generally, I tell patients by 3 months after SBRT, the PSA should have dropped by about 30 to 50%, and then it kind of goes like this exponential decline after that. But it can bounce.
You do see bounces?
We do see bounces.
And how long do bounces last? Because that freaks me out.
It's a common cause of concern. They can last for about 6 months or more even, but generally it's clear when it's a bounce. It's kind of a patient that has a PSA that's decreased and it starts to creep up a little bit. These big volume bounces are not common.
And what about SBRT focal therapy? Are you going to be able to do just like focally, let's just say a half of the gland needs to be radiated? Do you do that, or is that?
This is where it gets a little bit controversial.
Okay.
I don't do that.
Okay.
I think there actually can be an issue with that approach. If you radiate part of the gland and then there's a recurrence, it may be complicated to re-irradiate again, although it's technically possible. So I don't personally do that, but could it be done? Yes.
Okay. It's a paper I did with a radiation oncologist out east, Greg Merrick, who's done a lot of brachytherapy. We published in 2005. We looked at their data, and we found that men who were radiated and were on a cholesterol-lowering drug tended to have a better potential outcome. And then we published that and started arguing, well, why aren't we just telling patients who get radiation to focus on their cholesterol and go on a cholesterol lowering drug? Go to the next slide, please. So that was 2005, okay? Stay with me. Then we learned, for example, like with Lipitor, we just kept publishing this data. Like, people seem to be doing better, they're living longer. Okay, that's interesting. And then nothing is really happening. So then this comes out in the past few years, which was kind of stunning. This was a statin drug used with certain types of chemotherapy and other cancers versus placebo at Mass General. And they found that the patients, essentially, when they were on chemo, had a greater chance of protection to the cardiac function of the heart. So those patients did better. Okay. Story still goes on. This is Larry Klotz in the Toronto group, did the largest meta-analysis, largest study so far in prostate history, so to speak. And they looked at people who were on androgen deprivation therapy, and they found that those men who were on a statin versus those men who were not had a lower chance of progressing and a greater chance of living longer. Okay, so that's the largest data set overall. And now let's look at Dr. K. Just published this and your name's on it. I thought that was interesting.
Yes.
And for those of you who don't think at PCRI we keep up with the latest data, we actually change slides up till the night before the conference to make sure that we are on top of things. So his name is on there in the middle somewhere. There it is.
Yes.
And you looked at 2 massive trials in advanced prostate cancer with a drug. And here's what you said. These findings suggest a possible role of statin exposure in patients with advanced prostate cancer. In other words, you found that they were living longer with conventional treatment if they were on a statin during a major randomized trial, and your name's on there. So you want to know what the question is, or do you think you know what the question is?
I think I can guess what the question is.
Okay.
Yeah.
So I'm going to let you guess what the question is.
Okay. So are statins helpful for patients undergoing radiation? I think particularly, I would say the main takeaway is cardiovascular health optimization is incredibly critical for any patient, but particularly someone that may be undergoing androgen deprivation therapy, and especially someone getting second generation androgen receptor therapy, which is what patients on those 2 trials were getting, apalutamide.
Yes.
Right. And
so that's our LEDA.
Yes,
right?
yes, yeah.
For the trade name. So they were on an androgen receptor blocker, one of the newer ones. Okay. Yeah. And then, sorry, keep going. This is making me happy.
So I mean, whether patients that are getting radiation without hormone therapy need to be on a statin, I don't know. I think data are probably strongest for people that are on hormone therapy because of the cardiovascular impact, particularly longer-term hormone therapy. Honestly, most of my patients are already on a statin. I'm not, to be honest, routinely prescribing a statin to patients, but I do counsel them on the importance of diet, exercise, and maintaining cardiovascular health, which is critical pretty much for everybody, but particularly for patients who may be on hormone therapy.
Okay. If the #1 cause of death in the United States for 100 plus years has been cardiovascular disease, the #1 cause of death in prostate cancer patients, the majority has been cardiovascular disease. If when the disease progresses, prostate cancer, it creates inflammation which can create cardiovascular disease on its own, all right? If most of these new prostate cancer medications are so great, which they are, but they do come with the side effect of possibly increasing cardiovascular disease, and the best evidence for anti-cancer effects in patients and to reduce side effects from medications could be to reduce your cardiovascular risk, and now could even increase the effectiveness of radiation and or androgen deprivation therapy, then what are we doing? Why aren't we just telling everyone to reduce their cardiac risk to 0 before you zap them?
I'm a big believer in trying to optimize cardiovascular health. Okay. I agree with you.
Okay.
Yeah.
Thank you. You just made my conference. Your name was on this paper too, and this is a major publication of a spacer, right?
Yeah, this
you were talking
Barrigel,
about spacer, right? But this is a hyaluronic acid spacer. Your name's on there. So this is Barrigel, for example.
Yes.
You've worked with that one too?
Yes.
Okay. They're the options that you have, Dr. K. Can you tell me which one you like the most, or you can't say that? And is this something you discuss with every single patient now that has a prostate that's about to undergo radiation?
Great question. So I can give my opinion. I will have to give 2 disclosures. One is, for that Barrigel trial, we were the central reviewer of the plans. That's why our name was on it, so potential conflict. Spacer, I have consulted for the company that makes spacer. So take that as you will. I do think, as we talked about in the lecture, these introduce a physical space between the prostate and the rectum. I've treated thousands of patients. It clearly reduces the dose of the rectum, and I am a believer in the fact that less dose is probably helpful. So I think in general, these things are helpful, particularly as we maybe get more aggressive with the dose per day, targeting specific lesions, etc. If we can use one of these, it's helpful. Some people are not good candidates for this. They have gross extracapsular extension posteriorly. We don't want to dislodge that with, trying to put this in. Now, we have the most experience with SpaceOAR specifically, and so I would say the top two on there tend to be what I would prefer. Mm-hmm. Keep in mind the disclosures I gave.
Well, but these sit in my body for a while, right? So how long does it take for these to absorb into the body?
Generally 3 months.
Okay, so I got to walk around with this in my body for 3 months?
Generally, yes, yeah.
Do you allow supplements during radiation, over-the-counter dietary supplements?
I want to review what they are. There are some data to suggest, or at least some theoretical concerns about antioxidants, and so those specifically I try to talk to patients about, but if it's before or after the radiation, like literally before or after, I'm not as concerned about it.
Okay.
It's really during the course of radiation.
Right during that time.
Yeah.
I, at this conference, have not been a fan of when people have side effects of radiation, they don't know where to go. So I have begged, since going back 2010, 2011, you kind of know where to go when you have a side effect of surgery. That's fine. But when you have a side effect of radiation, who's the radiation side effect guru? I can't name one. I can't. And so, first of all, I don't know where people can go. Are they supposed to go back to urology? But let's just go through, you can answer that in a minute, but let's just go through alphabetically some that pop up. And, I think, tell me if it's more or less due to the hormone therapy versus the radiation itself or neither, and this is completely embellished. Bone loss, osteoporosis.
That's the hormone therapy.
Okay. Bowel diarrhea.
That's the radiation.
But you say now Imodium for that. So people...
You can, if you're experiencing that, you can take Imodium. If it's a more chronic issue, it should be addressed.
Okay. Yeah. ED and/or incontinence.
That can be from the radiation.
Okay. Fatigue. I just feel tired after you radiated me.
Yeah, radiation can cause fatigue. Hormone therapy can also cause fatigue.
Okay. Fecal incontinence.
Radiation.
Fistula. Can you explain what a fistula is? It's something nobody wants.
Fistula is something nobody wants. It's a connection between two hollow structures. So it could be a connection between the bowel and the rectum, bladder and the rectum, or between the prostate and the rectum. So these are going to be major complications.
Yeah.
Yeah. They're very rare, but they can occur.
Lymphedema.
Lymphedema, I honestly have not seen that as a result of radiation, but it potentially could occur, I suppose.
Bladder inflammation from radiation cystitis.
Yes, so that can occur, as could proctitis.
And then, or radiation proctitis in the rectal area, bleeding or pain, right? So for that, for example, those two, radiation cystitis and radiation proctitis, there's things you can do, but once in a while, the radiation oncologists throw their hands up and say, I'm going to send them for HBOT, hyperbaric oxygen therapy. Are you a fan of that if you run into a problem? Hyperbaric oxygen?
I actually do think it's effective. Okay. There is a trial, at least for radiation cystitis, that showed efficacy, and I've used it on some patients. These things do occur.
Yeah.
I do think radiation has toxicity. People should be aware of that and follow their own patients to make sure they're counseling them.
For those of you getting freaked out by my list, there's a purpose behind it. And the purpose behind it is I always find it so interesting that when I stand up here or I travel, people always want to ask, for the pathologist, how many slides do you read in prostate cancer? And if you've read 10,000, you're a great pathologist. And they always talk to their surgeon and go, how many radical prostatectomies have you done? If you say 5, the person's running out the door. If you say 5,000, okay, that might be attractive. Why in the hell aren't we asking our radiation oncologist, how many times have you given radiation oncology to a prostate patient? That number should be pretty high, right? Because I don't think this is any different than other types of treatment where the real competent ones are very different from the ones that kind of do it part-time. Am I wrong?
I think there's validity to that.
That means yes. That's a Harvard answer. Okay, secondary cancers like cancer of the bladder, a second cancer from radiation. I know it's rare, but...
It could occur. Yeah.
Sperm banking. Do you tell men to bank their sperm before you radiate them?
I do, because of the second thing that you mentioned, which is that there's a low volume of ejaculate after radiation because the normal function of the prostate has decreased. So they may be producing sperm, but it would be difficult outside of like a Tessie or something to get the...
But they have less volume for their ejaculations in general, right?
Correct.
Right, okay. Testosterone reduction from radiation, or is that more just the androgen deprivation?
I think that would be from the hormone therapy.
Okay. Urethral stricture, which is like a narrowing of the urethra, which we now have treatments for, obviously, but is that rare?
It is pretty rare. I would put it in that 2% category, but it can occur. Yeah.
The last one I want to focus on is the one you always tend to write about when I read your stuff, and most radiation oncologists do. They talk, this is the one I hear the most complaint about, even if you're competent on it. Urgency and urinary discomfort, inflammation. It's just like, I got to get up, especially acutely in the short term. I got to get up. I just feel like I got to go. What do you tell people to do with that?
So if it's related to incomplete emptying, which is most of the time what it is, meaning your stream is weaker, you're not able to fully void, so you have to go more often. Flomax is very effective. Tamsulosin Flomax is very effective for that, so we use that frequently, as well as NSAIDs, which are things like ibuprofen, Advil.
Okay, that's great. So I can use Advil, I can use Flomax. Do you still use, so what I want to explain to the audience is there's a urinary tract analgesic called Pyridium. It's also known as phenazopyridine, and it went over the counter. You can buy it, like at every single pharmacy it sells as Azomax.
Yeah.
Do you recommend that once in a while?
More rarely, but if someone is having like this pain with urination or this burning sensation with urination, I do recommend that. Azo is pretty good, as you said. It's a little bit weaker than the prescription Pyridium, so sometimes we just prescribe Pyridium.
Yeah. I mean, I find that people tell us all the time they really like it, except you pee orange.
Yeah.
And that freaks people out, but it's harmless, right? I mean, it stains stuff. I mean, but I think that's impressive that that it's harmless, but you got to just deal with that orange. It helps a lot of people. There's some stuff coming out. It's freaking me out. And so it's really, you got to comment on this. There's this thing called Medicure. I'm going to take you to the end here. This was a phase 2 trial. It was just presented. They give SBRT to people who have metastatic sites, 3 or less, and then they give them hormone therapy, double hormonal blockade, right? They give them the pill and the injection, and they give it for a short period of time so they get rapid testosterone recovery. And they found that it did a great job of controlling their metastatic prostate cancer. And then we got another publication called, I think, it was 6 months of ADT plus apalutamide and SBRT. Same thing happened here, that it was controlling it for a while. Then this trial comes out from Italy, and an analysis in the past few months, I know you know this, but they demonstrated that, you know what, it's not just about you drilling those spots a couple times with metastatic. When they added a short amount of hormone therapy of some type, they had really long areas, time of remission, right? So this could be a game changer in the sense that maybe not just drilling those spots with the type of radiation you give, but drilling them with a little bit of hormone therapy and then quitting soon thereafter could put these guys who have metastatic disease in sort of a remission. Am I reading this correct, or is something wrong here?
No. I mean, I think that's a valid interpretation of the trial. You have it on there. We wrote a commentary for that specific trial. It was called Destroy or Delay. And the concept was, you're right, if you give hormone therapy, you delay the time to PSA rising again.
Yeah.
But the unanswered question is that actually because you gave the hormone therapy? We know that if we gave hormone therapy, we'll suppress cancer. So when the supplement in that paper, they did look at something called eugonadal progression-free survival, or how long patients are not having a recurrence when they have a normal testosterone, and that actually wasn't changed. So we don't know yet. It is possible that, you're adding the hormone therapy, so you're delaying a recurrence, which we know will happen, and I don't have anything against this approach, but we don't know if we're actually eliminating the microscopic disease or simply kicking it down the can by doing the hormone therapy. But either way, it's highly effective.
These guys who have metastatic disease with a couple spots, they're walking around undetectable for years.
The question is, are there
So the
other
question has to be,
approaches,
if you're going to do this for me, are you just going to drill these spots, or am I the kind of candidate that you want to add a pill or a shot to, right? That becomes a big question for the audience.
It depends on a couple of things. So if it's the first recurrence, if it's a low volume recurrence, where the recurrences is, the interval to recurrence, I think plays a role on whether there's more likely other disease or less likely other disease. And that could influence this decision. I don't always say you need to have 6 months of hormone therapy. There are patients I treat with just radiation. We'll have some more data on this pretty soon.
What I dislike about this is that people got to be told that whenever you're given any type of hormone therapy, I don't care if you're 61 or you're 91, that even though they tell you your testosterone is going to recover, in the majority of the time, your testosterone doesn't recover in general back to where it was. It just recovers to a number that's normal, but it's still lower than what it was before the therapy. So why in the heck are we calling this testosterone recovery? We should be calling it in clinical trials testosterone semi-recovery, so the guy knows if he started out with a testosterone of 400, he's more likely going to end up now at 250 or 300, but he's not going to get back to 400. So what am I complaining about? I have no idea. But the reality is, I just don't like this idea that we give you a short course of hormone therapy and it's like, don't worry, you're going to get your testosterone back. That's not true. That what's true is you're going to get most of it back or some of it back, but it's rare to get all of it back. Am I missing something here?
It depends on a couple of things, like the age. Younger patients may recover a little bit more than older patients. But that's exactly why I made the comment I made, that sometimes these patients are, if you actually measure from when they've recovered their testosterone, the improvement is not as big.
Yeah. Well, no, that's my therapy. I appreciate that. What I learned about you is you used to love these donuts.
Yeah, but they're out of business.
And they went out of business.
In LA, they went out of business. Their mothership in Portland is intact. But
I know, but you tell me these are the greatest donuts in the world, and then they went out of business. Yeah. Should I be worried about you?
You should. You should question.
Okay, so I just thought you've been such a trooper all the time that there's a new donut place in town. It's called Alex Sidecar. Everybody talks about. So we got you a ton of Sidecar donuts.
Thank you very much. Thank you very much.
And because you had to deal with this long, can you play the Jaws theme again?
This year, I had the honor of speaking at our conference back in September in person, and what I talked about was how to win or overturn an insurance denial. Dr. Mark Moyad and I worked together on this talk, and it was really great to just learn so much about insurance, but also what you can do to work through barriers if you do get an insurance denial. There's a lot of information that we found to be very helpful, and I hope you find this informative.
For this 10 minutes is a topic that we have been hit with for years, and we finally said, look, Alex, I appreciate your videos, I appreciate them with Dr. Scholz, but let's start moving into an area of advocacy that's uncomfortable. So she took the task on. So in 10 minutes, you will learn more than the average doctor, I think, out there, or healthcare professional, on how to combat an insurance denial if your insurance ever says no for anything. It doesn't have to just be prostate cancer. Ladies and gentlemen, the CEO, the king, the queen of PCRI, Alex Scholz.
So we're going to be talking about, first of all, how many of you have received an insurance denial? Okay. How many of you have Medicare? And how many of you have private insurance? Okay, HMO? No matter any of those three that we just talked about, these are talking about a couple key things. Number one, we talk about at PCRI that you're not alone. So we're going to talk about people who can be on your team to help you with an insurance denial should you find one. The second thing that we're going to talk about is this access. And then the third thing we're going to talk about is language. Now at PCRI, it's already one thing to be diagnosed with prostate cancer and to have to learn all this new language between the complicated names of medications and what type of cancer you have. Well, unfortunately with insurance it gets even more complicated because there's languages between doctors and insurance companies as well. And so it's important to know those. So we're going to talk about kind of a little hints of those as we go through who can be on your team to fight an insurance denial. So first of all, this is a talk written by me, but also written by Mark Moyad. So if you like it, I wrote it, and if you didn't, talk to Dr. Moyad. It's fine. So a special thank you to Dr. Eugene Kwan from Mayo Clinic and his wonderful team with Lauren Rhodes and Nancy Way. They did this talk on AI and insurance denials, and this was at our Men's Health Conference. It is on the front of our YouTube channel. So if you want to use an AI chatbot and you want an in-depth lesson on how to do it, this is a great talk for you. So you can see it again on the front of our YouTube channel. This is a very sad number to me. This is the total number in the United States of the percentage of insurance denials that are appealed, which means 99% of the time we are taking no as an answer and as the final answer to getting something that is life-changing for you as a patient. This isn't just in prostate cancer, this is across the board. And this is why people hate insurance companies, right? But the thing is, there are pathways that you can take in order to change this number, and as an advocate and an advocacy organization, I want to see this number changed. And so you all don't have to take no for an answer, and here's how. So the typical reason that you would get a denial, let's say you receive a denial letter. The reason is going to be inside that letter. So that's going to be our first piece of what we're going to use to fight an insurance denial. So this letter goes to your doctor. This letter also goes to you. And you're going to want to look at that letter, and inside that letter, it's going to be usually on the first page, and it's going to say the exact reason for that denial based off of what you are asking the insurance company to cover. This is about a 10-minute talk. We're already a couple minutes in, but these are what we're going to be going through in order to, and I'll just pause so you guys can take some pictures. But this is the things that we're going to use to talk about who you can bring on your team to remind you you're not alone, and there are options. First of all, peer-to-peer reviews. So what is that? This is when your physician talks to the physician inside the insurance company, and what they do is they sit down on the phone, they usually talk for 5 to 10 minutes. The office can make this appointment happen for you. Now, most of the things I talk about in this specific presentation are free. Sometimes, most of the times peer-to-peer are free, but sometimes physicians charge for it. Usually it's an admin fee for the office to set up the phone call. But overall, from all the data that I've looked at as we've researched for this talk, over 50% of insurance denials can get overturned from your doctor talking to the doctor inside of your insurance company. So these peer-to-peer, sometimes you see P2P. Again, we don't want to complicate it with language. But it's amazing that in 50% of these, you can get them overturned by your doctor going on the phone and saying, wait a minute, this is what they need. Why are we blocking this? What needs to be done? So it's an important point, and I personally, and Dr. Moyad also believes, this should be your first choice. You should call your doctor's office. Now, should you wait until you get a denial before you ask if your physician does peer-to-peer reviews? No. Just like we tell you to create a game plan for your prostate cancer case, know what stage you are, know what you're taking now, know what the game plan is for the future. You should also make a game plan for access and insurance denials, and know ahead of time if your doctor does this, and if not, who can? Because that's an important question. Next, we're going to talk about internal, expedited, and external appeals. So internal is when you're asking the insurance company to review what their denial was and overturn it. Now, expedited is within 72 hours, and you can do an external or an internal expedited appeal. This means it's medical necessity. It's life-threatening. So they can look at it within 72 hours and make their decision on whether or not the insurance company itself is going to overturn it. The other way is external. So let's say that the internal doesn't work. You need an outside body to look at this insurance denial and to review it as well. You can also get expedited external reviews. So there's different boards dependent on your type of insurance. So it's different for private versus Medicare versus Medicaid. But external reviews, there's a lot of different outside bodies that can help with this. There's federal, which is called Maximus. And then there's also your state. And I've actually seen genetic tests, like $3,000 genetic tests that were denied from Medicare Advantage plans be overturned in it's usually about 30 to 60 days. And so it's quite amazing to see. I actually have seen the letters myself and seen what the patient did to work through that process. So there's going to be more information later on how you can get access to this information. But again, this is just good to know because again, if we get, you get a no with the internal, then you get a no with the external. we still have a game plan. If this doesn't work, what are we gonna do? We're gonna make an appeal letter. So there's non-AI and there's AI. You can get a form letter of an appeal letter, and I know Dr. Kwan has talked about this time and time again. You know, denials, especially in advanced care, become a little more crucial as far as timing goes. But when you think about it, you create a sample letter, you get clinical terms that explain the medical necessity of why you need this treatment, and then you have to prove with evidence using NCCN guidelines. So that's National Comprehensive Cancer Network. Those are the guidelines that all insurance companies use to decide what they're going to cover. So you're fighting fire with fire. You're taking the exact reason for the denial. You're taking the guidelines of what the insurance company is using to approve it in the first place and saying they're going to cover. And then you take your insurance policy and you put that into the letter. Now, a couple of caveats. If you're using AI, please do not put personal information into this chatbot. No identifiable, don't put your ID, don't put your name, date of birth, any of it. Leave it all out. Put those reasons in. You can even ask the chatbots to give you the NCCN guidelines. And you can download it and then put your personal information in later, but please do protect your privacy because that's important. Now let's say that this is an overwhelming process for you. You don't want to deal with AI and ChatGPT and all this stuff, that's too much. Or let's say you do. If you do, go watch the video I mentioned earlier on the front of the website. If you don't, there are services online that can do this for you. Getclaimable.com, we have found this to be the easiest process. It's $39.99. Again, not everything in this talk for free, most is free, but for $39, $40, they go in, they take your information, you fill out a form, you pay their fee, and they help fight that for you. According to their website, 70% of their appeals have been successfully overturned. Counterforce says 75%. I found Get Claimable to be a little more easy to use from a patient perspective, but Counterforce is also very good. There are others, but they seem to be a little more physician focused, so I would focus on these two first. Let's say that they go through this process and you need more help. Let's just say that maybe you want to get this started, but you want to get some more people on your team. So then we're going to talk about your insurance hotlines. Your insurance has a phone number you can call to talk about why you are getting a denial and what barriers can be taken down, how they can help you get over those barriers and get access to what you need. And you can do it for your HMOs, PPOs, Medicaid, TRICARE. Every insurance company has this hotline, and they are meant to help you. That is their job. And so a lot of times you just get this nice person on the phone that'll say, well, this is not why it's not being covered, and let me see if all the information's correct. Now, there's a very specific thing when I talk about language at the beginning of this talk of why I think it's important. One of the things that I see happen often is tiny little changes in that language. When we see prostate cancer written on, let's say, a encounter note or something you're getting from your doctor, the insurance company says C61. Okay, well, C61 is what they say, and that's how they're going to cover it, and they're going to categorize it. So they have all these little numbers they're putting in. If one of those numbers is wrong in a subcategory, your membership ID is wrong, your date of birth is wrong, your name is wrong, you got to remember they have a lot of names in their system, so they're really going on your group number, they're going on your insurance ID number. Triple check that with these insurance companies and these hotlines, because a lot of times I've seen that there's just a missing number, a CPT code, something that's weird. And a CPT code, again, is that language. They go by CPT codes, J codes. These are how these drugs are covered. So let's say you need more help from these insurance hotlines, and this is just not getting you where you need to go. Human resources at your work, HR. Sometimes, they're the ones that are bringing in these insurance companies, and maybe they're more experienced because they've dealt with a denial before, and sometimes that's a resource for you. Caregivers, if you are overwhelmed, get help. That's the entire theme of PCRI, is we want to make sure you get help. So bring somebody on your team. If you have a union that you're a part of, you can call your union and work through them. And there's nurses and social workers at large hospital systems. You can call your doctor's office and ask if they have them. These are unsung heroes who do this as just part of their everyday job, but it's a great resource for you. But again, let's say we need more help. Let's say we're just still receiving that denial and we need that treatment. You can call the drug or imaging company for the specific treatment that you're getting, and they have what they call access services. And I sit on ad boards for these drug companies. I do all sorts of things talking to them, and I listen and I give them feedback on behalf of patients. And I can't tell you how many times I'll hear about access programs, and then I'll ask, well, to what percentage is it utilized? You can get co-pays, you can get lower rates, you can get sometimes free drug samples. I know Bayer Pharmaceuticals will give you a couple drugs, they'll give you the drug for a couple of months in order to make sure that you're covered until you get insurance coverage. And they work through these whole processes when they get denials. And they have social workers, they have nurses who do this. And so they're called access programs. And time again, I'll ask what those utilization rates are. It's like 30%. Which means patients don't know about it and they're not calling. But not PCRI, they're not PCRI audience, not the PCRI family. We're gonna call. We're gonna utilize those programs. They're gonna be listed on the website. Let's just say that you've called the companies and now we need more help. Again, most of this is free. Legal help is not free. But there are legal reviews, legal teams and legal companies and lawyers who do, and they will look at your rights. They'll look and help you write a stronger appeal letter, and they'll help you with filing a complaint. And again, they can do those outside and external reviews with you, and they can get the federal government involved, the state involved, that have to hold these insurance companies a lot of times accountable for what they're saying they're going to cover. This is not a free resource, but we've also talked about unsung heroes. Another unsung hero is advocacy groups. That's what PCRI is. We're advocates. Our job is to help advocate for you. Well, the American Cancer Society, which we know for giving us these big statistics where it's like, this many people are diagnosed with prostate cancer every year, they actually have a portion of their website dedicated to insurance denials. You can call them. Patient Advocates, Advocacy Foundation, they have patient advocates who focus specifically on getting insurance denials reversed. This is what they do all the time across all types of cancers, and sometimes they learn tricks in breast cancer that work in prostate. They're just very experienced at it. They're nurses and they're social workers. It's very important. And then Triage Cancer actually brings in legal social advocates. So these are important resources for you, and advocates, they do this full time, and they are a tremendous, tremendous resource. As I've stated before, we believe that insurance denials at PCRI, we believe that they should be challenged. It is insane. When I talk to a patient, you're already dealing with so much. It's taken your time, it's taken your mental capacity, it's stressful, it's emotional, it's dealing with your own personal life, and then on top of it, somebody's gonna tell you that you can't get the drug you need access to that's gonna save your life. That is insane. That should not be the case. But unfortunately it is, but we want to help. So, what did we do? We launched an entire portion of our website where everything I talked about on this talk is there in detail. The websites, the phone numbers, sample letters, the talks that we've given before. It's all in one place. You can go here, you can get to the other advocacy groups that are there, and it's already on the website live today. So that's all I wanted to tell you. I know it's late in the day, but thank you so much for listening.
We're about to finish up, but I can't let you leave without one or two questions, and then the rest we can do tomorrow. That looks like a good foot on the left. That looks like a major fracture on the right. Can you explain the relevance of this photo?
You said break a leg.
Everyone's a comedian.
I try. Take after you.
No, explain it, because people are watching you hobble around, and I'm trying to understand what happened here.
So last year, right after the September conference, I got into a bit of a car accident, and it split my foot in half, which wasn't great. I had an emergency surgery, and it got botched. So funny enough, surgery and picking your doctor. Well, I didn't have that option. It was an emergency situation. So I remember Peter, my husband, called Dr. Moyad when I'm on the table in the emergency room, and Dr. Moyad, he goes, "What about a second opinion?" And he goes, "There's no second opinions, put her back together." So anyway, this happened in October. I have another surgery coming up next month, but, and hopefully by the next conference I'll be walking. The interesting thing about it is I received an insurance denial for the entire thing and got a bill for $124,000. For an emergency surgery, I got the bill for the ambulance, the surgery, everything, the ketamine they put me on, everything. And I looked at it and I went, oh, it was a CPT code error, and it was a membership code. And I think it's very interesting that I was given, or voluntold, to give this talk, which I very much appreciate and have the honor of doing. Yeah. To give this talk, and then all of a sudden I get an insurance denial. So, interesting. But I did learn about the process in person, and it was totally reversed once I got those numbers corrected.
In all fairness, I also told your husband how to read certain labs and ask certain questions to the ER doc, but you couldn't get the second opinion, but that's okay. So it's just funny how this all kind of came together. What's this? What's that?
That's me and two of my 3 children.
Okay, what's slide 2? What's that?
That's my husband.
What are you wearing?
Michigan gear.
Right.
Michigan Medical Center.
It's voluntary.
Yes.
All right. Slide
Totally
3.
voluntary.
Slide 3. This is when Alex was like 21 and I'm 50. And look at the kind of power she's trying to display. I mean, that's a power grab right there, you know? I'm still in therapy for it. So I found this photo and I thought, oh my gosh. Okay.
I was like 7 months pregnant in that photo.
Now you're not going to get
first
away
child.
with that.
See, it was
Grabbing
pregnancy
the old
hormones.
Guy. Slide 5. Let me tell you, please, and I'm going to let her explain this. No one leave this conference without understanding this slide and your ability to sign up to see this at any point, as long as you create a password and you give your email. And why should everyone know the significance of this slide for everyone here? Alex.
So as I said, when we were talking about generating appeal letters, the NCCN, National Comprehensive Cancer Network, is the one that creates the guidelines for everything patients are covered. It's how doctors do what they do. It's the protocols that they work by. It's what the insurance company covers. This is a massive part of the entire medical system. And you do have to sign up and just make an account and, use a burner email. But, it's important to get access to this. Now, the education behind it, they do have entire patient pamphlets and portals and guidelines and systematically going down of how it works. And it's just an important piece of education that I think every prostate cancer patient should know.
I got the idea that when you're interviewing your oncologist, your urologist, I'm not saying they have to do this, but I think you feel, as I'm beginning to feel, that when you're talking to them, you can just ask the office, how do you feel about peer-to-peer? Do you do peer? Because look at a lot of the busiest physicians in prostate have no time for peer-to-peer. They're seeing thousands of people. That's fine. But I think I'm trying to get what you're saying. Are you saying that the next time you talk to your doctor's office, stun them with the question, do you actually do peer-to-peer in case I get denied? Is that what you're suggesting?
Absolutely. You want to have that game plan ahead of time. Especially with these bigger, more expensive drugs, the more you get into prostate cancer, it's extremely important. And sometimes the nurses are the ones that'll answer you, nurse navigators or the nurse practitioner. They're very good points of access.
What's happening, Medicare Advantage, you name it, there's a new word in town called pre-authorization. And it's starting to happen for everything. It's making doctors wacky, healthcare professionals. Pre-authorization, got to check with the insurance company. This is why her talk is so critical today, because the fact, even I'm flying here from Alaska, I was talking to a guy who got rejected and thought, well, that's it, I'm not going to get that. And I said, what? This is going to happen more and more. This is the reality of life today. And so can we bring back up, do you still have her slide that shows on the website, PCRI? There. So just take a photo of that. Everything she said is there. Now, last but not least, I just want to kind of put into a quick summary. See, what goes around here is truly magic, which is part of the reason I still do this. So the team, which you're going to meet the team tomorrow, and just thank them on the way out. Even the Rollins team back there, the AV, they're the best I've seen in the business. I mean, all these incredible all-stars came together, and I'll show you how good they are. So like Alex and the team makes this look like this when you see photos of us at the conference, right? And then when in reality, we look like this. Yeah, so, I mean, that's the kind of cleanup they do. And then the final slide, let me just make it absolutely clear. We are not dating. We are happily married. Nothing that there's wrong with the two of us being together, but we are not romantically involved. So I just want to make that clear since I did that at the very beginning. Thank you so much for coming here. Thank you to the staff. Thanks to the folks back there, the camera people, all the volunteers. This is a magic place. Thank you. Can't let Alex leave without doing her first talk at the major conference, so she gets what everybody wants, the Sleeping Bear Sand Dunes National Lakeshore, which is near where I live. It's an official hat for the national park.
He buys me a hat every year.
It's blue, as in prostate cancer awareness, and what every woman wants, definitely, at the end of a conference after giving a talk, is official Michigan tube socks. So That will be for your foot as it recovers, all right?
I love it.
And now you should probably say last words, and then we'll call it a day, and Dr. K is going to cross
All right, hold on.
for a
Where
little
are you
bit.
going? You can't go anywhere for a second. So first of all, I wouldn't have given this talk, or even had the idea to give this talk if it wasn't for Dr. Moyad. I started at PCRI when I was 21 years old, and it's been 12 years, yeah, and it's been an amazing journey. I don't know what Dr. Scholz was thinking when he hired me, but it was great. I was very young and dumb, and I learned a lot along the process. But what the cool thing is that I've been learning alongside of all of you patients, which has been the greatest honor of my life. Part of that honor has been getting to train and work with Dr. Moyad. So he gives a gift to all of our speakers, and I made him one because Dr. Moyad and I have a lot of titles for each other. On all of our phone calls, we come up with something new. And so some of his titles are on the next slide. So he is our PCRI Epic moderator. He's Mark Scholz' best friend, but he's really mine. He's also an international male model. You can read it in
true.
You can read it in the PCRI bio.
That's true.
Yeah. Next Mr. Olympia, also true. Grazi's dad, it's his dog. And Boss Man, which is what I call him, and Legend, because he is going to be running the New York Marathon, which is incredible. He's been training constantly, and he's doing it for charity. He's not getting a dime for it. He's doing it for PCRI, and he's doing it for unpaid debt, which is amazing, and I'm so excited. And so we're going to have those fundraisers up specifically with his webpage and QR code up tomorrow if you would like to donate, because I'm very proud of him. I don't know anybody who's ran the New York Marathon personally, and when he told me this, I gave him the new nickname, Legend. Now you get your own shirt where you can wear it anywhere you want.
Oh, thank you very much. I appreciate that.
The next thing that I really love about it is the fact that we didn't always get to keep him in person. So it's a big thank you to you, and it's a big thank you to him. This conference coming back after COVID, we weren't sure if it was going to happen. Our Zoom life together was for 5 years straight, where we didn't have the opportunity to meet you guys as patients. And meeting you, I can tell you, brings tears to my eyes. I'm going to get over it right now so I can talk. It's been an incredible joy, just getting to say hi to you, getting to be there for you, getting to remind you that you're not alone. And Dr. Moyad, we wouldn't have this conference without you. So we're very glad we're not virtually in that picture anymore, and we're in person with him now. So a big thank you to Dr. Moyad for moderating this conference.
Thank you. All right.
I'd like to say a big thank you to Dr. Scholz and to Dr. Moyad. Dr. Moyad for working with me on this talk. You can go ahead and visit our website, pcri.org/insurance denials, and get all of the resources that I spoke about. It's just a great way to be able to click into what your needs are and learn more about the specifics that we spoke about, and it gets into a lot more detail there. Also, please don't forget to subscribe to our YouTube channel and support the work we do here. If you would like to support us financially, you can do so at pcri.org/donate. And if you found this video helpful, go ahead and give us a comment. Let our team know. It's just a really great way to give feedback, not to me, but to all the people who work, our volunteers, our staff, and our team, and the prostate cancer patients who help build this conference, both in person and virtually. Now, I would like to thank our sponsors, Bayer, Pfizer, Astellas, Janssen, Novartis, Dendreon, Miradex, Blue Earth, Foundation Medicine, and AstraZeneca. We really appreciate all the work that they do to help support PCRI and bringing these big events, not just in person here in LA, but also to you all over the world with thousands of people viewing it. We really appreciate it. And don't forget to go ahead and see the conference bonus information that we have at pcri.org/2025-conference. It's a great way to view our exhibit hall, to ask more questions, to contact our helpline if you have very specific questions and needs, and to get more information about your case and overall general health. We also have a lot of men's health information on that page, and it's just a good way to get support. After so much content, we're so excited that we get to be kind of at the finale of our conference with our two favorite doctors, Dr. Mark Moyad, who's done an incredible job moderating this conference. He does it every year, but I can't tell you the countless hours that he spends and these stacks of paperwork that he has on his desk going through the latest treatments, the latest indications, what the supplements are doing, what health and lifestyle and just in general, all the research that he does. But he does it for every single speaker, and when I'm speaking to him, it's amazing just to see his breadth of knowledge and research that he does to make sure that we are really keeping you up to date and that he's bringing up the latest topics that just jog the memory of the speakers so that we can make sure that we're getting as much out of them as we can in the limited time that we have, and he just does such a beautiful job doing that. I'd also like to thank our executive director and our founder here at PCRI. You know, we have the honor of filming with him every week, but in this video, he reviews the conference and what really stood out to him as a medical oncologist. You know, Dr. Moyad is coming from a urologic background, Dr. Scholz from the medical oncology side. We really appreciate that we get to see both viewpoints and we get to hear about Dr. Scholz and what his, you know, takeaways are. I think these are important factors and things that he can highlight since he sees patients in clinic all the time and can show a lot of what Dr. Moyad has presented in these speakers and what is significant. So without further ado, here is Dr. Mark Moyad and here is Dr. Mark Scholz.
All right. Hello, everybody. Thanks for hanging out.
We won't take very long. We're going to end this session about 6 p.m. So, you know, sorry we're running late. This is feels like my mantra this whole conference. Sorry we're running late. Sorry we're running late. But there's so many important things happening. So we'll probably take 30, 45 minutes, 1 hour max, and then conclude the conference, right? And how we normally do this, if you haven't come here before, is each of you one by one just bring me cash, and then we start. But apart from that, what we do is I let him do, so I get to do so much of the talking. He does the talking. He goes through each presentation chronologically as they appear at the conference. We comment on it, then we get a couple other comments in. So when you're ready, I'm ready.
Let's take our first slide. Yeah, it won't be chronological because the slide from Dr. Cooperberg, I thought, set up our situation best. His first slide, we can go ahead. Yeah. And the things that I picked, I try and pick 1 or 2 slides out of each talk that really resonate with what I do in my day-to-day clinic. This slide that Dr. Cooperberg showed relates a concept that it's very hard for patients and even doctors to wrap their brains around. And that is a very simple statement. You can just say it. Prostate cancer is not one thing. But there's this inevitable belief that the good cancers are going to slowly morph into the bad cancers and that they're going to spread around your body. And sooner or later, because it's a cancer, it's going to get you. And it's just, of course, can't be true if you look at the active surveillance information that's out there and how we heard today that someone has been on active surveillance for 20 years. The only way that that can happen is if people have a defined type of prostate cancer that is genetically consistent with itself and remains the same thing over extended periods of time. This is illustrated in this slide by Dr. Cooperberg, which assigns different animals and how quickly they can move, snails, tortoises, hares, and birds. And the idea, of course, is that we know that snails don't turn into birds, tortoises don't turn into hares, that these things remain consistent over the years. They're the same animal. And it doesn't help that in the prostate world we number these different types of, with the Gleason score, for example. Again, it sounds like a continuum. A 6 is just that far away from a 7. And the doctors that work in the dermatology world, I think, have done this better. The really bad cancers of the skin, they call them melanomas. They give it a different name. And it would be really helpful if we had different names for these different numbers. So this, I thought, was a great slide from Dr. Cooperberg, and I wanted to try and help people think that their cancer, once you identify what it is, the diagnosis, it's going to stay in the lane of what the diagnosis, if the diagnosis is correct. And that leads to the second concept that I thought is really important and often is missed by doctors as well. People oftentimes will come and say, my knee hurts, and I'm going to do this to fix it, but they haven't actually diagnosed, is it osteoarthritis? Is it a torn ligament? As if that the fact that it hurts is a diagnosis. So when you're diagnosing prostate cancer, you can see that there's a lot of talk about trying to get the Gleason score accurate. How high is the PSA? This whole constellation of stuff that leads to, is it an intermediate risk, a high risk? The need to really define the diagnosis accurately before you can start to talk about what the recipe is for treating it. is another thing that gets missed a lot. So this slide encompassed a lot of the things that I face in my day-to-day practice. You can see how this grading system of how the cells look under the microscope, this numbering system defines these different categories of prostate cancer. And Dr. Cooperberg says, and I think this historically has been true, that this is the most important determinant. How high your PSA, that's important. How big the tumor is, that's important. But the grade is going to weigh most heavily, and of course it's important to get an accurate estimate of what that grade is, and the next slide is going to address that. The issue of grading may be superseded in the future by these amazing new PSMA PET scans. Grading is a system that they're basically profiling you. They're looking at, if you had a grade 3+4, they've looked at thousands and thousands of men who've had 3+4. And they've observed how did that behave in those individuals over a 5 or 10 year period. And then they impute those percentages to you. I think that we're going to see greater and greater confidence being for projecting the future in newly diagnosed patients based on whether they have metastatic disease on a PSMA PET scan. People tend to misconstrue these PET scans as something that's like just a slice in time. Well, there's no metastasis today, but who knows about tomorrow? Forgetting that you can't come to a day of prostate cancer diagnosis if you haven't had prostate cancer for years already. And the absence of any metastasis at the time of diagnosis, I think, may end up weighing as heavily as Gleason's score in terms of predicting future behavior. And we're seeing some movement in this. Historically, people that have grade 4+4, prior to the PSMA PET scans, the newly diagnosed were always getting 18 to 24 months of hormone therapy. Whereas now, these people who have PSMA PET scans showing the absence of metastasis are having discussions about cutting that type of treatment back. Because when you don't have a PET scan, you don't know if there's anything out there. When you do have a PET scan, you can be about 80 to 90% sure that there's nothing out there. And that's more of the profile of a 3+4 than a 4+4. Since getting an accurate diagnosis is super, super important, when you look at this slide, you go, wow, this is super complex, even for myself who does this all day long. The need to get a second opinion from a flagship pathology center and determine accurately the pathology. If the Gleason score, the 3+4, 4+4 is going to be the most important indicator, with or without a PET scan, then you need a world-class pathologist to tell you what's really going on. So those were what I picked out of Dr. Cooperberg's wonderful talk, so much great information, but I thought that this was really some core stuff that we should review. Any thoughts on Dr. Cooperberg?
You know, he's always good. If you haven't seen him before, he did a lot of Zoom. He's done probably a conference every 2 years. So you should go back on some of his old lectures. They're still relevant. They're incredible. They're really good. A couple things I thought about, just to, maybe I'm belaboring this a little bit. I just find it so interesting that everybody stands up here and says the importance of pathology, the Gleason score, the grade, the group, it drives everything. It's just such a critical piece of information. Then you end up talking to someone and then you find out, well, did they even try to get a second opinion on pathology? And maybe they're sending their slides to a pathologist. I don't know, it depends on your hospital system. Some hospital systems will send the slides to a pathologist to read that only sees prostate cancer or only sees urology. Other ones, they'll have pathologists that see everything under the sun. I think there's a professionalism to this that there's a couple places in prostate cancer I wish everyone had the opportunity to get a second opinion, and the pathology reading, getting someone else, a different pair of eyes to look at your pathology, have your slides sent there or however they want it. We used to use Jonathan Epstein a lot at Hopkins. Hopkins is still a great place. There's a number of places PCRI recommends. But just getting a second pair of eyes on your pathology is so much more critical today, because When you're talking about things like a Gleason 4, what people don't realize is now there's sub-classifications within these different Gleasons. So I've had friends, doctor friends, send me a pathology report and it will say Gleason 4. It won't comment on whether or not they found something intraductally, for example, or cribriform, or all these other subtypes that could mean it's a more aggressive 4. I like to always ask the question, is this a mild 4, a moderate 4, or is this aggressive 4? It comes in different forms. It actually does. With a good pathologist, they'll comment on it. They're supposed to comment on those things. And when you don't see any commentary, that's a red flag to me that this needs to go to a second opinion. And I'm glad that he agreed with that. The other thing I want you to comment on too, I keep bringing this up over and over again, PSA density. Can you please talk to the audience of why I've been obsessed with PSA density over the past decade, and I don't care how many conferences I bring it up, everyone, in my opinion, should ask if they can have their PSA density done, and will you walk them through that?
Sure. One last, to further talk about this, who is it particularly important to get a second opinion when you're looking at your own pathology? Am I concerned about a patient who has a 3+3 getting double checked? No, not really. I think that that's a fairly easy diagnosis, and the pathologist is describing something that there's going to be almost universal agreement that it can be watched. Am I talking about someone with a 4+4 or a 4+5? Screw-ups where people get sharply downgraded when they already have a 4+4 or 4+5 are very, very rare. What I'm talking about is the people that have the 3+4s and the 4+3s. There is so much room for interpretation there. And I would say when we have 3+4s come to see us in the office and we get second opinions in the pathology, I'd say 1 out of 2 are downgraded. Yeah. And boy, is that fun information to give. Someone thought that they were probably slated for treatment, and they get a world-class pathologist says, nope, pure 3+3. Wow. It's a total turnaround.
Every major pathologist we've had at this meeting, we've had the best ones here, they always cite a global statistic, a US statistic, that when they see something as a second opinion, anywhere from 25, 33%, upwards to 50%, that grade will change in the hands of someone more competent. Yep. The other thing I can't emphasize enough in terms of advocacy is when you send for a second opinion, what is traditionally done is the institution that sends it to the second opinion sends the positive slides, sends the ones that have cancer. In my world, that's not good enough. You should ask them to send all the slides, including where they did not see cancer. Because now you're going to the NFL, you're not playing high school ball anymore. So some of those negative slides that didn't have cancer might reveal something else in the pathology that the less competent pathologist did not pick up. So it's up to you when you send for a second opinion. I asked Jonathan Epstein this. I said, do you just get the positive slides? He said, mostly. I said, but don't you want to see all of them? He said, absolutely. And I said, why don't you? He said, because they only send me the positives. So I said, then should we start telling people to send all of them? He said, yeah, that's the second opinion. I read whatever I get. So that's my other piece that you helped me bring up. Thank you on that. And then PSA density.
Yeah, let's talk just briefly about PSA alone. PSA density is the highest form of what PSA can deliver in terms of accurate prognostic information. And that's because you're contextualizing the PSA in light of how big the prostate is. PSA is coming to some degree from prostate cancer, and then to some degree from the prostate gland. Bigger glands, higher PSA. So getting a ratio of how high the PSA is to how big the prostate is a very logical way to get a sense of how much leftover PSA is coming from cancer. And it's a fairly simple formula. You have to know how big your prostate is. They range from 10 cc's to 300 cc's. And then you take your PSA, the normal ratio of PSA to gland size is 10 to 1. So if you have a 100 cc gland, which is very large, the average PSA with no cancer at all is going to be around 10. If you have a 40 cc prostate, which is normal for a 65, 70-year-old man, the average PSA in a person with no cancer is going to be around 4. When the PSA is 50% higher than the average, doctors are starting to say your density is higher than it should be. Could that extra PSA be coming from cancer? And that's the most that PSA as an indicator can offer you. I think sometimes PSA is overemphasized in this day and age because PSA changed the world back in the 80s and 90s from most men being diagnosed with metastatic prostate cancer to most men being diagnosed with localized prostate cancer. It was one of the most revolutionary breakthroughs. And for many years, we didn't have PSMA PET scans, and so how much cancer was present by how much PSA was present was used as one way to kind of guess as to whether metastases were present. And guessing whether metastases are present has always been the most important exercise. So PSA carries a lot of weight because of its history. Now that we've developed super accurate scans to determine if metastases are present, in my view, when men have had a PSMA PET scan, the PSA becomes somewhat less important. It can't be ignored because of the history. And if you want to try and interpret where your PSA is, don't overweigh it if you have a negative PET scan in terms of, oh, I must have metastasis, because the PET scans are very accurate. But it can tell you when that threshold of concern starts to go up. If you have a really big prostate, say a 100 cc gland, that would be 2.5 times bigger than the average prostate. You say, well, does anyone have a gland that big? Yes, lots of men have prostates that big. And when that is occurring, you say, I would tell that patient that their upper limit of normal for their PSA with a 100 cc prostate is 15. 15. And this is something that's not widely understood by general family practitioners who are always horribly alarmed if anything's over 4. Now, can you just say, oh, your PSA is 14.5 and you have a big prostate, don't worry about it? No, because you can have BPH, which is causing a high PSA, and prostate cancer at the same time. So, but what can really assuage the concerns is a good quality MRI. The industry historically has defaulted to these random biopsies, which we haven't done a random biopsy in my practice for 10 years. But now with MRIs being so accurate, a scan showing no evidence of any disease is incredibly strong evidence that there's no cancer present. And if the MRI is missing a small tumor, because the natural history of prostate cancer is so slow, it's perfectly safe to wait a year and get another MRI 12 months later. And you'll still pick up early prostate cancer while it's in the prostate before it metastasizes. So all of this, in my view, circumvents the need for random biopsies, which we won't talk about how unpleasant those can be.
Someone came up to me after the sessions yesterday, and they brought their MRI, and they said, can you look at this? And I went, okay. I'm like the dermatologist that's going to look at the mole right now, but I'll take a quick look. And the first thing that caught my eye was, there it was, the size of his prostate. There it was, the PSA, but no PSA density was calculated. And I asked the gentleman if he knew what that meant, didn't know what it meant, and we did the calculation. It came out to about 0.07, 0.08. The best way to think of PSA density is like PSA in the sense that the higher that is, the more concerning it is. So we have this magic number called 0.15 or higher, that maybe that might take you off active surveillance. That's just one piece of the puzzle. Like I always tell people that once you're diagnosed with something or you're dealing with something, you're a puzzle. And part of the goal is to collect as many pieces as possible, especially relevant pieces. And when you put those together, then you get a more clear picture of what's going on. But these are just pieces. It doesn't mean one piece should dominate. MRI is a piece, but then you get the great measurement of a prostate with an MRI. And the PET scans can do that too. Ultrasounds can do that. So anyway, we just calculate his PSA density. I do it in my phone, and there it is. It helps to give another piece of reassuring information that maybe they need to watch, but again, it's one piece that wasn't provided, and you wonder just how many men out there are dealing with that. In my world, PSA density has become so important that I visualize a time where in 20 or 30 years, men in locker rooms like to show off the size of their prostates. They're just like, my PSA density is this, mine's this, and this is what we boast about. And then that's kind of our locker room talk. But that's my twisted mind thinking. The last thing I want to touch on is two things. I want your comment, and then we'll move on from Cooperberg. What you don't see and what the speakers don't see, because they never see my slides, they don't know what's coming. I sometimes don't know what's coming. I prepare for a year. We start preparing for next year's meeting tonight at dinner. And so it's all this prep that goes in, but what no one sees in the audience except myself is that depending on the time factor, because we're giving more time, just so you know, if you come to this conference, we're giving myself less time, which is fine. This is voluntary. We're putting more time in to after the speaker's done that you can go ask a question. We want to personalize this, but make the Q&A even more pithy. So sometimes you'll see my slides, but you won't see the other half of the slides that didn't make it in there because of a time crunch. What I was going to try to trip Dr. Cooperberg on was I was going to show him what's a phase 3 trial from Harvard. It was called Cosmos. You can go look at it anytime you want. This is for anybody in general, partners, kids, you name it. It's called Cosmos. It is with seniors, men and women in the study. It was a multivitamin essentially versus placebo. And it turned out the multivitamin reduced cognitive aging, regular cognitive aging, by about 2 years. Now, if this is a drug that costs a penny a day, everybody's talking about it, and this is Harvard, which is not so sure about supplements, and now some of the top people in the trial, because it was an independent, objective trial, is running around saying everyone should take a multivitamin. And what I find so striking about this study is that essentially it was with Centrum Silver. So what I always tell the residents and the students is repeat after me, if something costs more than Costco, you got to question it. Meaning, it doesn't mean you shouldn't pay more for your supplements. It just means you have to realize that some of our best clinical trials, the best one we've ever had with a multivitamin was a Centrum Silver. And that's what I've been taking for about 15 years because of some other trials. It doesn't mean you can't take a different multivitamin. I've never worked with the company. And that's just interesting for men and women in general. And the reason I find it interesting is I left my hotel room a little while ago and I saw my 100th commercial on cognitive health and taking a pill. And none of those products that cost $100 a month have any of the evidence that Centrum Silver has from the Cosmos trial. In fact, it might go in our clinical guidelines. Okay, fast forward to Cooperberg's talk. They have an organization, they run a database called Capture. It's very well known in the urology database. And they just found in their database that men who took a multivitamin regularly had a lower rate of recurrence after treatment. And I wanted him to comment on that, if he actually believed that. I don't know if I personally believe that, but I think someone taking a multivitamin regularly is also a characteristic of someone that watches their health and is more aggressive. They tend to be more aggressive exercisers. They tend to be more careful on their diet. So it's funny how in my world, multivitamins, when I started in my career 35 and 40 years ago at meetings, they would say, that's just expensive urine. And now today, we're in a very different spot as we're aging in terms of the potential there. People talk about vitamin D, they talk about B12, getting these kind of things. But a good multivitamin daily, like Centrum Silver, has enough of the recommended daily allowance of vitamin D, B12, and all these things. So you're not taking a million pills, you're just taking one pill. And the very smart companies today are realizing that one of the biggest problems with seniors, and now that I'm a senior myself, taking some of these multivitamins is some are as big as a house. You can't swallow them. And so now they have minis. So the good companies have mini pills. But what I always tell people, this is what you can pick up on the side, since I never have time to do these classes anymore, is when you're looking at a multivitamin, use Centrum Silver as your comparative. If you don't want to support the company, that's your prerogative, but look at the ingredient list, because that's the same ingredient list that's gone through the most rigorous trial that we've seen so far called Cosmos, C-O-S-M-O-S, and it's now kind of spilling into a potential impact in prostate. We'll see if that ends up being true. So he didn't bite there, because I couldn't ask him, I didn't have time. Where he did bite, and I want you to comment on, is it still makes me half wacky every year when we start discussing men on active surveillance or in any situation after diagnosis in germline testing. So I want you to comment on the fact that when people come to your office and they have advanced prostate cancer, they are automatically signed up to do a germline test, which means that's the genes that you got from mom and dad. Do you possibly have one of these ones that we're concerned about, BRCA2, ATM, CHEK2, there's a whole host out there. So they're offered it, but we haven't decided yet if people on active surveillance or localized disease should be offered the test. And I said, what do you think? He said, well, maybe we're going, he wasn't sure yet, but he felt like maybe we're going there. How did you feel about that?
Genetic testing, you're going over a threshold that you're not going to come back from. I'd say one of the things that I struggle with most in my clientele is anxiety. And that it can be multiplied. I don't know if I track anxious people like flies or what it is, but so I always counsel patients that as Mark pointed out, with advanced disease, you've got to do genetic testing. In fact, we have a slide on that, I think, coming up right away. But in people on active surveillance, I think that it's often underestimated how powerful active surveillance is now in 2025. We used to do active surveillance with no MRIs, just these rude and crude random biopsies periodically, and PSA. We had no PET scans. We had pretty poor understanding of all these different subtypes of, as we got in front of us, all these variants of 4. This one has more metastatic potential. This has less metastatic. None of that was known. And yet somehow we muddled through and people in active surveillance did fine. Now, so I am not concerned personally if someone did have a BRCA mutation of doing active surveillance if they meet the criteria for active surveillance on all other levels. So when patients ask me about genetic testing, I ask them to do their research. And are you going to be comfortable if you get discover that you have some scary sounding gene that no one knows what to do with it, which is much more likely than you're going to find an actionable gene, which is about 3% in these, finding a BRCA-related gene.
My point with them, I can just tell you, is that whether or not you do it is your choice. But to not have the discussion is what concerns me more. When families find out 3 years later there is a possible test. I just talked to a close family friend and I just told the kids, just so you know, because one of the parents ran into a situation that genetics could make the difference in the next generation. And we just had a discussion of the pros and cons of that test. And I don't want to turn them into a stress ball, There is anxiety out there. We said that we should change the name of prostate-specific antigen to prostate-specific anxiety. We should just replace every little A with anxiety. But what I'm trying to push with some of these docs is I just want the discussion to come up. Because I was at this meeting 7, 8 years ago when nobody got genetics if you had advanced disease. And I would say, just give it 3 or 4 more years. It's going to change in the guidelines. And here we are, and so I just think that this train's a-coming. So we need to educate ourselves on the pros and cons of getting the test earlier, and that's just my speech.
We're moving on now to talk about Dr. Mulhall, and I loved his, I increased the font of the quest for truth. It went by so fast on his lead slide that I thought Dr. Mulhall probably missed his calling as a, like a fire and brimstone preacher. The way his delivery is so polished and beautiful. So we'll go to the next slide. This is his first slide that he came up with, and he said 50 years to get a wrong idea out of medicine and 100 years to get the right one onto it, and then go ahead and advance it. And then I thought, well, the PCRI is going to fix that. Our reach has gotten greater and greater, and that wasn't there originally, but I hope Dr. Mulhall will put that in all his future slides. So he also coined this term obsessive oncocentricity, which, does that mean anything to anyone in the room? Raise your hand if you think you know what he's talking about. Yeah. So this is obsessive oncocentricity would make great sense if you had pancreatic cancer or metastatic lung cancer, which is, you're just in a cat fight for survival. Prostate cancer, as we know, is a spectrum. So he's talking about this in the context of not over-treating prostate cancer and ruining your quality of life. And this is all contextualized in men that are, perhaps have a median life expectancy of 10 to 20 years and want to have the last few years of their life to be good. So he is right at the tip of the spear in that he is trying to help people recover their sexuality, which is, for newly diagnosed men, far and away the number one thing that takes a hit with treatment. The technology to cure prostate cancer without causing incontinence, without damaging the rectum, has really arrived. But if you're looking at standard radiation, for example, there's going to be some risk of lingering problems in getting normal erections. So one of the things that Dr. Mulhall raised was this concept of penile rehabilitation. If it were conveyed to men that were going to have a radical prostatectomy, that your best outcomes are probably going to occur if you start with penis injections a week or two after the surgery. I don't know how many men would still do radical prostatectomies. So I think that in the competitive entrepreneurial world that the prostate cancer world is, I think that this idea of early institution of penile injections, especially after radical prostatectomy, doesn't get talked about enough. And it's an unpleasant thing. One of the slides said that it sounds awful, but don't base your decision on mental imagery. This does work, and it's not just for men that have had a radical prostatectomy and are encountering problems. It's for any man that wants to resurrect his romantic life, and the sooner it's implemented, as Dr. Mulhall repeatedly told us, the better the results are going to be. So this is an uncomfortable thing to talk about. It's a very real and effective treatment, and I thought this is what I wanted to emphasize out of his talk.
The slide that people have been begging for on YouTube, that was slide 7, if I remember. He walked us through his regimen when going into a radical prostatectomy. He thinks it should also be applied potentially to ADT and radiation. And that's a pretty critical slide, that you're trying Cialis, you're trying Levitra, you're trying Stendra, you're trying all these options of the pills, and if they don't work, and you're not getting anything going on, then it's time, he thinks, within 6 weeks, I don't remember the last time I met someone that in 6 weeks started penile rehabilitation with injections, because I don't think they were being told.
If it's so effective at 6 weeks, why are we waiting 6 weeks?
Yeah, well, because I think, he's a data-driven guy, so it's based on some of his studies, but maybe earlier, right? So, but the idea is that we're selling this too much with the word penis in it. We're already obsessed with our penises enough, and now we're going to talk about penile rehab. If we said major side effect rehab, or we just renamed it, I think more people would be excited about it. And I'll tell you why I feel this way, and we need to do a better job of explaining penile rehab. When you're bringing blood supply, oxygenated blood supply to the penis and all the nerves around that, and you still have your neurovascular bundles after surgery, for example, that help control erections. It's all a network of nerves back there. But those network of nerves crisscross and go to the bladder also. So there's preliminary evidence. Some of the experts aren't jumping on the bandwagon with me yet, but there's preliminary evidence that shows that a good penile rehabilitation program may not only help the penis work better, but may also have an impact on the incontinence. So the data either says that a good penile rehab either improves continence or it doesn't do anything for continence. There's no data saying it makes it worse. So in the Moyad world, that's enough. You are now selling it as, look, this is healthy not only for the penis, but for the bladder, which is so critical to get that function back regardless of your situation. So the other question that we need to sell is it's not automatic sex rehabilitation. Whether it's with the pill and being aroused or penile rehabilitation, it doesn't mean you inject yourself and, oh my God, you got to go run have sex. It means you're just getting blood to come in there. So if all you do is get an erection, wait a little while till it goes away, that's rehab. I remember, and I think some of the partners go, oh my God, if he's popping a pill like some of these doctors say 7 days a week, I can't have that much sex. And you're saying, no, the idea is to get an erection. What happens after the erection is your business. But the reality is, if you look at all these studies, even, I'm going to use the politically correct language, self-induced erections that just were like themselves, just hung out there, nothing happened with them, that's penile rehabilitation. The other thing that's so critical that you need to know about John Mulhall is they did a study of surgery patients and radiation patients, which I still quote to students, which is they looked at them before their treatment and they found the ones that were the heart healthiest going into treatment. They had great cholesterol, they had great blood pressure, they had great blood sugars, they were extremely active. When they had what I call the Moyad 4, those are the top you always want to come back to, they had a lower rate of side effects afterward and a faster rate of recovery, which I think would happen in any scenario, be it ADT or radiation. And so, again, it's too bad we call it penile rehab. It should just be called, overall health rehab. And it gives you a better look at what's going on there. We have the same thing that he talked about in oncology, where people become obsessed with their cancer, with the name that you threw out. We have the same thing in diet. It's kind of catching on, called orthorexia, where people become so obsessed about every single thing they put in their mouth that they are just complete and total stress balls. And so everything they eat is somehow going to determine their outcome. And I think as long as I've been working in diet, and I'm a huge fan of diet, and whatever diet you want to do, as long as it changes the Moyad 5, so the Moyad 4 should make your cholesterol better within a month to 2. It should make your blood pressure better overall, right? So blood pressure, blood cholesterol, blood sugar, it should help you lose weight if you're going to lose weight. And then you should be happy on the diet you're choosing. If you're a messy, miserable, moody mess, making everyone miserable around you on this new diet, that's a bad diet. And so I think the other thing I try to teach people when dealing with this topic or another topic is everything can be obsessed about. And I get nervous when someone says, oh, I can't have a scoop of ice cream. Why can't you? Cancer, sugar, cancer. I'm going, really, honestly, if it was that simple, all of us would be out of business. If it was really that simple. So we need to just generalize those messages more, and I'll talk about that in a minute. The other thing I'll tell you about Mulhall is he is he's kind of a good sport. This poor guy has heard every Viagra joke known to humankind his whole career. What you didn't hear is the one that I told him. He's like, yeah, I heard it. I didn't think he heard that one. There's a new side effect with Viagra that you're going to be hearing about in the next few weeks. Oh, well, what is that, Dr. Moyad? If you don't swallow the pill fast enough, you get a stiff neck. So, no, I thought that was funny. He didn't think it was funny because he's so sick of this stuff. So he says, anyway, that's my comment on penile rehab. I had a friend in LA say, I don't really want to stick a needle in my penis. I don't want to do that. And I always say, look, I understand that. Nobody wants to stick a needle in their penis. But diabetics, even at the very young age, learn to stick needles in themselves, and suddenly it changes their lives. And they become very comfortable with it after a few times. They practice with an orange or whatever not. And I'll tell you, the new line of cholesterol-lowering drugs, which is changing medicine this year completely, they are injectables. So like Repatha, we're seeing these medicines take your cholesterol from 100 down to 20 and no problem. You can just give yourself a little injection once every 2 to 4 weeks. And in the future, in the next few years, those injections will probably come once every several months and you're done. And they work incredibly well. And in fact, there's a study right now in Australia of the injectable cholesterol-lowering drugs in men with advanced prostate cancer because we believe they have ancillary potential benefits. So we're going to be watching that trial. But I'm saying the whole world is moving to when they need a really good med, that sometimes you got to inject yourself. And if you kind of keep that holistic thought, usually after the first few injections, men do extremely well. My other joke, which he didn't like, which was behind the scenes, is, you're always getting warned about a 4-hour erection. And I always say, well, then I'm just going to get a 3-hour and 59-minute erection, then cut it off right there. And then he's like, that's not funny. That's still an emergency. So I didn't share that with the audience. Okay, I'm done with that.
This is another thing that I see over and over is men that have been diagnosed with prostate cancer who are afraid of taking testosterone. This comes up incredibly commonly because for 2 reasons. One, as we get older, our testosterone levels tend to go down to lower levels, and which has a variety of side effects. And then men who've been taking Lupron, Eligard, Trelstar, Firmagon. These medicines often leave people with lingering low testosterone levels for the rest of your life.
Right.
Studies are black and white that it is safe to stop these medicines and allow testosterone to recover to normal levels. But doctors and patients alike are routinely nervous about taking testosterone. It's like gasoline on the fire. When the chemical makeup of the testosterone that comes in these different products, whether it be a gel or an injection, is identical to what comes from the testicles. So basically what's happening is men are reestablishing normal physiologic levels of testosterone. And why isn't it dangerous for people to do that who have had prostate cancer? It isn't dangerous because all these men are going to be carefully monitored. And studies have shown that, God forbid, some activity of prostate cancer resumes, it's safe to resume hormone therapy or initiate other forms of treatment at that juncture. And 10-year survival rates will be equivalent. There's even a possibility that giving testosterone could be advantageous now that we have these new PSMA PET scans. There are studies showing that you can spot weld early metastatic lesions, and in some cases even cure people, are getting stronger and stronger. If someone's been on Lupron for 5 years, their PSA is undetectable, and because they've been so nervous about stopping Lupron or taking testosterone, if there was a very small isolated metastatic site out there, undetected because the PSA has been undetectable, then the opportunity to possibly even cure the disease will never transpire. So the fact that Dr. Mulhall was pointing out the safety, there are caveats, the main risk being a high red blood cell count. When people have heart disease, we monitor your LDL cholesterol. When you have prostate cancer, we monitor your PSA. And if you're taking testosterone, we monitor the hemoglobin, the hematocrit. These are the measures of how many red blood cells are floating around. And if they go too high, men either need to cut back on the testosterone or they need to donate blood.
I'm so glad he talked about testosterone therapy. I'm so glad you brought it up because I just have a different take on all of what's going on here. The first take I have, not from you, from just the experts in the category, the first take I have is that men should know their testosterone, especially coming off therapy or going into therapy, and then they get a total testosterone, but they should also know their free testosterone because the majority of it is bound up. There's only a small portion that's free to go do what it's supposed to do. So there's some men that come back with a really low total testosterone 2 years after ADT and go, oh my God, but they feel fine. Because you look at a free testosterone, the number is perfectly fine. So those two are married. Always think of those, that when you get a total testosterone, you also want to know how much free testosterone, because one could be normal and the other one could be low. And I do believe there has to be a candid discussion going on that when men eventually come off hormone therapy of some type, that testosterone recovery looks very different. And this is, I'm not going to jump ahead, but this is what I told Dr. K, that this makes me nuts in the literature, having to review so many articles I have to review for medical journals. They use words like testosterone recovery was 90%. And then you look in the little fine print, and testosterone recovery is something that anyone reaches 150. Now, his testosterone might have been 700 going into therapy, and now you're saying 150 is fine for that man. So it's really important to know your testosterone before you get that first injection or take that pill to know what your goal is. But we also have to be honest, as you get older, many of the men will never reach back to where they were. It's very unusual, even if they're doing 6, 12 months. So don't let little words like testosterone recovery mean that you're going to get it all back. Many people don't. The other thing I have to sell you on, and you're going to see this movement, and it's happening quickly, because every month I have to review articles for doctors for them to get credit. And I can tell you that the articles I've been reviewing lately are men losing a significant amount of weight and regaining huge numbers or amount of testosterone when they do that. So my biggest excitement about some of the new weight loss drugs is actually in the area of regaining your testosterone, because it has been an ignored area of the field. We know diabetics have a good chance of having low testosterone. We know a variety of assisting aging can cause that. But one of the greatest killers of testosterone in our society is weight gain in men. And for some men who can drop 5, 10, 15% of their body weight, you can see an increase of 200 to 300 points. And so our largest endocrinology meeting just happened on July 14th. It's called Endo 2025. This was the study that's going to not be published yet, but it was presented from St. Louis University. With 10% weight loss in men of a variety of ages in their study, these are men on the new weight loss drugs, the proportion of men that regained both their total and free testosterone, that regained it fully to a normal level, went from 50% to almost 80%. This is just with weight loss. So testosterone replacement is an intriguing area. It's really nice. But what I wish would be part of the discussion at some of our medical meetings is there are some men, and you can never predict who they are, they'll lose a ton of weight, their testosterone won't move. Other men will lose a ton of weight and their testosterone will shoot up to the highest level they've ever had in their life. And they should be told this, in my opinion, that can happen. The other thing you have to keep in mind about testosterone replacement is some people don't use enough criteria before they go on it. What Dr. Scholz is describing is a great situation where you could possibly go back on it, but there are a lot of men out there just jumping on testosterone replacement without changing diet, without improving exercise, and certainly without losing weight. And that's, to me, my concern. I pulled also, for the sake of this meeting, some of my favorite questionnaires that can get you on testosterone that you'll see online, whether or not you would qualify for testosterone therapy. Here's some of my favorite questions that could qualify you for testosterone therapy. Not that there's evidence that would help with that, but this gets you excited about it. Question here, do you have joint pain and muscular aches? I have that every day. Do I have an increased need for sleep, often feeling tired? Right now I have that. Doesn't mean I need testosterone. Do I have a decrease in muscular strength, feeling weak? Yes, as I get older I feel. Here's an actual question. Do you feel like you've passed your peak? Shit, I feel like I passed that 20 years ago, man. That's fine, I'm getting older. That's fine. Do you have a decrease in the number of morning erections? Since I was 16, yeah, I have a decrease. I used to get them so much I couldn't go to school, I was embarrassed. Now, I'm lucky to get one before I go to work a week or so in the morning. That's just life, right? So these questions are sort of set up to make men go, oh, I think I found the solution. I think I know. And the other thing I want to tell you about testosterone replacement is that there's lots of different types of testosterone replacement today. People want your money. And I always still find it interesting that testosterone is exactly like Dr. Mulhall described. In the morning you get a surge, and then you kind of get a drop and a little bit of a bump. That's what we call physiologic testosterone. So a lot of experts believe that men with prostate cancer or any other men, if they're going to go on testosterone, they should go on something daily. A daily gel, for example, because that brings them up in the morning and then it comes down. So it's like the normal amount of testosterone you make. The other options are pellets that last for months and injections that last for months where you shoot up and then you come crashing down. And a lot of people argue, well, that's not physiologic, so what are we doing? We're not so sure. And those people have higher rates of some of the side effects you described. So if you qualify for testosterone, also make sure they're taking you through some of the cheap options. Because some of the cheaper options where you apply it yourself is exactly how the body normally does it, which a lot of people believe is one of the safest approaches, especially if you qualify after prostate cancer treatment. I'm done with that now.
One other comment. The issues that we see in medical oncology treating a lot of prostate cancer patients, which has been founded on injection therapy like Lupron, Eligard, Trelstar, and whatnot, and which cause those lingering low testosterone levels commonly. I mean, it's just part of the way the treatment works, does not occur with the new oral agent called Orgovyx. And the recovery, or if you were to use a second generation medicine like Nubeqa, Xtandi, or Erleada, in those people, their testosterone levels recover generally 100% and usually pretty quickly when they're stopped. So
that's a good point. Orgovyx is a daily pill you can take instead of the injection, and it's also known as Relugolix. And a lot of men like it, and at least they should know that it's an option there for testosterone suppression overall. How's everybody doing? Because we're supposed to finish in 15 minutes. Are you doing okay? All right. We all know where the bathroom is. At least I know. Okay, so I think we covered that. Who's next on the docket?
Dr. Heath went through a number of important treatments for advanced prostate cancer. I thought we'd take a moment and emphasize this. It is, this is the reason if someone has metastatic disease or hormone-resistant disease that you have to do genetic testing. You must do genetic testing because you might win the lottery. If you have this particular genetic abnormality, immune therapy with a medicine called Keytruda, which is quite well tolerated, certainly in general much easier to take than chemotherapy, for example, is almost certain to cause a dramatic remission. She cited a patient that went from a PSA of 1,000 down to 4 or 10, I can't remember what it was. And I don't think she was citing an unusual response. That's the sort of response that you expect if someone has this genetic abnormality. You're not going to know if you have this genetic abnormality unless you have genetic testing. You can't guess it by the hair color or any other phenotypic abnormality. You have to do the genetic testing. People should also be aware that this same medicine, Keytruda, which is very popular for a number of different cancer types, could have activity in prostate cancer, even though it's not FDA approved for prostate cancer. And the other thing that genetic testing will let you know is how many mutations there are in the cancer cell. It turns out that when the number of mutations mounts up, say they find 10 or more mutations, this same medicine, even though it may not be microsatellite instability per se, this same medicine, Keytruda, is also quite likely to induce responses in prostate cancer patients with advanced disease. Now, this medicine is very expensive, and its off-label use could cost you $10,000 to $15,000 a month. But Merck Pharmaceuticals has been very generous in dispensing this on a compassionate use basis at no cost whatsoever. So be aware that genetic testing could lead to 2 very useful, quite tolerable situations where a medicine such as Keytruda can make a big, big difference.
As you know, I come from a different area that Dr. Scholz does. We agree on about 66% of the stuff, and that's the 33 we don't. I enjoy that. Otherwise, my name would be Dr. Scholz if I agreed with everything he said, and he'd be Mark Moyad. But my take is a different take outside of prostate, which I'm watching. MD Anderson in Houston, along with the National Cancer Institute, did a study several years ago of people on these medications for melanoma. And as you know, they're highly effective in melanoma. They're approved for 18 different cancer types, 40 indications. It's just unheard of. And so what they look back on their database is they found that individuals that were getting the normal amount of dietary fiber you're supposed to get in your diet versus those who didn't had a higher chance of responding. And people are saying, well, that can't be right. Well, they believed so much in that trial, they got funding for another huge trial, which is actually going on right now. And how I look at it is you have to understand, when you're getting a lot of dietary fiber, a high amount of dietary fiber, it's not just that your train runs on time. If you know what I mean by the train, I'm not going to go into it in detail before lunch. But the train runs on time. It doesn't run too early and it doesn't run too late. And as you get older, the train's always running on time if you get your amount of dietary fiber from whole unprocessed foods, especially beans, lentils, whole grains, fruits, and vegetables. What happens is that when it hits the colon, the dietary types, I'm not talking about the commercialized types that get all the attention that are bogus in a lot of cases, they create something, the bacteria in your colon feed on them to create something called short-chain fatty acids, or we call them SCFAs. So if you go Google SCFAs, you'll see the reason we're studying them is those get then absorbed into the bloodstream, which then may help with immune modulation or immunity for certain things against maybe viruses. And they think this is part of the reason that this could be true. So they're now doing a trial where people are getting their 25 to 30 grams from food. And I just never thought I would see the day that this kind of trials, because we're always seeing, what else can I add? let's just pretend that this trial is bogus, it ends up not working. What I love so much about this dietary fiber trial is dietary fiber already meets the Mark Moyad standard, which means it's heart healthy. It really is one of the greatest anti-aging ingredients that you could think of. So not only does it help with bowel health, your microbiome, and many people, it can reduce their cholesterol, it can control their blood sugar, it can make them feel more full overall. Some people, it helps them lose weight. But unfortunately, they get excited about a lot of little pills and powders over the counter instead of getting them from Whole Foods. But one of my favorite products, I don't work with the company, is if someone wants to get a little bit more, I used to bring it to the meeting. And if you put it just in a shot glass daily, just a shot glass or every few days, think about that, a shot glass of all brand buds, not all brand, but all brand buds, B-U-D-S. There's nothing that has more. It's 17 grams per half cup. So if you try it, you got to move into it slowly, and then you drink water with it. But if that's 17 grams on a shot glass full, that's good enough to keep the train moving constantly. So, and I promise you, there's one thing I will disappoint you with. If you start doing more fiber, you're going to get less reading done. So, because we know that you strain less, it's shorter to go, and like you see, if you ever see a cow go, they go in seconds. And there's a paper this week in medicine that I have reviewed, which I have firmly believe that the longer it takes someone to go, the higher they have a risk for hemorrhoids, for example, the higher the problem they run into rectal issues, because that's so much pressure and so much strain. So to not only go, but go quickly is a sign of very good bowel health. But how you do that is you're incorporating fiber in your diet. And so thanks for opening that up, because I was not able to talk about that.
It was on my mind the whole time.
I talked about with her the abysmal rate of men on hormone therapy not getting DEXA scans. Partners, you get DEXA scans for osteoporosis.
Wait. Let's take a show of hands and find. So everyone knows osteoporosis occurs in women, but really in the women in the room, have you all had a DEXA scan in the last few years?
Okay, see, I trust the women in the room.
A few?
Yeah.
So it would be considered standard over what age for a woman to get a DEXA scan?
It depends, based on family history, but now you can get it covered 60, 65, and the insurance, my wife has it covered at 62, so it does, and I don't even care anymore if they cover it. The prices dropped so much that she can go in and pay $100, $150, and she's good to go for several years.
And if you don't get one and you have bad osteoporosis, what could happen to you?
So what happens is sometimes you have, like in prostate cancer that you've seen, see, what you think of fractures is you go, oh my God, I broke something, it's a fracture. Those are the obvious ones. In Scholz's practice and in our world, you see what's called pathologic, where there's a fracture there and there's pain and they don't know that they fractured something until it shows up on the screen. So the DEXA scan is a brilliant, brilliant scan, because 10, 15 minutes at a cheap cost, 10% of the radiation of a chest x-ray, it tells you how your spine's doing as well as your left or right hip. And then you can use that to incorporate in algorithms to look at your overall risk and whether or not you qualify for medication or not, or you're high risk. And so it's a complex thing that can now be simplified with men getting DEXA scans. But I'll tell you some breaking news, too, for all the women who came today in the audience and the men that I have never heard yet because it's so new. The biggest problem with DEXA scans is it tells you about the quantity. It's quantitative scan. It tells you the quantity of bone you're dealing with, and you start to lose the quantity, then we become concerned, and you can have osteopenia, which is on the way to osteoporosis, which most everybody has in this room, including me. It's just life. And then you have osteoporosis, right, which is a little bit more bone loss, but that's a quantity thing. We really never had a good test for quality. Like, maybe you're losing bone, but the quality of your bone is still very good. So now some of the newer medical centers are incorporating something called the TBS score. It's a trabecular bone score. They look at your trabecular bone, but that's a fancy way of saying they can tell you, they can give you in that scan, that same scan, they can give you an indication of the quality of your bone, and that's just really taking off in 2025. So if it's me, and I'm going to get a DEXA scan like my wife is going to get one, I said, don't go to that scanning place before you ask them, look, You do DEXA scans? Yeah, I do DEXA. Are you incorporating TBS? Are you doing trabecular bone scores, looking at quality also? That's a software thing. So when they upgrade their software, then you know it's the latest, greatest software for DEXA scanning. So that's the next thing anyone in this room should just ask next time you go to an imaging center. Do you look at quality also, not just the quantity? And the official word for that is a TBS score, trabecular bone score. That, I'll get off my soapbox, would be helpful. The other thing I wanted to talk about was, I brought up metformin to Dr. Heath in the big trial. Are you still using metformin in your practice? The drug that helps control blood sugar that costs a penny a day?
There's a trend towards an anti-cancer effect with metformin. The patients that I would prescribe metformin in are the ones that are overweight.
Yeah.
And if someone's already pretty slender, I'm not typically putting them on metformin. But so many people are carrying a few extra pounds, and it's a very inexpensive and somewhat effective weight loss drug.
It is, you know, and they're studying it for anti-cancer effects. In the big trial I mentioned to her, and I agree with her actually on that. We're not necessarily jumping up and down about anti-cancer, but it's helped controlling some of the side effects. In this huge trial, it helped, you know, reduce some of the weight gain, reduce cholesterol, help control blood sugar at a penny a day. The reason why I think we're not going to be talking about metformin, even though I've been writing about it for 25 years in medical journals, is because I want you to understand what's coming with these new weight loss drugs. These new weight loss drugs that we've been excited about, doesn't mean they don't come with catches. I think the next excitement on the weight loss drugs is the companies have now submitted for a pill version. So now they're injectables, the big ones, like Wegovy, right? So, you know, Zembic, when you talk about Zepbound, all these names, they're injectables. So what would happen if they invented a pill and you still lost 10 or 15% of your body weight? Those trials have just ended. So the first company that just submitted their application and it got approved, the application got approved by the FDA, is semaglutide or semaglutide, which is also known in the circles as Wegovy or Ozempic. So what does that mean in my world is, barring some hiccup, by the end of the year or first quarter, there's going to be a pill you take daily, an Ozempic pill from the same company, same molecule, that's going to give significant weight loss, and it can be controlled at home. And I'm hoping the company steps up and drops the price because it's a pill version, it's not an injectable. Right on the heels of that is Eli Lilly that has tirzepatide, which is Zepbound, which they went head-to-head against Ozempic and were the clear winners in weight loss. Their average weight loss with the injectable is 20% of body weight versus 15% of body weight with the Ozempic-like compound. So why don't they invent a pill? Of course they invented a pill. And it's called orforglipperon. Say that 3 times fast in the bathroom. Orforglipperon is a pill they invented, and they're just submitting now. We just got their phase 3 trial data. I don't work with any of these companies, but I've published medical journal articles on them. And so we're expecting them in 2026 to have a pill, and we'll have 2 pills out by this time of the conference next year, barring no hiccups, which will then, the patients who are coming in your clinic and other places who need to lose weight on ADT and other situations, have this other beautiful possible options to control their weight, which will blow away the weight loss with metformin, right? It will blow, and plus we're studying the anti-cancer effects of those. So just keep in mind, you have 2 pills coming out that work almost as well as the injectables. They should both be out by the conference next year. We'll bring you up to date, barring some hiccups. I'll just give you an early indication of which one has the advantage, if you look at it as an advantage. The Eli Lilly drug has no beverage or food restrictions. You take it, you can eat what you want, you take it daily in the morning, you can eat what you want, drink what you want, that's fine. The Ozempic or Wegovy pill has a food or beverage restriction. Every day that you take it, you have got to wait 30 minutes at least before you eat or drink something. You're allowed to have it with 4 ounces of water, but we wonder if when the public they're going to finally reveal to the public that one of them has no food and beverage restrictions, it might give you the same amount or more weight loss, and the other one has food and beverage restrictions, that people are going to lean toward the one that has no restrictions. But just so you know, when all this comes out, that's going to be the big difference between them. On the heels of all of this, so the largest amount of weight loss we've seen in this trials is 20% of body weight. That's with Zepbound or tirzepatide. Mounjaro, people call it, right? Eli Lilly has another drug now in phase 2, phase 3 that's an injectable. We call it a triple agonist. It's called retatrutide. I know, I can't even believe I know these names. That's why I have no life. So retatrutide, the average weight loss, R-E-T-A-T-R-U-T-I-D-E. Oh my God. All right. Anyway, the average weight loss has been 25% of body weight. We expect no hiccups. That's in the next 2 years, may put to shame the other two. So this is a topic that's not going away. Everybody is worrying about when's the other shoe going to drop? When am I going to grow a sixth toe or something? Like everybody's predicting all this horrible stuff that's going to happen, and those predictions have in general not come true. The only prediction I will tell you is that I'm watching is we don't know about the effect of that kind of weight loss on the eyes. So the only real hubbub going on behind the scenes, especially with diabetics, is could these injectables and pills increase the risk ever so slightly of certain type of eye conditions, whether it's macular degeneration or another one that's really rare, which we won't discuss. And the answer to that is when you're losing that much weight, if you're diabetic or not, a yearly or an annual ophthalmology exam or eye exam is just a smart way to go anyway. So if you want to be ahead of the game and you're on one of these weight loss drugs, it would be a smart idea just to do a yearly vision exam anyway, and then you'll know what's coming, what all the talk is going to be about, so they can look at that. All right, that is my PhD course on that.
Super important to mention that. These are insane breakthrough medications, and in the early years of prostate cancer, when we had few or even very limited treatments, it was obvious that people that embarked upon really careful diets, weight loss, that they had, it retarded the cancer growth. So there's also a place here for people with the serious types of prostate cancer doing better. Dr. Kishan's talk, to summarize it, was a talk about giving beam radiation, SBRT, quickly and comparing it to more traditional IMRT, which would take maybe 6 weeks. And the difference turns out between those two is summarized here. The question is, are the cure rates just as good, and are the side effects equivalent? And that's the bottom line. Yes, the cure rates are just as good and the side effects are equivalent. And therefore, if you're at an experienced center that knows how to give the faster radiation, SBRT, which is 5 visits instead of 25 to 40 visits, it's far more convenient. What's interesting about this, which he didn't really tout, is that there was a trend towards even better cure rates with the SBRT. And this really isn't surprising, because it's been shown that radiation is not only how much you give, but how quickly you give it. And SBRT is given much more quickly than with IMRT. And so if you're giving equivalent amounts but at a faster rate, you would expect to get a bigger dose of radiation into the target and somewhat enhanced cure rates. So it looked like there was a slight trend towards better cure rates with SBRT. He showed some other studies where this trend wasn't observed. But this is where my breaking off point, where I would say, well, if a bigger dose of radiation is going to give better cure rates, what kind of radiation gives the biggest dose of all? And the answer is seed implants. Seed implants, because they don't have to pass the radiation through normal tissue, allows the experts who administer this treatment to really crank the dose perhaps 20 or 25% higher than what can be safely delivered with any type of beam radiation, whether it's proton or IMRT, SBRT, or whatnot. SBRT is an excellent treatment. We use it a lot for treating metastatic sites, as we talked about earlier. It's a type of treatment, SBRT or IMRT, that I would use perhaps in someone who's 80 years old and who needs to get control of a worrisome tumor in their prostate. It's non-invasive and well tolerated. But for younger people who are looking for cure rates, I would probably steer them toward seed implant radiation rather than toward beam radiation, although SBRT certainly performs as well as IMRT, if not maybe slightly better. So that was Dr. Kishan. Any thoughts on radiation?
My only comment on Kishan is as the first time I just wanted to draw him out, and I just wanted to semi-agree with, I just walked him through what's making me wacky lately in the area of radiation, which is We published this article in 2005. We saw what we saw with brachytherapy, that cholesterol lowering might act as a radiosensitizer. His name was on a major paper that now showed, so that paper I showed with his name on there was a major trial of the anti-androgen drugs and the fact that they saw a greater survival rate in men who are on statins than not. It's not proof of concept, it doesn't mean, but what I find so interesting and fascinating about this discussion is if all we do, Mr. Smith, is put you on a statin before your radiation and you continue to be on that, I apologize if it does nothing else for you except lower the #1 cause of death in America for the last 100 years, which is cardiovascular disease. Man, I'm telling you, there's one place I get pissed off in prostate cancer. This would never be allowed in breast and other places. There is a whole world going on in breast cancer right now and the other areas, in HIV medicine. If you go talk to experts in that category, the discussion of putting someone on a cholesterol-lowering medicine at the time during treatment for a variety of reasons, including patients on HIV, because some of these medications they're on, the disease condition itself can increase the risk of a cardiovascular event. And now we've reached a milestone in medicine that we've been, you know this, I knew you 25 years ago, like a statin was a Cadillac. Oh, I'm on a statin, how can you afford that medicine? Now they cost pennies. We got 6 of them, basically all generic. You can get Lipitor generic for pennies. You can get rosuvastatin out there, which works even better than Lipitor, which is known as Crestor. It's now generic. It costs pennies to be on these things. And we're debating, oh, does it improve ADT? It either makes it the same or better. And with radiation, it either makes it the same or better, but I'm not so sure if I can recommend them. It makes no sense to me. It just makes no sense, because in breast cancer, the patient would say, well, what's the downside here? If this is going to help reduce my risk of a cardiac event, which ironically, many of our medicines increase the risk of cardiovascular problems, even though they're incredible drugs. Why in HIV have they moved there? Why in breast cancer have they moved there? Why have they moved there with other types of chemotherapy drugs, which increase the risk of cardiac issues? Everybody's moved there except the place that we should have moved there, which is prostate. The ADT's been around over 35 years. It's been there that long, and we're still one of the only groups not saying, look, just frickin', I'm not using bad language, by the way, I said freaking. I said, just freaking go on a cholesterol-lowering medicine. And if you don't think it's natural, the original cholesterol-lowering medicines came from a fungus, by the way. So just go on a cholesterol-lowering med. Let's get that number. Let's make it extremely heart healthy. And again, I apologize if all I'm doing is reducing your risk of the #1 cause of death in men for 100 years. So I see him inching there. I see him inching there.
One of the reasons Mark is so passionate is there's a long list of retrospective database studies showing better cure rates in men undergoing radiation who take a statin. It's not just one study or 2 studies. There's multiple studies. And the reason it isn't put in the NCCN guidelines is because these are retrospective database reviews, huge insurance studies that show consistently better results, and the only variable is the statin.
And exactly, and so that's why you look at your care holistically. And people buy into this for a variety of reasons. And I accuse too people in the diet world, my world's the diet world too, of sometimes we're making promises we can't promise yet. But if you look at it holistically, you should make a change in diet. So everybody wants to know, well, if I make a change in diet, can that help me reduce my risk of recurrence? The data clearly says that. Well, I don't know if it says that, but it says it could possibly strongly reduce your risk of a cardiovascular event or a cardiovascular side effect potentially from some of these medications. That's reason enough. But we don't want to overpromise just yet. So as long as something's heart healthy and it's cheap and easily accessible, prostate needs to move there immediately. And so that's why this stuff makes me nuts that we haven't moved there, but I'll get off my soapbox.
Exercise helps, right?
Yeah.
And I don't have any further comment on that.
Just a horrible talk. Just clearly pandered to the audience.
Yeah.
Let me tell you, one of the greatest thrills of getting older here and having a little bit of say at PCRI and other places and people listening to you is, boy, it's not easy to bring someone over from Australia. But when you're dealing with the LeBron James of our world, or I don't care who your big hero is, to get him here is so unheard of, with the schedules and everything else. But You know, I went over there 3 times. It was a real honor. I can't do that anymore. It's a long flight. I think I watched 8 movies on that flight. I don't even know anymore. And so he's coming here. He's also going to do some extra work with us. He's coming to my house next year. We're going to do some extra things, and PCRI is going to film it. And we're just going to keep making this a priority. And like I said, he's a gem. You know, I joke with these guys and gals for 30 plus years, having traveled with them. But he's really just a top-notch individual. And so you should start looking at some of his stuff. And I do hope everyone buys this book, because the book is teaching sound knowledge, not just in the area of prostate cancer, but also in women's health. It's extremely important. One of the biggest problems we're dealing with women's health is this idea that not enough women are using a resistance exercise or doing aerobic exercise to reduce the risk of falls, to reduce the risk of fractures, to reduce the risk of muscle loss. And so I just thought it was outstanding, and I'm glad he had a second shot to talk this morning.
Yes, and last but not least, our wonderful Alex, the squeaky wheel wins the appeal, and she put together a website listing all the resources that she reviewed so excellently yesterday evening. So with that.
Well, I have a comment on that. Alex, it was a highly disappointing talk too, overall. It was just, let me tell you, to be all honest, because we were out last night, I never give A+ to students. That gives them too big of a head. It was a straight A. And I'll tell you why it was a straight A. Because not only did she rehearse it all summer like you should rehearse it, but this is a really tough subject to not only tackle, but to admit is a problem. So we got a lot of advocacy out there, but this is staring us in the face constantly. So first we have to admit there's a problem, and this problem's only going to get worse, I'm telling you, knowing all this pre-authorization going on, making doctors nutso. It's going to make you nutso too, and you've got to be able to fight it back. So we're admitting finally that this problem is an epidemic problem. And it's a problem that, believe me, I'm scrutinizing too, as my wife and I move toward Medicare age, and like talking to my colleagues, well, what do I do? Do I really need Advantage? I heard Advantage rejects a lot of people, but Medicare and the cancer, we just go back and forth. So she took this on, did all the homework needed, incredibly objective, and then puts it on a website. But this is the very beginning, because what I see also for Alex is, leadership is great, and she makes things run, but what she has to do now, as we see young people, is like, I want to believe that him and I will be doing this for another 100 years, but that's just not going to happen. Maybe if we get our fiber, we'll be able to do this a little bit longer. But, we're here to be replaced. That's a good teacher. We're here to be replaced. And so it wasn't just a lecture on this topic. It was a commitment to the controversial advocacy moments that we deal with in cancer that someone is going to start tackling. So I told her this has got to be something now every year. You're going to have to tackle a different controversial issue with a path that solves it. And she's like, last night, she's all excited. Yeah, I know, I've got all these. She's just so hyper. I'm just like, I just need my sleep. I'm an old man now. You're 30s. But what you saw here is an inauguration moment, not just her delivery, but her commitment to doing more investigative work and then presenting it to us so we know how to quickly get a solution when we run into problems like this. So she did a great job.
Yay, Alex!
Yeah. Can I say one more thing? I'm in the public health world, which is with the different bent that I bring. And anytime there's something new, like we talked about DEXA scans, what's new is trabecular bone scores. I'll always tell you what's new. What makes me nuts is that we've got COVID picking up again. So when I just came from Alaska, I carried what I always carry with me. Over-the-counter testing market is becoming $1 billion market. And for the most part, I've always advocated for more over-the-counter tests being available to the public. So as of this summer and spring, we now have a 3-in-1 test that everyone should travel with the rest of their lives, unless this goes away, and should have at home. So if you go to Walgreens and CVS today, you can get a FlowFlex Plus, or you can get it on Amazon. It's a 3-in-1. In 15 minutes, you can find out whether or not you have COVID or flu A and B. Think about what our options were my entire life of 60 years. If I want to find out I have influenza, I got to go to urgent care or make an appointment at my doctor's office. Okay, I get an appointment 4 days later. They tell me I have flu. I don't even qualify for flu med at that point because you got to catch it in the first 48 hours. What? This was ripe for an over-the-counter test. One of the greatest successes I saw this year is finally, after 5 years, combining the flu test, it's a nasal test, 15 minutes like the COVID test, putting it in a little container, and it tells you whether or not you have flu or COVID. What's the significance of that? If you find out immediately, you can call your doctor's office and you get medication for flu. And we've got an incredible medication for flu that's new called Xofluza. It's one pill. You don't have to take it for 10 days anymore. It's one pill and you're done. So, but the only way to find out if you qualify for Xofluza, I don't work with any of these companies, is if the test is positive. And you got to find out quickly because it works best within 48 hours. Just like the COVID pills or getting help for COVID work best within the first several days of finding out you have it. So everybody should pick up the 3-in-1 test. It tells you whether or not you have COVID or flu. And then you can, when you find out or not find out, you can then move along and do what you want to do. The second thing is please pay attention to the vaccine space. Don't get caught up in all the vaccine mumbo-jumbo talk right now. People are just yelling from both sides of their face. What I've always tried to tell people is that I'm most excited about the ancillary benefits of some of the vaccines for adults right now. For those of you who don't know it, as of this year, if you're 50 and older, you now qualify for a pneumonia vaccine. So I immediately overnight qualified for a pneumonia vaccine. Hallelujah, it's still a big killer. And in the past, you had to wait till you were 65. So that's a huge change. You can now have insurance cover your pneumonia vaccine if you're 50, 56, 58. That's like Capvaxive. You might see that commercial out there. The other big study is that we've talked in the past about the shingles. The shingles vaccine, Shingrix, it's 2 shots. You get 1 shot, then you can get the next one within 2 to 6 months after that. I don't know people who saw the biggest study this year that was done in the UK and other places suggesting now that the shingles vaccine might reduce the risk of dementia. And people say, how's that possible? And I'm saying it's an ancillary benefit that we're seeing from this immune surveillance. It helps control inflammation. And so by preventing an infection, preventing the shingles, or if you get shingles, the bout's not that bad. See, it's not just that the shingles vaccines prevent shingles. Even if you get shingles, the bout is generally not that bad. It's more calm. That means you get less body inflammation. So I believe this data. There's 2 datas we pushed in the literature that it might be one of our strongest ways to ward off dementia. We need more research there. But we've always believed that it reduces your risk of cardiovascular events. Because when you get a serious infection, flu, shingles, you name it, you get a massive inflammatory response. That inflammatory response can go into the coronary arteries and break off things and cause nasty little events. So these are heart-healthy vaccines overall. Another big study that came out in the past 2 weeks, I'm not ready to jump on, so if anyone ever asks me the question in the future, is now there's a suggestion that when you get some of these infections, and they're very serious, they can awaken dormant cancer cells. So that's the big research. If you go Google this today and say dormant cancer cells and infections, some of the leading people working in vaccines are suggesting that one of the other benefits might be extra immune surveillance so you don't get a serious infection that can't wake it up. I'm not ready to jump on that camp, but I just can't believe I'm sitting here in 2025 and we're seeing already the other ancillary benefits of Shingrix, for example, or the flu shot, or the pneumonia shot, or, there's a variety of other ones. We now have an RSV vaccine, which is incredible because so many people get still hospitalized, and we never had anything for it in adults. And now you have an option, and we know that the shot can last anywhere from 1 to 2 years and maybe even longer. We thought it would only last a year, and that would be it. But it's clearly going on beyond a year, maybe 2 years and longer in people. So I wrote a paper in the medical journals a few years ago, and it said, if you're on active surveillance, or you're anywhere in the prostate cancer spectrum, especially active surveillance, make sure you go back to your primary care doctor and say, hey, am I caught up on all my vaccines? Because we're just seeing all these extra ancillary benefits. They're heart healthy that just don't get enough attention overall. So I just wanted to throw that in here with the plug about the new testing kit and the new medication there.
Yeah, lifetime risk of shingles for all of us that have had chickenpox, which is practically everybody, 1 out of 3. That's the risk. So it can almost be completely eliminated with a vaccine.
And remember HZO. HCO is shingles to the eye. It causes blindness. And the vaccine also reduces HCO. And so the ancillary benefits, again, the fact that we have these, you know, people forget that, remember chicken pox in the younger kids used to be, could run people into the hospital in some bad cases. I mean, some of these ancillary benefits we're getting is quite interesting. The last thing I forgot to mention is creatine and exercise. I asked Dr. Newton, he did a study on creatine, it didn't help in prostate cancer, but he said the study was flawed and he thinks it might help. Let me tell you, there are a few things in life that will never end. It will always happen regardless of how much you intervene. So for example, a patient asking a doctor, if I was your brother, what would you do? Right? Everybody asks, or if I was your sister, you know, people want to personalize it and then they think they're going to get the inside information. And what I always say is, I don't know if you want to ask that question because how do you even know I like my brother? So I might not even give you a... So what I'm saying is that certain things will not go away. Creatine will never go away. Some people will love it, some people will hate it. We're not getting the right message out about creatine. It's cheap, it's great. If you like it, great. But here's what I teach the students. Creatine, the more you take of it, is converted into creatinine. If you've ever looked at your blood labs, your laboratory values, creatinine is a measure of kidney function. The higher the value, the more your doctor's concerned that your kidneys might be having a problem. So if you start creatine, and you take a lot of it, you're going to convert to creatinine, and the next time you go to your doctor's office, you're going to see a jump in that value, and your doctor might freak out. So if you take it, and you take a lot of it, you may be one of those many people that can see a jump in that laboratory value. Do we think that's harmful? We don't necessarily think it's harmful for many people, but it could set off an alarm with your doctor, like, why did this just jump 25%? So just realize that's one of the catches out there, that if you commit to a very high dosage, that your creatinine might jump. We had a resident who took a ton of it, a bunch of it, and his creatinine jumped, and he came to me and said, I said, it's all the creatine you're taking. And so he backed off a little bit, but I think we just need to teach people about the pros and cons of some of these things, but that's one of the issues that you have to keep in mind if you're going to take that. And with that, I think
I'm
we're
told,
good.
Alex, you're going to come give away something.
Oh, we're raffling? All right, let's raffle. Thanks for waiting late, everybody.
Good job, Marcos.
Thank you.
Yeah.
It was such an honor getting to build this conference and put everything together. I would just like to say an incredible, just very big thank you to my team, because they always do such an incredible job. From all of the details to the websites to organizing the in-person conference, we literally spend a year doing this, and so we really appreciate them. I'd also like to say thank you to all the speakers who take the time to fly out, let us film them, work with us, build these slide decks. I mean, it's hours and hours of work. It isn't something where they ever just walk in and give a talk. It is not a simple project like that. They spend a lot of time thinking about how to best communicate these concepts to patients. And even like someone like Dr. Robert Newton, who flew halfway across the world just to be with us, we really appreciate it. These are world-class speakers and the top of their field. They're at the top, and they just do such a good job presenting this information. But I'd also like to thank the man who gets everyone together, Dr. Mark Moyad, because he's done an incredible job not just moderating, but bringing so much information to light. We appreciate his humor and the levity that he brings, because he just helps it make it more palatable. It's a lot of information all at once, as you've seen. And speaking of a lot of information, I want to remind you, you can go back and view this conference at any point. It's going to live here on our PCRI website, but also on our YouTube channel. You can click back. We're going to put it into chapters, and you can go through each section. And there's also a transcript button on the channel itself, and so you can click the transcript button and see in writing what the speaker said. There's also in the settings little gear icon. You can slow it down, You can speed it up. And again, if you have specific questions, I would encourage you to reach out to our helpline at PCRI.org because they're a wealth of information. I'd also like to thank our sponsors, Bayer, Pfizer, Astellas, Janssen, Novartis, Dendreon, Miradex, Blue Earth, Foundation Medicine, and AstraZeneca. They have done a great job supporting us over the years, and we really appreciate them. And then a big thank you to Dr. Mark Scholz for founding PCRI, for filming with us every week. We appreciate everything he does. We thank you so much for watching, for trusting us, for helping us develop more content. Again, leave your questions in the comment section. It just gives us, you guys really are our true north of where we go next, and where your questions lie is where we need to film more content. And that just helps us out so much. So again, leave your comment, give us a thumbs up. Thank you so much for trusting us and supporting us. And please remember, most of all, you are not alone.
Why do we come? Because knowledge is power, and knowledge provides hope.
And this is a place of hope and healing. And that's why I like coming here.
People come to this conference, they're uncertain, and they walk out of here with hope.
This is my 5th time. I learn something every year.
That was my first conference.
This is my 4th.
I think this is my 6th, and I love it. It's part of my treatment plan.
I've come to quite a few of these PCRI conferences and enjoyed all of them.
I've been to probably 9 PCRI conferences. Every one there's something different, so I keep coming every year.
The key is to be able to go and even have direct, individual questions answered with such kindness and such patience by folks that are at the top of their field.
It surprised me how accurate and up-to-date all the physicians are.
And they're very warm, they're open, they're available, and they present scientific information in a way that's very easy to understand and also quite entertaining.
The way they keep it moving and engaging, I mean, this is not a dull conference. This is, I don't want to use the word entertaining, I mean, it is entertaining, but it keeps you focused, keeps you engaged, anxious to hear the next thing.
I would say you have to come here and experience it.
Excellent beyond description what this conference brings to our lives.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.